Hello and warm good morning to all of you. Today is the day 2, that is 20th February 2022 of CardioCon 2022. I am Dr. Mithilesh Kulkarni, Assistant Professor Cardiology of UN Mehta Institute at Ahmedabad. First of all, I would like to thank Dr. Kamal Sharma sir for giving me this wonderful opportunity to speak on this topic. Coming straight forward to the topic is my case is a 55-year-old male with AICD implanted 2 years back has come to us in storm with 12 shocks in last 24 hours. So my talk will be on the approach, the management, including the diagnosis and the treatment of such a patient. So, first of all, I would like to stress on the point that why is it important to discuss such a topic? Because post AICD shocks have got an increased mortality, therefore important to diagnose and treat the precipitant of shocks. Further evaluation will require that if a patient is having AICD shocks, then we need to do the reassessment of heart failure, that whether the device therapy is appropriate or not. Does it require a step up? And is there any increase in the ischemia burden? So basically this chart has been taken from the BRAUNWALD textbook, the latest edition. And we will discuss this differential diagnosis of ICD shocks. So what we'll do is whenever a patient comes to us with a history of post AICD VT storm, first we analyze the data and the clinical data, the AICD data and the clinical data, and we classify them whether it is due to tachyarrhythmia or there is no tachyarrhythmia, that is oversensing. If there is tachyarrhythmia, whether it is due to SVT or that is inappropriate detection, or it is due to VTVF, that is appropriate detection. And again, if it is due to VTVF, then we have to say whether it is a avoidable shock in which the ATP is preferred, and whether it is a necessary shock in which VF or ATP will be unsuccessful. And again, coming if it is not a tachyarrhythmia, that is it is due to oversensing, then it can be due to intracardiac signals or extracardiac signals. So directly coming to the management of AICD shocks, so how to manage a patient who is post AICD and presenting with shocks. We need to, the basic goal is to reduce the number of shocks, which will require the strategic programming, the patient alert and the remote monitoring. And once the shock occurs, we also have to look into the history of the patient, that what were the symptoms at the time of shock. Was he having some sort of palpitations, VT, MI, the radiology for the lead position, or if is there any form of lung pathology like pneumothorax disturbing the I would say the lead placement. And the ICD diagnostic, obviously whether the sensing and the shock was proper or not. So we see that in AICD there are two types of AICD, as we all know, whether it is placed transvenous or subcutaneous. The shocks can be due to oversensing, and T wave oversensing was once a common cause of inappropriate shocks in transvenous ICD, but now they have reduced due to programming options. But in subcutaneous ICD, even today, the most common cause of shock is T wave oversensing. So as we said that in the differential diagnosis of the patient with post AICD shocks, he can have either of the above, like we discussed. Either he can have a tachyarrhythmia or there will be no tachyarrhythmia. And as I said, in tachyarrhythmia, either it can be a SVT or it can be a VTVF. So we'll go stepwise how to manage the each entity of a patient having shocks post AICD insertion. So a patient presenting with SVT, that is supraventricular tachyarrhythmia. So it can be done by reprogramming. We can do the reprogramming of the device using the SVT VT discriminators, and we can also go ahead with the medical line of therapy. So for a patient who is having shocks due to SVT, the drugs which can be used are: first is the beta blocker, second are the anti-arrhythmic drugs, and in some cases we can also go ahead with the EP study and the radio frequency ablation. So, coming to the patient who has presented to us in emergency, we all know that it is a form of medical emergency. We have to determine the cause, we have to treat the cause because this is life threatening. The VTVF detection may be disabled by a programmer or a magnet. So this is important that it is a medical emergency. Rule out the cause, treat the cause, and if not, then we have to disable it by a programmer or by a magnet. So, what can be actual causes of repetitive shocks? Like a patient having ICD and coming to us with repetitive shocks. Either it has to be multiple unsuccessful shocks for a single episode, or it can be due to recurrent VTVF after successful shock termination. So we have to know which of it is. So again, coming to the like multiple shocks for AF or SVT with rapid rates, the treatment will be treatment of the underlying arrhythmia, correction of the device malfunction if there is any, the reprogramming of the detection criteria, the detection and the VT criteria, or the disability of the detection. And I would like to say that we have to hospitalize such patients because we need to monitor them, and we see the parameters of ICD are okay or not. Coming to the next slide, a patient presenting with us with VT storm, like the case which we are discussing, a patient presenting to us with VT storm, as I said, first we have to point out the cause for the precipitating event. The acute event can be in the form of five of the below. First is acute ischemia, patient with post AICD having acute ischemia. Second, it can be exacerbation of heart failure. This exacerbation of heart failure itself can be because of some electrolyte imbalance or some sort of arrhythmia. Next is the metabolic abnormalities. The fourth reason for the fourth cause of precipitating is the drug proarrhythmias, and next is the non-compliance. So if we see that in a patient there is no reversible cause, that is the precipitating event cannot be searched, then we have to start on drug therapy like the beta blockers. We go to, if the patient is not able to revert on beta blockers, then we shift to ablation, and last will be the neuraxial interventions. In this, I would like to also discuss about the unsuccessful ICD shocks. We have to determine a patient coming post AICD shocks. If the ICD shocks are unsuccessful, so what will be the causes of unsuccessful ICD shocks? These can be these can be grouped into three major headings. First heading is a successful termination of VTVF, which is misclassified by the ICD. The VTVF recurs before the device determines the VTVF episode as terminated. Failure to terminate the SVT post block rhythm is SPT. There can also be patient-related factors which lead to ICD shocks, like metabolic, like the hyperkalemia, ischemia, progression of heart failure, some antiarrhythmic drugs like the amiodarone, specifically the type C anti-1C antiarrhythmic class of drugs, some pleural or pericardial effusion, and third heading for unsuccessful ICD shocks will be device system related reasons like the insufficient program shock strength, battery depletion, failure of generator component or lead, device lead connection problem, lead dislodgement, and delayed detection resulting in prolonged VTVF that increases required shock strength. So we have to do a patient coming to us with the VT storm. We have to do the EGM analysis. Whether the shock truly failed to terminate the VTVF or the ICD misclassified effective therapy as ineffective. So we have to analyze whether the shock did not terminate the VTVF or it was misclassified. So shocks in a chronic ICD system may fail to terminate the true VTVF because of the following reasons. There can be patient-related causes, ICD system-related causes like the excessive detection, lead failure, connection failure, out-of-range voltage impedance. In the absence of diagnosis, ultimately the defibrillation testing should be performed. At the end, I would like to present this small flowchart in the form of summary in the way how to treat a patient presenting to us with multiple VT shocks in a patient who has undergone ICD. So a patient coming to us with more than one shock in 24 hours, if he is not having any cardiac symptoms, send the remote transmission, analyze the EGM data, necessary shock was given, then no further action is required. If we found that it was a unnecessary shock, then we'll have to do the troubleshooting. If we find that the patient is having some sort of cardiac symptoms, then we need evaluation, that we send the remote transmission. The patient requires urgent evaluation, consider for emergency medical service admission and hospitalization. After hospitalization, we'll be analyzing the EGM data. After that, if we find that there is some form of avoidable or inappropriate shocks, then we again do the troubleshooting. And if we find that it is if it is necessary shocks, we do the address triggers, we use the drugs including beta blockers, or we go to the EP study, ablation, anesthesia, or ultimately we do the autonomic modulation. Thank you so much. I hope this talk was useful. And again, I would like to thank Dr. Kamal Sharma sir for giving me this wonderful opportunity of presenting my talk. Thank you.
Hello, and to the attendings of CardioCon 2022. It's a pleasure to virtually be here, and it is a huge honor to be invited to give my talk on cardio-oncology to you and your colleagues here in India. My name is Eric Yang. I'm a clinician educator at UCLA, and I direct a UCLA cardio-oncology program. And I want to thank the organizers, in particular Dr. Sharma and Dr. Parvani, for the opportunity to present one of, I believe, to be a growing issue amongst the cancer population, not just within India, but throughout the world, in a case regarding HER2 positive breast cancer and concomitant cardiovascular disease, and how to gauge the unique nuances of cardiotoxicity related to any potential cardiotoxic treatments they may receive. And this will be in the form of a case presentation, and I am excited to hear some of the feedback from the audience. So we shall proceed. Here are my relevant disclosures, none of which are financially relevant to the content of this talk. So the objectives of this case presentation are to do several things. One, to have the audience understand the relevance and importance of recognizing and treating cardiovascular toxicity and disease in the growing cancer population worldwide. And although the field is very rapidly moving and we still have ways to go on really generating robust evidence-based guidelines on the diagnosis and treatment and surveillance of cancer treatment-associated cardiotoxicity. I will review what we have so far in our literature in the past couple of years on how to best serve these patients. And finally, how can we integrate these evidence-based approaches to day-to-day clinical practice, particularly in this example of a breast cancer patient, in being able to effectively treat and risk stratify cancer patients and survivors with pre-existing cardiovascular disease or acquired cardiotoxicity. So my outline will be two major sections. First, this one patient case scenario and an overall commentary of whether knowing the field of cardio-oncology matters. For those of you in the audience who are not familiar with this term, I will go into this multidisciplinary field in more detail. And also from what we know about how to care for these patients with a review of recent society expert consensus statements. So first, let's go straight into the case. So I'm going to give a more conventional history and physical, or assessment, if you will, perhaps coming from someone who is a traditional cardiologist. So we'll call it a non-cardio-oncology assessment, someone that would normally take a history seeing someone with known coronary disease. So we have a 55-year-old female coming to your clinic with a recent diagnosis of left-sided breast cancer requiring chemotherapy and radiation, of which you're not really sure what it is. She herself is not very physically active and walks maybe a couple times a week leisurely or as part of her activities of daily living or to go to the grocery store. She doesn't elicit any symptoms. Her past medical history is certainly significant for a history of myocardial infarction 2 years prior. She had a stent placed in her right coronary artery, and also dyslipidemia and a decade history of type 2 diabetes and hypertension. Her family history is significant for a father who underwent coronary bypass surgery at the age of 65, and her medications, as you can see, are here with aspirin 81, metoprolol tartrate 25 milligrams twice daily, atorvastatin at 10 milligrams daily, metformin twice daily, and a small dose of lisinopril. Her blood pressure, at least in clinic, is mildly suboptimal at 135/82, with a BMI of 29.8, with overall an unremarkable physical exam, normal jugular venous veins, no obvious peripheral edema, clear sounds, heart sounds, and clear lung sounds. Her lipid profile is here below, and I believe I have the right units for the South Asian population here. But her LDL, as you can see, is not particularly optimal in that it is still elevated at 110 on a moderate intensity statin. Her hemoglobin A1C is somewhat near control at 6.8%. What is also notable that her NT-proBNP is elevated at 1600 nanograms per deciliter, and her ECG shows evidence of an old inferior infarction consistent with her history. Films from her angiogram, you could see here a ruptured plaque with the hazy appearance of her mid-right coronary artery here, seen in multiple views, requiring also temporary pacing at the time of her myocardial infarction. And her ejection fraction prior to treatment still showed a long-standing, mildly depressed LV ejection fraction of 46%, a dilated right ventricle with low normal function with inferior and inferior septal hypokinesis. So what I went over is something a cardiologist would ask. But then the question is, what would you do if you actually knew more information or the nuances about the breast cancer? And let's say you were able to get that information and you found out that this poor woman was diagnosed recently with left breast carcinoma, and genetic testing revealed ER positive or PR positive, as well as HER2 positive stage 3 breast cancer. So we can call it a triple positive. And her cancer doctors propose, in an ideal situation, if not for her heart disease, neoadjuvant TCHP, also including the drugs docetaxel, carboplatin, trastuzumab, and pertuzumab, or also known as dual 2 anti-HER2 treatments. In the modern era now, with this kind of early breast cancer, no anthracyclines proposed, but also followed by a radical mastectomy and subsequent radiation treatment to prevent recurrence. So some of these may pose potential short and long-term cardiotoxic risks, but the question is which ones do and which agents should you be worried about? And this, case probably fits the milieu of many of your patients without the cancer. But now there's an additional element of potentially a patient that may have a survivable malignancy, but then her oncologist may potentially hesitate or be reluctant to continue some of these traditional treatments because of her pre-existing cardiovascular history. And then the big questions that come up to both sides of the cancer and cardiology team members of her care might include, the question of which following risk factors predispose her to cardiotoxicity during treatment. Her coronary disease and prior history of myocardial infarction, and the fact that she does have evidence of diastolic dysfunction and elevated filling pressures with her BNP levels and heart failure with mildly reduced ejection fraction. And also, given that her EF is below 50% by echo, is it safe to give her anti-HER2 treatments? Or, do you just give one, or do you continue with both agents nowadays with modern treatment guidelines? And what protects the heart during this? What's known to be effective? And then how do you watch her during treatments? What's the surveillance strategy? What's the long-term surveillance strategy? What's the best way to do it? MUGA, echo, cardiac MRI? And then what's the long-term risk of radiation treatment that she would benefit from on cardiovascular event rates? So switching over to recent society expert consensus statements, and I put this with a big asterisk that a lot of this is still based off of expert opinion because we still lack widespread randomized controlled trial data compared to our interventional and electrophysiology colleagues of thousands and thousands of patients being studied. But before I go on, I do want to review really the fundamental tenets of cardio-oncology, which is a growing field internationally and has growing programs in India and throughout Asia, and also has been very firmly established in the United States. And it really focuses on three major factors of the cancer patient: the interplay of cardiovascular risk factors and disease, the cancer biology and disease itself and how it can affect one's cardiovascular risk profile, and the cancer treatments that occurred in the past if they come to you as a survivor, or what they are going to get. And this intersection of this Venn diagram correlates to the possible effects of treatment-related cardiotoxicity, where if it happens acutely, it can certainly affect access to life-saving drugs. And then chronic toxicity, number two, can certainly affect still quality of life and long-term survival and morbidity. In fact, you will learn that many cancer survivors, the top causes of death are usually cardiovascular disease. And what makes this field so incredibly rewarding, intriguing, and interesting, but daunting, is that in every patient, this combination changes very differently based on the cancer, the stage of cancer, and the type of treatments, and also the pre-existing risk factor profiles that they present with. And why we think cardiotoxicity occurs overall stems from this general theory of what we call the multiple hit hypothesis. And this paper described by Dr. Lee Jones at Sloan Kettering talked about how pre-existing cardiovascular risk factors in general make the likelihood of suffering cardiovascular injury during chemotherapy or cancer treatments makes the overall risk of further exacerbation of cardiovascular disease much higher. In fact, if you get cancer treatments, not only does the treatment themselves cause ongoing potential cardiac injury, but the indirect effects, the fact that you can't exercise as much, your cardiovascular reserve suffers, you can't stay on your medications for your cholesterol, your high blood pressure because of liver dysfunction or renal failure from dehydration or anemia. These are all things that we don't have really good evidence-based guidelines as to whether this is appropriate to continue in cancer patients because these were never studied in the original trials in cardiology. And at least within the United States here, you could see that by the year, currently there are about 3.8 million survivors here, but studies of our population shows that if you are a breast cancer survivor and you have lived more than 10 years, you are more likely to die from cardiovascular disease than you are from recurrent cancer or cancer-related causes. And yet, despite advances in treatments, the incidence of cardiotoxicity in modern trials still remains not insignificantly low. You can see here with some early trials here, ranging from Dr. Cardinale's prospective look at anthracycline cardiotoxicity of EF drops that were significant, as well as the long-term effects of heart failure with adjuvant chemotherapy with or without trastuzumab. The risks of heart failure remain elevated, as well as a modern European cardiotox registry that the likelihood, thankfully, of severe LV dysfunction remains low, but even mild LVEF decreases still were rather common. And the CICSI trial, which also focused on a low-risk Brazilian HER2 negative cohort getting anthracyclines, the incidence of both arms getting beta blockers or placebo remained elevated from 13 to 14%. So going over what are some of the risk factors that make you concerned about potential issues of cardiotoxicity, meaning that this could cause cardiovascular dysfunction during cancer treatments. And you can see that the patient I discussed already has some of these issues already, including her being hypertensive. She may have an abnormal LVF baseline, less than 50%, and pre-existing diabetes. And then some, and I don't have time to go over it all, but many of these agents that have been tested or studied in cardio-oncology trials here, you can see a variety of ACE inhibitors, angiotensin receptor blockers, statins are being tested, as well as certain classes of beta blockers. And essentially, it also points to the fact that neurohormonal agents, although a meta-analysis did not show a clinically significant effect, it certainly warrants aggressive use to prevent the onset of long-term cardiovascular risk. And the best we can do right now is extrapolate what we know from traditional heart failure literature to also do what we can to lower one's risk factor milieu. And although this meta-analysis of 17 trials does suffer, unfortunately, from significant heterogeneity, but there does show a non-significant trend towards lower adverse clinical events, and subsequently further studies are warranted. Now, the other question is that if you already have underlying heart failure, is it safe to undergo trastuzumab or anti-HER2 treatments? And while we still have very small studies showing this, historically it was thought to be forbidden, or you would have your cancer doctor stop treatment. But there are some phase 1 trials, including the SCHOLAR trial, which was published in JACC Cardio-Oncology 2 years ago, looking at a phase 1 prospective single-arm study of 20 patients, all of which of note did receive anthracyclines, but they were eligible if their cardiac function dropped to less than 40% or more than 15% from baseline. And subsequently, they were all put on aggressive goal-directed medical therapy with beta blockers and ACE inhibitors. And they found that 60% of patients were actually able to tolerate both medications. And even the better news is that 90% of patients were able to continue all of their treatments. And nobody died during this study in terms of related to cardiac failure. And essentially, only 10% were not able to complete this. So this was a very promising look to show that if you developed cardiotoxicity during treatments, if you were closely followed and you had very aggressive uptitration of heart failure medications, there was a good likelihood you could continue your life-saving treatment. And the other question of whether you should use 2 agents or 1 agent with anti-HER2, especially if there's concern for underlying cardiovascular dysfunction. So this was a meta-analysis that we performed also with Dr. Daryl Leong at McMaster University's leading this study of a meta-analysis of approximately 8 high-quality randomized controlled trial studies looking at pertuzumab versus placebo. And one of the endpoints we looked at was whether or not pertuzumab had an effect on asymptomatic or minimally symptomatic systolic left ventricular dysfunction. And the overall cohort of approximately about over 4,300 patients, there was no statistically significant signal to suggest that pertuzumab added more harm or more cardiac insult based on multiple randomized controlled trials. And then now turning over to cardiotoxicity surveillance strategies. And this was a paper that was just published in the European Society of Medical Oncology, looking at this algorithm of overall potential cardiotoxic mechanisms and medicines, and how you should risk stratify a patient based on their cardiac function by their LVEF. And in this case, you have a woman who has probably mildly reduced or low normal features. And then the question then becomes, if you can't consider alternative non-cardiotoxic treatments, as anti-HER2 treatment is really the best way for her to ensure her survival, then it's very important to initiate or uptitrate cardioprotective therapy and also continue cancer treatment with close monitoring. No longer is it really the situation where it is forbidden and you can stop. In fact, we should be aggressive, just as the cancer doctors are, in trying to attenuate their cardiovascular risk while they get life-saving cancer treatments. The American Society of Echo a few years back also had an algorithm of how often one should be screening for cardiotoxicity. And while the model they use, the type 1 and type 2 toxicity, I believe is flawed and oversimplistic, it is probably best to substitute type 1 with anthracycline-based regimens and type 2 with anti-HER2-based regimens, not including all the other classes of tyrosine kinase inhibitors, because that has not been studied in the same fashion as anti-HER2 treatments. But briefly going over anthracyclines, which is not applicable to this patient, But it's important to not only get a cardiac LVEF assessment at the beginning of treatment, but also it's very important to get it at the end of treatment and within 6 months, because that is when the ejection fraction, the majority of ejection fractions, if they do decrease or they drop, this is the time to check. And this is very important to do so. Other additional things to improve the quality of your studies or your surveillance include using echo contrast or using 3D technology if you have access to it, global longitudinal strain, and biomarkers such as troponin I prior to treatments. Now, with anti-HER2 treatments, like our patient, it is important to look for ongoing or the development of cardiac dysfunction, although the risk of it happening during, without anthracyclines is very low. It is important to also check ejection fraction every 3 months during treatments. On the long-term treatments are not usually, long-term surveillance is usually not indicated after treatments unless you combine it with anthracycline therapy. And if the ejection fraction or the global longitudinal strain drops below a certain amount in the LVF of 53%, or the global longitudinal strain that was in the lower limit of normal, then it is reasonable to refer to a cardio-oncologist for further care and uptitration of health. Now, moving on to radiation treatments. And this is still used commonly in up to more than 50% of cancer patients, especially in breast cancer, as there is associated with a 50% reduction in disease recurrence and reduction in death. It is also used less so now in Hodgkin's lymphoma, but other hematologic malignancies. In general, nowadays, compared to older techniques, overall decreased radiation doses have occurred due to improvements in more precise CT planning systems and other techniques, but we have yet to know whether or not this truly reduces cardiovascular event rates. We do know historically that breast cancer and Hodgkin's lymphoma radiation survivors are at higher risk for ischemic heart disease and cardiac death. Really, one of the most prominent epidemiologic studies was published in 2013 by Dr. Darby and colleagues, which was a Scandinavian cohort looking at over 2,000 women who underwent radiotherapy for approximately 4 to 5 decades in Sweden and Denmark. And they compared women who had major coronary events and to their controls. And they also derived that anyone who got left-sided radiation, and they also extrapolated this to the radiation doses to the presumed left anterior descending artery. And the overall mean doses to the whole heart was 4.9 grays, which is probably about the same that our woman in question would get. And the rates of major coronary events increased linearly with a mean dose by heart by 7.4% per gray. And this increase started within already the first 5 years after radiotherapy and continued into the third decade. And also, if you included other cardiovascular risk factors, hypertension, disease, age, your risk of cardiovascular event rates would exponentially go up. Thus, really again emphasizing the need for aggressive risk factor modification and aggressive control of risk factors such as diabetes, blood pressure, and lipids. And another thing that I also advise my trainees as well as our colleagues now is that CT imaging, which is done for many cancer patients, it gives you, to a sense, free cardiac data. And this is an example of a CT simulation breast of a woman who had radiation therapy about a decade prior with left-sided breast cancer, which you can see on the CT. But really, as a cardiologist, what I'm really struck by is really the heavy calcification seen here. This does not necessarily warrant invasive treatments, but it does tell you whether or not this patient should likely be on aggressive statin therapy and presumed secondary prevention. But going back to our patient finally, so the question then becomes, what do I recommend as a cardio-oncologist? Well, some of this is based off of opinion and from what we know from the limited evidence. But again, going back to, going from a conservative, sort of prohibitive mentality of saying, oh, you can't get these treatments because you have risk factors or you have cardiac disease, there are risks that exist. But in my opinion, in my mind, and to many of our cardio-oncologists, such things are not necessarily prohibitive. If she is going to die of her breast cancer without adequate treatment, then it is the cardiovascular disease, frankly, is a minimal point of discussion, or really there is not much that needs to be focused on when it's more of an important prerogative to let her get her cancer treatments, even if she does get cardiotoxicity. So it is important to counsel the patients on being aware of potential symptoms of heart failure and also the long-term risks of radiation treatment. Obviously, there is risk that it could exacerbate her cardiac event rate in the future, but if it also provides her a much higher chance of remission, cure, and survival, then it is certainly something that should be considered. What I would do during my time taking care of her would be to change the beta blocker to a more studied drug such as carvedilol, which also may potentially have some afterload blood pressure lowering properties, up-titrate her lisinopril aggressively to get her blood pressure below 130/80, and also change her atorvastatin to a high intensity with a goal LDL of less than 70. Some other things that also I would encourage her to do is that, given if her prognosis is good, is to really focus on activity, physical exercise, and not to just frankly become sedentary and suffer the side effects of her treatment, but to truly restore as much normalcy as possible. We also know that breast cancer survivors also have better prognoses based off their exercise capacity, even after treatments. And even those who are cured of cancer who have poor exercise tolerance fare very poorly in the near future. And in going to the big question of whether TCHP should be done, my answer is yes. And obviously you would need very careful monitoring and doing echocardiography with the highest quality you have available with image modalities that you have available at your institution, including that with contrast or with 3D every 3 months until the end of treatment. The long-term surveillance of this, unfortunately, is unknown with anti-HER2 alone. It is reasonable to perhaps repeat imaging in the future, but usually long-term isolated LV dysfunction with anti-HER2 therapy by itself without anthracyclines is likely unlikely. And only stop if heart failure symptoms develop and or drop with an ejection fraction greater than 10% with careful, high-quality imaging, as I stated before. So in conclusions, the field of cardio-oncology is a dynamic field that is increasingly relevant to a growing cancer population and to survivors worldwide. And really aggressive management of cardiovascular risk factors and prognostically favorable cancers, such as stage 3 and below breast cancer, is key to potentially reduce the risk of cardiotoxicity and the worsening cardiovascular disease. Cardiotoxic but life-saving treatments can be given in high-risk individuals, really with good risk-benefit discussion and careful imaging and monitoring for symptoms and optimization of cardiovascular medications. And finally, concomitant multidisciplinary care of cancer patients with cardio-oncologists can potentially attenuate cardiotoxicity and long-term cardiovascular effects, along with morbidity and mortality. Once again, I'd like to thank the organizers for this opportunity to talk about this case and the field, and I'm happy to discuss afterwards and answer any questions. Thank you.
Thank you, chairpersons, for kind introduction. Thank you, Dr. Kamal Sharma, for giving me an opportunity to talk on a very important topic, the challenges in diabetes care in our country, in India. What I'll be talking in next 20-25 minutes, the different challenges. I don't have any conflict of interest for this particular talk. This is a very interesting slide and very important slide, which was published in Lancet Global Health. And it is talking in 2018, how in 25 years, from 1990 to 2016, the number of people with diabetes in India increased from 26 million to 65 million. And this shows that how diabetes in India is increasing in last 25 years or 30 years. This is a slide of 2019 IDF Atlas, which is talking that we will be projected maybe in 2013, 2045, we will be having a lot of people with diabetes, around 100 million, 134 million. But whatever the projection which was done or prediction which was done by IDF or WHO, actually India got those numbers before 5 years. So whatever the number which is predicted in 2030, we may have 100 million, but we don't know in 2025 this number we may have. We have other major problem that 50% of our patients are actually not diagnosed with diabetes. Our national prevalence is 8.9 and 1 million people are dying because of diabetes. So that's a sad story about diabetes in our country. If you see 2021, the data shows in IDF that again, increase in our country, it will be like 68%. So I mean, in Southeast Asia, the number of people from last IDF Atlas to this IDF Atlas, and probably in 2045, it will increase by 68%. As I already told you, 50% of them are not knowing the diabetes. But if you see all over the world, 4 in 5 adults with diabetes, they live in low and middle income countries. So actually diabetes is a major problem of the countries which are developing countries or low-income countries. So India, China, they are the major problem in our country compared to the Western world like America or Europe. So the problems which are associated with diabetes care in our country is one is huge burden of diabetes and its complication. We have several issues of diabetes care, which includes socioeconomic factors and medical infrastructure. We don't have appropriate monitoring, so follow-up of patient is very much poor. Access to healthcare is poor in several parts of our country, and the financial burden of diabetes, both on the patient and national economy, is very, very high. There is a non-adherence to recommended guidelines, and that results in an inappropriate care. There are some distinctive features of type 2 diabetes in our country. There are genetic predisposed, as we are more having high waist circumference, still we have low BMI. The waist hip ratio is more, high visceral fat, we are highly insulin resistant, and high prevalence of atherogenic dyslipidemia with early beta cell defect. There are environmental factors like economic prosperity is increasing, but because of economic prosperity, there is a faster urbanization, decreased physical activity, and nutrition abundance is high intake of refined cereal and low intake of dietary fiber, fruit, and vegetables. This all leads high incidence of diabetes, which is occurring in young age. We are getting diabetes at a lower BMI. We are getting more complication. Heart disease is more prevalent, low prevalence of peripheral vascular disease, but more of coronary artery disease, and very high incidence of even microvascular disease also. But even after these so many problems in our country, the biggest problem is that there is a low awareness level, and this increases the management issue. High prevalence of undiagnosed patients, unaffordability of care, unavailability of trained medical and paramedical personnel. And these all are important issues which we have in our country. So in spite of higher prevalence, we have very low awareness in our country. 40% of our patients are unaware that diabetes can cause neuropathy. But I just want to give one very important example that 53% they believe that eating Kerala or methi can cure diabetes, which is not true. So I mean, people just eating the Kerala and they feel that diabetes can be cured. And this is what I'm seeing even in the urban areas. Staying in the Gujarat or in Ahmedabad also, we are seeing that a lot of patients feel that just by taking something Kadvo Kadiyat or eating Kerala, it may cure the diabetes. And this type of awareness is in our country. And that's a major challenge in our country. Now, I just wanted to give you the 2-3 slides, which is talking that how many people in India are actually having good glycemic control. So forget about those who are not diagnosed. Those who are diagnosed, 80% of them are not having a good control of diabetes. Only 19.7% were found to have a good control. And this is a Mohan paper which was published in 2007. Now let me talk about one more paper from Unni Krishnan. It is in 2014. Again, this paper is being taken by ICMR in diabetes study, which is the principal investigator was Dr. Mohan. And in that study, had also shown that 70% of our patient HbA1c is remaining more than 7. So I had shown you the paper of 8. I had shown you the paper of 2014. Again, you see the third paper, which is again from the Ramchandran and group, and they are talking in 2020. The status is same. Still, the number of patients who are achieving good glycemic control is only 22.5%. So what it means, the 3 paper which I had shown from 18, 8, 14, and in 2020, even with so many newer molecules had come, so many new combination of drugs, so many CM in educational program which we have done, still at the level of glycemic control, the patients are not getting good control. 80% or 75% of them are not achieving the tight glycemic control. We are having one of the country who is with the rule of half, that half of our patients are not diagnosed. Half of them who are diagnosed, they don't receive the care. Those who are receiving care, they don't achieve the target control. Those who are achieving the target, still they are not having the desired outcome. And I will put here, not the desired outcome, rather than half of them will not able to get even the control of all 3 aspects of the diabetes control, with A1C, blood pressure, cholesterol, along with obesity control, diet, exercise, compliance, and smoking cessation. So if I put all these things, probably out of all 100 patients, maybe 2 or 3% of the patients, we may have a desired outcome for our patient. So this high burden of diabetes, but high burden of complication also. At any given point of time, and this is paper again from Ranjit, it talks that even in the clinic, we can see that a lot of patients who are coming to our clinic, not just having diabetes, but they have a lot of diabetic patients, they come with a complication. So a huge burden of diabetes complication. This is very nicely written by Dr. Anup Mishra in a Lancet, that what are the challenges? There is a low educational status, poor awareness, delay in seeking treatment, poor access and adherence to medication, socio-economic and socio-cultural changes, which are contributing inequities in prevention and management, coexistence of communicable diseases like tuberculosis, HIV, and now like COVID, heterogeneous dietary behavior for community and religious practice, gestational diabetes is very high, adoption of alternate system of medication, diabetic peripheral neuropathy is otherwise also high, and again practicing of walking barefoot in a religious places, which increases the risk of diabetic foot, and access to trained physician and educator is really inadequate. So if I just put all these are challenges which are there in our country and how we can improve. One is probably early diagnosis. So delaying diagnosis itself increases the risk of complication. Early provision of basic treatment, and that treatment should be available across the country, even at the rural area also. We have to upgrade the skills of physician, and that is what we are doing in last 2.5 years or 2 years. Because of this COVID situation, one big advantage is that now we are reaching to the rural physicians. We are reaching to thousands of the doctors across the country, and we can train them online. It is more cost effective because nobody is wasting their time. The money is also very much less, and then still we can upgrade the skills of physician. And we have to find out some specific solutions which are affordable. And probably this is one of the solutions, a teleconsultation, and online education itself. Regularly updating National Diabetes Management Guideline, which also we have started in last 2 years. And with the support of USV, RSSDI, nationally we are promoting our guideline, RSSDI guideline, Indian guidelines to each and every district. We have identified 745 districts with the district coordinator, and they are regularly, we are updating about all national diabetes management guidelines too. So early diagnosis is a need of our, it's a timely diagnosis, early and aggressive management will definitely delay the complication. And we know that this is going to give us the legacy effect. And this we know from UKPDS data. If you can achieve a tighter glycemic control, probably for long term, you are going to have less and less complication. But at the same time, we must know, and for all those clinicians who are here, they should know that bad glycemic legacy also increases the risk of complication. So if somebody could not have early glycemic control, this bad glycemic legacy will also continue throughout the lifetime, and patient will have more and more complications throughout the lifetime. That's also very important. So early aggressive control is very important. If we can't control early, then to undo bad legacy is very, very difficult. So those diabetologists, we all know that once the patient comes to us, it's already 10, 15 years of uncontrolled diabetes. Now we can't do much. Even we do best of the best treatment, we can't undo the bad legacy. Whatever the patient had a complication or the chances of getting complication, probably patient may have it. And if we want to have a good legacy, then early and aggressive management is must, and that is done by primary care physician, not by diabetologist. So where we are, we should get early diagnosis. This is what we are trying. We should improve the access to diabetes care. That is what constantly we are trying from the organization. We should have an aggressive management for tight glycemic control, and that is what we could learn more in last 20 years with a newer agents, screening of the complication. That's very, very important. Glucocentric approach, now we changed to the complication preventive approach in last 5 years after we know the data of these newer drugs that they can prevent the complication, and we had become more precise in treating diabetes. That is with the advantage of continuous glucose monitoring, and we are also trying that how we can prevent the diabetes, particularly for high-risk population, by increasing the awareness. And this is all what we are doing through Diabetes India, by RSSGI, and by multiple organizations across the country. But can we change the natural history of type 2 diabetes? If somebody is talking that if we get the diabetes, can we reverse it? If somebody at the high risk of diabetes, can we prevent it? And can we primordially prevent the diabetes itself? Because that is what otherwise we will continue to increase the diabetes in our country. Yes, we can do it. Let me start this story with the 2004 paper from Lancet, where Dr. Yagnik had talked that we are Indians are thin fat Indians. We get diabetes even with less fat. We get diabetes at an early age. We get diabetes at a lesser BMI. Why? Because we have higher insulin resistance. We have more fat, and we are thin fat Indians. We have more fat and muscle mass is less, while the European phenotype is more muscle mass and less fat. This is we know from 2004. So, I mean, this is a paper which is published long back. And even in his YY paradox also, he talked that even his BMI and his Professor Yudkin BMI was same, but still the fat percentage in Dr. Yagnik was more in compared to Europe. Now, if you see this data, this paper, that globally, we are the one who get maximum low birth weight child, even more than Africa and some other countries like South America and some other countries like in Syria and all these countries. So we Indian subcontinent, which includes India, Pakistan, Bangladesh, Sri Lanka, and these 4 or 5 countries, we get maximum low birth weight child in the world. And at the same time, if you see diabetes point of view, we get more diabetes also. So we are capital of the two. One side we have undernutrition, other side we have higher incidence of diabetes, and this means this dogma is mean that we are having more of a undernutrition, more of a low birth weight child, and still we get more diabetes. So there is a connection between that. And this is the connection that we get a small, thin, fat Indian baby. Again, Yagnik had produced this paper in 2002, which is talking that we are small size, more fat, less muscles, less viscera, high insulin, high leptin, and low adiponectin even at the time of birth of a child. And that body composition is we have in compared to Western population. Even our Indian baby is born with 2.7 kg. The fat percentage is more than 20-25%, while a Western baby is around 3.2 with a fat percentage of less than 15 or 20%. So this is what from birth only we are getting high insulin resistance. And this Indian scenario, again, what happens? The child in early nutrition age, I mean in early childhood only, we just try to feed the child, increasing his adiposity. Instead of, we are not working on increasing his lean body mass, increasing his length. So in early childhood, in early pediatric age group or early adolescence group, we should work more on increasing lean muscle mass or increasing the length of a child or young adult rather than increasing their weight. If we increase their weight, even by few kg, it is going to increase their more adiposity, which is going to increase the risk of metabolic syndrome, increasing the risk of diabetes risk. While if we increase the lean muscle mass and length, probably we are going to decrease the diabetes risk throughout the lifetime. So this is what we have to work. We have to start working from these young children or these young adolescents, that how we can increase their lean muscle mass and length of the body rather than weight of the body. If the epidemic of diabetes in India is disease due to low birth weight child, we all know that this low birth weight child, more insulin resistant. Again, this become most postnatal undernutrition, and this is going to become a undernourished, a small mother. And this small mother is going to have a child. If she is more nutrition is given, they are going to have a macrosomia. Again, obesity. Again, there is a fetal adiposity and islet dysfunction. So both the side, if the child is not developed properly, an undernourished mother, or if you make the obese mother, both are going to get the child which is of low birth weight. Or we may get a birth weight which may be higher, but it is because of GDM. So if the epidemic of diabetes in India is a disease due to low birth weight, undernutrition, or even overnutrition, that occurred within a generation, is last 30 years, if you see, or 15 years, 20 years, or 30 years, or 35 years, we will find in last 2 or 3 generations, suddenly this increase in diabetes incidence or metabolic syndrome. There is no reason why it should not be reversed. If we just change complete cycle, probably we can reverse on a similar time scale. So this is what we proposed, that after 2030, any child born after 2030, he should not see those diabetogenic risk factor in his lifetime. So we have to start work now for the young children, for young girls who are going to become mother maybe after 10 years, maybe the 12 years old girl or 10 years old girl or 14-year-old girl. We have to counsel them now to eat healthy, to become more physically active, and that will increase in their mass muscles. We have to make healthy mother with increased muscle mass, and they are going to deliver a healthy child if provided with proper food and nutrition. We are going to have a healthy kids, healthy young adults, and they should go in a school where we want to create them more healthy, and healthy school children, healthy young adults, and then probably we can think of a disease-free adults. And that is what our mission from Diabetes Care in India, from making it our country diabetes-free India by 2030, those who are born after 2030. It does not mean that we may not have diabetes after 2030. We wish we have a vision that those who are born after 2030, we should not get those diabetogenic risk factor in their lifetime, so they develop diabetes in their early young age. With this, I thank. Once again, I conclude by saying that we believe we are at a time when we can change the natural history of type 2 diabetes, and doing so should benefit the health of millions of patients and will benefit healthcare system by reducing resource use and cost. With this, I thank once again. Thank you, Kamal, for giving me this opportunity. Thank you.
See, today we are going to talk on blurring lines between metabolic disorders with cardiology, and fundamentally cardiometabolic cardiovascular disorders, the old wine in new bottle. So fundamentally, it is nothing but cardiometabolic based chronic disease and metabolic flexibility, and how the modern cardiodiabetology are married to each other, and it is nothing but this common soil hypothesis. So first we will define the burden, then we look at the critical and crucial link between glucose control and cardiovascular risk. Then we look at non-glycemic factors and cardiovascular risk. Then we will combine the two, or the cardiometabolic chronic disease model with meta-inflexibility, connecting the dot. And then we look at newer treatment strategies and newer research to reduce cardiometabolic risk and cardiovascular risk. So when we define the burden of cardiometabolic based chronic disease, we know that cardiovascular disease is a very significant global burden, whether it is heart attack or stroke. And we all know that it is killing Indians in a very, very big way. And we all know that the clock starts ticking at birth. We know whether it is coronary artery disease. By the time overt coronary artery disease develops and diabetes develops, the clock often starts ticking in the first and second decade of somebody's life. So Professor Jeffrey Mechanic, my good friend from Mount Sinai, who is in Professor Valentine Fuster's group in the cardiometabolic program at Mount Sinai. So here you have an endocrinologist working with the leading cardiologists. The cardiometabolic based chronic disease and its metabolic drivers. We know that we need to have a population based strategy which warrants an early and sustained interventions which can control the metabolic drivers, including functional adiposity, dysglycemia, and hypertension. That's really the key. So what is cardiometabolic based chronic disease? Is nothing but ABCD and DBCD. ABCD means the adiposity based chronic disease, which has two parts: adiposity based reflection of mass function of adipose tissue, and chronic disease which reflects risk, presence, and severity of complications. DBCD reflects dysglycemia based chronic disease. It's an overarching term including all forms of diabetes, type 2, pre-diabetes, and insulin resistance associated with the risk of disease progression. And when you combine ABCD, adiposity based chronic disease, and DBCD, dysglycemia based chronic disease, you get a cardiometabolic based model of chronic disease, which is a medically actionable model which addresses the underlying pathophysiology and the interrelationships and intersections between obesity, type 2 diabetes, and cardiovascular disease. That's the overarching thing. And it outlines a comprehensive approach for primary, primordial, secondary, and tertiary prevention of cardiovascular disease as an end stage development of a chronic disease process. And that is where the lines between metabolism and heart get blurred, and we have nothing but old wine in new bottle, as illustrated here. So clearly we know that there are different stages of these models: stage 1, stage 2, stage 3, and stage 4. The at-risk model has genome, environment, and behavior in the ABCD component. The DBCD component has beta cell dysfunction and insulin resistance. And CMBCD model has dyslipidemia, metabolic syndrome traits, and hypertension. In the pre-disease state, it's all about abnormal distribution and kinetics of overweight and abnormal function of adipocytes. And then in the disease state, it's all about obesity, anthropometric, oxological, and biochemical thresholds, ultimately leading to the cardiometabolic and biomechanical complications of obesity, the macro and microvascular diseases of diabetes, and of course, then unveils the whole symptomatic coronary artery disease, heart failure, atrial fibrillation from asymptomatic heart disease. So clearly we know that the CMBCD or the cardiometabolic based chronic disease is a reflection of beta cell defect and insulin resistance, which is contributed tremendously by glucose and lipotoxicity. Now, does glucose control matter in this process? We have excellent data with these elegant trials published more than a decade back of UKPDS, 3 decades, Accord, Advance, that microvascular complications with good glycemic control comes down. No impact on cardiovascular disease, and actually mortality, again, no impact. Clearly, in long-term follow-up, however, with UKPDS, we found mortality came down. And if you do try glycemic control very tight, very late, then in Accord, we saw increase in mortality. Are there non-glycemic factors in cardiovascular risk? Yes. Despite of decades of improvements in type 2 diabetes, people are still not reaching to the goal, whether it is the blood pressure goal, the A1C goal, or the LDL goal. And we know that 82% don't achieve the A1C, blood pressure, or the cholesterol goal. And that's really something which we are worried about. The Look-Ahead trial showed us very clearly that if you aggressively do intensive lifestyle with weight loss, it did not improve the cardiovascular risk in type 2 diabetes in long terms. And weight loss, of course, happened very, very aggressively. But we know that the non-HDL cholesterol is a better marker for cardiovascular risk in addition to LDL cholesterol. And we know that it is the mitochondria which is the root cause of all the problems in the thin fat type 2 diabetes, cardiometabolic disease-based chronic renal. So insulin resistance leads to mitochondrial dysfunction, which leads to endothelial dysfunction, cardiac steatosis, and hyperglycemia. So it is the metabolic inflexibility and the ability of the mitochondrial capacity to switch between oxidative fuels, depending on the nutritional context, is lost either in obesity or type 2 diabetes. And that triggers this inflexibility in the mitochondria, is where the marriage, the mitochondria is the place where the diabetes marries heart disease. And that switch, ability of the mitochondria to switch between fuels when there is obesity or type 2 diabetes leads to heart disease. And that's really the key. So when there is mitochondrial dysfunction, it interferes with oxidation of acetyl-alkyl-CoA. It accumulates the intracellular lipids and diacylglycerols. It activates the serine kinase. It interferes with the insulin receptor signaling, and the GLUT4 translocation is interrupted. And this metabolic inflexibility, this mitochondrial dysfunction leads to citrate excess and beta oxidation, insulin resistance and endothelial dysfunction, ATP depletion, which leads to a trio of dysglycemia, dyslipidemia, and hypertension, which kills through coronary artery disease. And we have very good epigenomic data, which has been seen in different studies, including Indian studies on insulin resistance, clearly showing that mitochondrial dysfunction induces these challenges on the DNA methylation and insulin sensitivity, particularly in the overweight subjects. And we clearly know that this can impact in a huge way. And there is an unmet need for an ideal drug, which will correct both chronic-based metabolic diseases and metabolic inflexibility. So that's something which we recognize. We have metformin and prednisones which correct insulin resistance, but we have no drug which can correct the respiratory chain transporters on the mitochondria-related glucotoxicity or the impaired insulin signaling. And that's an unmet need which we need to correct. And that's something which we need to do. So obviously, when we are connecting the loop from flexibility to inflexibility, from rapid power efficiency to glucose sparing efficiency and rapid energy abundant glucose, we need metabolic modulators. So obviously, we now know that making a point of the blurring of cardiology and diabetology, the cardiometabolic based chronic disease is here to stay. It's an early, sustained, evidence-based, comprehensive, integrated approach to target metabolic disorders involving subclinical adiposity and dysglycemia or type 2 diabetes. If you do multiple risk factor interventions, early, hit hard, hit early, it can delay or halt the progression of cardiovascular disease. But there will still be something which will delay or defer the residual risk. We know there are Indian clusters which significantly impact the cardiometabolic based chronic disease or type 2 diabetes. And they are mitochondrial or metabolic modulators. We are getting and emerging newer and newer therapies targeting energy kinetics or mitochondrial health, which may correct glucose and heart both simultaneously. Thank you for a patient hearing, for opportunity for this unique topic.
Good evening, doctors. And it's my proud privilege to be a part of the CardioCon 2022. And I will be sharing my slides and I will be talking about my topic today. My topic today is emerging therapies in lipid management. And I'm very thankful to the team CardioCon 2022 for giving me this opportunity to talk about the emerging therapies. Now, why are emerging therapies important in dyslipidemia? Why is there a need for new therapies? Studies have shown benefits with statins in both primary and secondary prevention of atherosclerotic cardiovascular disease. There has been a relative risk reduction of 25 to 40%. However, many individuals continue to have ASCVD events despite statins and despite optimal level of LDL. Therefore, we need newer emerging therapies to reduce LDL further, to reduce apolipoprotein B containing lipoproteins, to reduce LP little a or lipoprotein little a, which has emerged as a very important risk factor for ASCVD, both primary and for secondary ASCVD. Now, also to reduce events in patients with high triglycerides and to target inflammation to reduce ASCVD risks. So today I'll be talking about some of the currently available as well as the investigational non-statin medications for dyslipidemia or hypercholesterolemia. I'll be talking about the cholesterol absorbing inhibitor ezetimibe. I will be talking about the PCSK9 inhibitors. I will also talk about bempedoic acid, and I will be talking a little bit about inclisiran. So basically, what are RNA and gene therapies? This is very interesting. Patients with untreated lipid disorders carry a very severe risk of cardiovascular disease. To achieve better treatment outcomes, novel selective gene expression and epigenetic targeting therapies are being developed. And in my subsequent slides, I will be talking about such therapeutic innovations which are employing targeted RNA technology. So let me tell you that these are the drugs I'll be talking about. So coming to ezetimibe, there has been a very interesting trial on ezetimibe called IMPROVE-IT. What was done in the trial is that patients who had an acute coronary syndrome, within 10 days of the ACS, they were classified, they were divided into two groups, the conventional group and the interventional group. The standard treatment where simvastatin 40 milligrams was given, irrespective of the LDL numbers, which could be between 50 to 125 milligram%. And in the other group, which was the interventional group, we gave ezetimibe plus simvastatin. So two groups, one receiving simvastatin alone and the other simvastatin plus ezetimibe. And after follow-up, and the duration of follow-up was for about 2.5 years, it was found that the primary endpoint of cardiovascular death, myocardial infarction, stroke, heart failure, hospital administration for unstable angina, as well as coronary revascularization were all less in the group receiving both simvastatin and ezetimibe. Again, benefit of adding ezetimibe to statin therapy on cardiovascular outcomes was more in patients with diabetes in the IMPROVE-IT trial as compared to the non-diabetics. So the diabetics benefited more with greater reduction of events as compared to non-diabetics. Probably the reason being that absorption of cholesterol from the diet is more in diabetics as compared to the non-diabetics, and therefore ezetimibe may be more effective in patients who are diabetic. Over and above statin, they may help to reduce cardiovascular risk. Now, coming to the role of PCSK9 inhibitors, doctors, we have been using this in our hospital, Gangaram. I have been a part of the trial. Now, very simply explained, there are LDL receptors on the hepatocytes. The circulatory low density lipoproteins, it attaches itself to the LDL receptor on the hepatocyte. This LDL receptor complex, this is actually now PCSK9 attaches to it, right? So what is basically PCSK9? It is also known as pre-protein convertase subtilisin kexin type 9. The entire complex of PCSK9, LDL and LDL receptor is then internalized by the hepatocyte. After internalization, it is destroyed by the lysosomes, and now the LDL receptor is destroyed. But if we could somehow block the PCSK9, then the PCSK9 LDL receptor complex will not be internalized and destroyed, and more number of LDL receptors will be available to come back to the surface of the cell, that is the hepatocyte, and carry more LDL inside. So this is a very interesting group of drug because PCSK9 blockers are basically monoclonal antibodies, and we are using 2 of them. I will subsequently in the slides show you the trials of the 2 of them. Now, this is very, very interesting that once the LDL receptor number increases, more LDL receptors are available to catch the LDL from the circulation and bring the LDL inside, where of course the low density lipoproteins are then metabolized into fatty acids. So this was the trial with evolocumab, the clinical efficacy, effect on other lipid parameters compared to placebo. So see, statins may not decrease consistently other proatherogenic lipid parameters, and they may not increase the HDL as much as evolocumab. So evolocumab decreases apolipoprotein B, it decreases LP little a, it also decreases VLDL cholesterol by 30%, and it may increase the good cholesterol or high density lipoprotein cholesterol by 5 to 9%. Now, these were the 2 trials. The Odyssey trial, it was in 57 countries. And again, in the Odyssey trial, it was found that when you use the evolocumab, there was a reduction in LDL to even lower levels that you could achieve with statins alone. So here you can see that on patients on treatment with the PCSK9 inhibitor, this drug, there was a reduction in all-cause death, further reduction in even the primary endpoints was seen, which is non-fatal MI, non-fatal stroke, and hospitalization for unstable angina or requirement of angioplasty. Now, again, there's another trial called the Fourier trial. In this, further cardiovascular outcome research with PCSK9 inhibitors in subjects with an elevated risk. Huge number of patients was screened, and then they were given evolocumab subcutaneously versus the other group which received only placebo. And again, it was found that there was a reduction in the primary endpoint as well as the key secondary endpoints, with a 59% mean reduction in HDL in LDL as compared to statins group, which means a placebo group which had only statins. So again, safety wise, very safe drug. CV death, MI, stroke at the end of LDL, and the LDL cholesterol levels at the end of 1 month. You can see months after randomization that there is a reduction. Now, so PCSK9 inhibitors are now in a big way. We are using them not only in patients of atherosclerotic cardiovascular disease to avoid a secondary event, we are also using in patients of familial hypercholesterolemia. We have been using it in patients of heterozygous severe familial hypercholesterolemia. I have used it in Gangaram. So in these patients, more than 50% of the LDL receptors are absent. So they're less in number. So if the LDL receptors are less, obviously less LDL can be taken from the circulation and internalized. So by using PCSK9 inhibitors, we can block the PCSK9 so that the LDL receptor complex is not destroyed and more LDL receptors are available to bring the LDL inside. Now there is another oral antilipidemic drug called bempedoic acid. Again, this is oral. Again, it is a non-statin drug. And what is the mechanism of action of bempedoic acid? So this is very interesting that bempedoic acid does not act where HMG-CoA acts. It acts at a higher level. So what bempedoic acid is available as a prodrug, then it by the enzyme ACSVL1, it is converted to active bempedoic acid, the drug itself. The advantage is that ACSVL1 is only present in the liver and it is not present in the skeletal muscle. So bempedoic acid does not cause many side effects on the muscle. So it causes lesser side effects on the muscle as compared to the statin. Now, how does bempedoic acid work? It blocks cholesterol, this biosynthesis in the liver. It inhibits ACL. So this ACL is adenosine triphosphate citrate lyase. This enzyme is upstream from HMG-CoA. You can see it. It is upstream from HMG-CoA. And therefore, what happens? There is also LDL receptor upgradation, more LDL receptors. And again, the same thing, more LDL receptors means more LDL is trapped. More LDL is trapped inside the hepatocytes. Therefore, the plasma LDL cholesterol decreases more. So this is an oral non-statin drug, which is still experimental and we have not used it yet. Now, this is the efficacy of bempedoic acid, pooled analysis of 4 phase 3 trials. And there's also a combination of bempedoic acid and ezetimibe, which is available. And so if you summarize, it inhibits ATP citrate lyase, inhibits hepatic cholesterol synthesis upstream of statins. It decreases LDL-C, then 25% in statin naive patient. And if you give it to a patient who's already on statin, there is an additional 18% reduction in the LDL levels, right? So well tolerated in individuals with statin intolerance. This is the biggest advantage because it does not cause any myalgias and therefore, but it can be used in patients who cannot tolerate statins because of severe myalgia or myositis. Then small increase of uric acid, but there's a signal for improved glucose tolerance. And it may also decrease HSCRP. So it also has, bempedoic acid also has an anti-inflammatory effect. And now we know that ASCVD may be related to inflammation. Now coming to another new class of drugs known as inclisiran, again, very interesting drug because here what we were talking about, the targeting the RNA, right? So this is targeting the, what we do is basically, inclisiran is a small and it is small and it is interfering double-stranded RNA. And what does it do? It silences the messenger RNA in the hepatocytes and prevents translation of PCSK9. So again, PCSK9 is not translated and therefore PCSK9 cannot, block the LDL receptor complex, which is destroyed by the lysosomes. So because of non-translation of PCSK9, there will be inhibition of production of PCSK9. And therefore, this drug is again a very powerful drug to lower LDL over and above the reduction seen with statins. And it also lowers Lp(a). There were 2 trials on inclisiran, the one in America called the Orion 1 and one in Europe called the Orion 2. To summarize the trial, the inclisiran is given twice a year as an injectable therapy. It lowered LDL-C by greater than 50% very safely from baseline. So Orion 2 met all its primary and secondary endpoints. It reduced the primary LDL-C endpoint by 54% at 17 months and 50% time averaged. Inclisiran resulted in potent and a consistent PCSK9 knockdown. And inclisiran achieved durable and potent LDL-C reduction with only 2 yearly injections. So you just have to give 2 injections. Of course, they're very costly. There are not many side effects. Safety profile similar to placebo. And of course, there have been some injection site events. There can be some itching and some reaction. All right. So this is, then I'd like to talk about the reduce IT trial. So we come now from inclisiran, now we come to omega-3 fatty acids. So we know there are 2 omega-3 fatty acids, epoxypentoic acid and docosahexaenoic acid. Now, omega-3 fatty acids decrease triglycerides and VLDL, but the effects are seen with high doses, greater to 2 to up to 4 grams per day. So this was the trial known as reduce IT. This trial evaluated the use of icosapent ethyl. So IPE is a highly purified EPA, either in patients with established ASCVD or patients with type 2 diabetes with one or more ASCVD risk factors who had persistent hypertriglyceridemia in spite of giving them maximally tolerated dose of statin. So these were patients who were identified. They were given maximally tolerated dose of statins. They had good LDL levels, but they had very high triglycerides in the range of 135 to 499. So this trial was carried out for a period of 5 years, and it was found that when you gave IPE or icosapent ethyl to patients, there was a reduction in pre-specified ASCVD endpoints, both fatal, non-fatal MI by 31%, fatal and non-fatal stroke by 38%, cardiovascular mortality by 20%, and in reduced IT, the net triglyceride was reduced by 15%. So we do have these omega-3 fatty acids, which can be used, of course, in a dose of 2 to 4 grams. Now, this is the algorithm to manage hypertriglyceridemia. We have to remember that main target is LDL. Then you calculate the non-HDL. You assess the ASCVD risk. Lifestyle intervention is important. A low-fat diet, avoid refined carbs, more complex carbs, weight reduction, exercise, less alcohol, no smoking. All these, of course, we have to control type 2 diabetes. But if the cholesterol is more than 500, and there is an increased risk of both pancreatitis and ASCVD, then we can give a very low fat diet, weight reduction, all that. Along with that, you could give either fenofibrate, or now after the reduced IT trial, you can give omega-3 fatty acids. And of course, in our country, we do give saroglitazar, and I'll be talking briefly about it. So this is another new drug called pemafibrate. It is a novel selective PPAR alpha modulator with higher potency and selectivity for PPAR activation, PPAR alpha activation than even fenofibrate. Now, the available preclinical and clinical data suggests that this new drug, due to its favorable benefit-risk balance, is more effective than the conventional PPAR alpha agonist. Now, the drug that we are using, saroglitazar, is a dual agonist of both PPAR alpha, thereby taking care of hypertriglyceridemia, and it's also a gamma agonist, thereby taking care of some amount of blood sugar. Fibrates are, of course, PPAR alpha agonist, and this is a new fibrate, pemafibrate, which is an even highly potent PPAR alpha agonist. Now, of course, we know that thiazolidinediones are PPAR gamma agonists. Now, after a quarter of a century of treating LDL cholesterol, we have realized, yes, we realized after these studies that high is bad and statins were needed. And statins decreased both primary atherosclerotic cardiovascular disease and also protected from secondary. But still there was some risk. Then it was found that average is not good. We need to lower it even more. After trials, we found that even lower is better after the improve IT. And after Fourier and Odyssey, it was found that if you take the LDL even to as low as 20, you still found cardiovascular benefits. And Fourier and Odyssey were the two trials with the PCSK9 inhibitors, evolocumab and the other cumab, right? So to summarize, I have not talked about the anti-inflammatory agents. We have lots of them. We have colchicine, methotrexate. We have other studies on various other drugs. Since I have little time, I will summarize to say that the development of novel RNA-based therapeutics and viral gene therapy is providing more specific and potent therapies for tackling complex and devastating lipid disorders. The other thing is, doctors, we must do an extended lipid profile. We must check the LP(a). We must do the apolipoprotein A and capital A and B. And we must remember the other lipoproteins. We must target not just LDL, but non-HDL, also triglycerides in diabetic patients who, in spite of full dose of statin, maximally tolerated dose of statin, still have a high triglyceride, may have residual risk. So the gist of my topic is that newer therapies can address residual risk of ASCVD in patients who are already on dose of statins. We have several drugs which are in phase 1-3 of development, and several novel therapies are being explored. And lipid metabolism is very complex. It's a multifactorial system, and therefore the side effects of different gene targets have to be considered. Thank you.
共有の。
レコーディングしたよ、尾形。
じゃあ、
ありがとうございます。
あれ、どこだ、これか。声いけてますかね？
大丈夫です。
My name is Koshimatsu. I'm from Yao Tokushukai General Hospital, Japan, Osaka. It's great honor and pleasure for me to attend this conference. Today, I would like to talk about CTO procedures for beginners. I hope this lecture will help for beginners. I have nothing to disclose. Recently, CTO procedures success ratio is improving. Retrograde approach dramatically improved the CTO success ratio. Before starting retrograde approach, we must familiarize antegrade approach because CTO procedure require various skills and knowledges, especially for retrograde approach. During retrograde approach for externalization, you must advance the wire antegradally. It means antegrade preparation is necessary for retrograde approach. So we must familiarize antegrade approach technique. Before starting CTO procedures, you should estimate success rate. This is JCTO score. Maybe you know. We can estimate success rate using this score. High score case is a difficult case and frequently requires retrograde approach. JCTO score over 3 is very, very difficult. CTO vessel is straight. CTO entry is tapered. Around the CTO entry without side branch, and inside of a CTO body without severe calcification. CTO length is short and the CTO exit is large. Like this case is easy case. On the other hand, CTO vessel is tortuous. CTO entry is abrupt. CTO entry with a side branch. Inside of CTO exit, inside of CTO body is severe calcification, and the CTO length is long, and the CTO exit is small. Like this case is tough case. Like this case, sometimes we need retrograde approach. For intensive wire control, for antegrade approach, intensive wire control is necessary, and we need enough backup and coaxiality. For CTO procedures, guiding catheter stabilization is very important. For intensive wire control, stabilization is very, very important. Method of stabilizing guiding catheter is using bigger size guiding. It's very simple. And the backup type guiding catheter. Sometimes deep engage and power position is useful. And the mother-child guiding technique is another method. Techniques of stabilizing guiding catheter is like this. Anchor wire technique. It's very simple. Only insert wire, another wire into the side branch, and the body wire technique, and the anchor balloon technique. This is a very famous technique. Sorry, my slide is long. And the coaxial anchor balloon technique. Using OTW balloon like this. This is RCCTO case. We can see microchannel inside of CTO. You can see. You know, about 50% of CTO cases are not totally occluded histologically. They have microchannel. When you can see microchannel inside of CTO, you should create tiny curve like this one. Filter XT series, filter series, and cyan black can create tiny curve like this. Otherwise, it's a little bit difficult to create like this tiny curve. This is another case. Sorry, this case cannot move this case. Why? I don't know. I'm sorry. And like this case, I couldn't use a backup guiding catheter for this case. So it means I use the Jadkins light guiding catheter. But I want to stabilize the guiding. So I insert the wire to the side branch and performing the anchor balloon technique. Fortunately, I could cross the wire using only XTR, and this is the final angio. This is another case, also RCCTO case, but this RCA has big problem, abnormal origin. You can see. Like this case, stabilizing guiding catheter is really difficult. Finally, I used guiding extension devices for stabilizing the guiding catheter because I wanted to control the wire intensively. You can see guide extension and cochlear insert in this. I couldn't cross, even though using XTR and Gaia first. So I decided to change the wire to Gaia second. Finally, I could cross using Gaia second like this. This case, I could succeed antegrade because I could control the wire intensively with Corsair and the guide extension devices. When you start wiring, firstly, single wire manipulation, and secondly, parallel wire technique. And sometimes we need IBUS guided wiring. I want to talk about handling the wire. You should feel of wire tip resistance in CTO region during push and occasionally pullback to keep the true lumen, not to go into the false lumen, and to change the wire appropriately. It's very important point. And very important point is never advance fast and rotated roughly. This is also RCCTO case. I tried to cross using XTR with anchor wire technique. But I couldn't cross here easily using XTR. So I quickly change the wire to Gaia fast. After changing the wire, I could cross easily to the distal true lumen like this. I want to talk about single wire manipulation. If the CTO entry tapered type, and you can see microchannel inside of the CTO body, you should choose XTR wire. Some doctors want to use XTA, but I firstly recommended XTR because XTR tip load is only 0.6. It's safe. We not create subintimal space easily. And CTO entry, tapered type, and without microchannel. You should choose XTA or Gaia fast. Because maybe you need a little bit tip load of the wire. And the CTO entry abrupt type depend on CTO lesion classification. If you know Bessel course, if you cannot know Bessel course and the CTO exit small or ambiguous, you should choose Miracle series or Ultimate Bro 3. Because this wire low rate of perforation compared to other CTO wires. If you know Bessel course, for example, from CT angiography or something, and the CTO exit large or clear, you should choose penetration and controllable wire. It means Gaia series or Conquest series. If you cannot cross the distal to lumen using the fast wire, you should switch to parallel wire technique as soon as possible to avoid create dissection and hematoma. Keeping controls of fast wire sometimes create the big hematoma, and finally, we have some risk of losing distal to lumen. So if you want to perform parallel wire technique, you should switch to parallel wire technique as soon as possible. And using the dual lumen catheter, Crusade or Sasuke is very useful. My recommend is Sasuke because Sasuke's side hole is a little bit go to antegrade compared to Crusade catheter. And this is also RCS CTO case. I could not see microchannel inside of the CTO. I started using XCR, even though we cannot see microchannel. But I wanted to try one time using XTR, but I could not cross easily. So I changed the wire to the Gaia fast. After changing Gaia fast, I thought I could cross the CTO lesion like this. Wire movement, it was very smoothly, like this. But from the angiographically, I found that my wire went to subintimal space. And sorry, so I performed parallel wire technique using Gaia second. After changing the wire to Gaia second, I could change the wire direction intensively like this. And I could change the CTO entry like this. Finally, I could cross to true lumen using Gaia second like this. And this is the final angiogram. I could succeed. Finally, I want to talk about IBUS guide wiring. For IBUS guide wiring, dilatation of subintimal space is required to deliver IBUS catheter. Sometimes 8 French guiding catheter is required for simultaneous wiring with IBUS. Stiff wires such as Conquest and Gaia second or third are required. This is a LED CTO case. I could not see microchannel inside of the CTO region. Here. I used Gaia firstly, but I felt some resistance around the distal LED. So I checked IBUS and I found Gaia fast inside a false lumen maybe from around here. Around here. I performed the firewire technique using Gaia second with Crusade catheter. I want to stop one time. This is a collateral from the RCA. My Gaia fast already into the subintimal space. Firstly, I checked the IBUS and from the angiographically around here, my wire went to the subintimal space. So I insert the double lumen catheter here. And from here, I use the Gaia second. This is because I use the 7 French guiding catheter. If I use the 8 French guiding catheter, I performed simultaneous IBUS guided wiring, but this is the 7 French guiding. But performing the firewire technique using Gaia second, fortunately, I could cross to the distal true lumen. This is the IBUS imaging after crossing the true lumen, but already you can see create the subintimal, big subintimal space on here, like this. So finally, I needed the long stenting from the distal LED. Integrated approach is still a major modality for CTO PCI, and we should estimate the difficulties region morphology. We should use various kinds of integrated techniques before creating dissection and hematoma to distal true lumen. CTO operators must know various kinds of techniques and knowledge about CTO. CTO operators must know characteristics of wire and microcatheters. Thank you so much for your kind attention. Hi.
Hello everyone. So today we are going to discuss approach to a case of HFpEF. So heart failure is not a single pathological diagnosis, but a clinical syndrome consisting of the cardinal symptoms and signs, as you all know. This is due to a structural and or functional abnormality of the heart that results in elevated intracardiac pressures and or inadequate cardiac output at rest and or during exercise. So you know that the heart failure is now classified depending upon the EF, and now EF more than 50% is classified as HFpEF. And I just wanted to note that there is another category which is known as heart failure with improved or recovered ejection fraction, in which patients of reduced ejection fraction, patients of EF less than 40%, when their EF improves of more than 10% by medical treatment or by other device treatment. And then when the EF becomes more than 50%, they cannot be classified as HFpEF, but they have to be classified as HF-IMPF or recovered EF. So why preserved? Why not normal EF? Given the known variability of echo measurements, which is around inter-observer variability of echo is around 7%, and the controversies regarding the precise LVEF cutoff to define normal, the guideline decided to keep the EF of 50% as preserved. And also very high EF, like above 65-70%, which is also known as supranormal EF, is not normal. And when any patient has a supranormal EF, we should be hinting that there should be a search for any other pathology like cardiac amyloidosis, hypertrophic cardiomyopathy, infiltrative restrictive cardiomyopathies. So nowadays, if you see, there is a trend of decreasing patients of HFrEF and increasing in patients of HFpEF, which is now almost 50% of patients of heart failure are actually HFpEF. So why is this happening? Because aging of the population coupled with increased life expectancy thanks to the healthcare model. Now more number of patients are having access to healthcare. Also increased prevalence of cardiac and non-cardiac comorbidities, and also improve recognition of HFpEF in clinical practice, because the number of physicians and other medical personnel are now coming to recognize HFpEF. And there are other non-cardiac comorbidities which are more in patients of HFpEF life, like obesity, overweight, hypertension, COPD, diabetes, renal insufficiency, anemia, sleep apnea. Our patient also today has obesity, hypertension, diabetes. So all these non-cardiac comorbidities which are more in patients of HFpEF, they lead to chronic systemic inflammation, and which leads to inflammatory markers acting on coronary endothelial microvascular inflammation, and ultimately leading to myocardial remodeling and dysfunction. So there are also some other cardiac comorbidities like atrial fibrillation, chronotropic incompetence, systolic dysfunction. Yes, there is systolic dysfunction in patients who have HFpEF. We will discuss that later. Atrial dysfunction, coronary microvascular dysfunction, pericardial restraint, and secondary pulmonary hypertension. So there are some theories of HFpEF. The first theory is primary metabolic, like patients of obesity and diabetes have increased epicardial fat. And how this epicardial fat causes HFpEF is that it releases more pro-inflammatory cytokines, firstly, and secondly, it can also act as a pericardial restraint, leading to HFpEF. The second theory is about the renal theory, of which I would like to discuss because it is very interesting. Like in patients of HFrEF, if you remember, there is neurohormonal activation, and the angiotensin 2 and aldosterone, they cause sodium and water retention. But in patients of HFpEF, there is not much of neurohormonal activation, and the EGFR also in patients with HFpEF is actually normal. Then why the hell are we having sodium and water retention, fluid retention in patients of HFpEF? Like any patient of HFpEF, if he takes extra beer or pasta in his diet, he should just urinate it out. So why is he developing water retention? So the problem here is that sodium avidity is the problem. So either the proximal or the distal tubular increased propensity for sodium retention, or there is decreased propensity for sodium excretion at glomerular level. This is occurring chronically over decades. And sodium and fluid retention, which is occurring subclinically without any symptoms. And this subclinical congestion and stiffness leads to endovascular dysfunction. And then on top of it, whenever the patient has hypertension, LVH, diastolic dysfunction, then because of this decreased reserve, any degree of fluid retention and overload cannot be tolerated, and patient goes into HFpEF. The other theory is the HFpEF is a clinical syndrome theory, in which actually HFrEF is a disease which starts in the myocardium and it goes into the body. Like when a patient has decreased EF, the neurohormonal activation is there, and hemodynamic abnormalities then ensue, cellular abnormalities, CKD, that is goes into the body. But in HFpEF, the theory is that it is opposite, that it is starting in the body and then eventually it is affecting the heart. And the last theory, which is the more favored theory, is the nitric oxide pathobiologically, which is going haywire, is the theory in which there is a metabolic milieu. There is obesity, hypertension, diabetes is causing oxidative stress, and nitric oxide signaling pathway is going haywire, is getting affected. And nitric oxide is present in endothelium all over the body, as you all know. And therefore, when nitric oxide is signaling is affected, the SGMP, CGMP is affected, leading to LVH, fibrosis, atrial dysfunction, and ultimately HFpEF. But the downside of this theory is that we had 4 big trials of nitric oxide, which were all negative. So still it is not very proven. So what do you see in the microscope of the patient with HFpEF? You will see inflammation, you will see hypertrophy, you will see fibrosis. And predominantly these patients of HFpEF are older. So always remember, there are abnormal LA mechanics in patients with HFpEF. There is, because of LV diastolic dysfunction, there is LA fibrosis, there is atrial fibrillation, and there is atrial myopathy. And these patients, they become increasingly symptomatic when atrial fibrillation ensues, because you all know that the 15-20% the atrial kick to cardiac output is lost. So these patients become very, very symptomatic when the atrial kick is lost. So there are some other disorders which should be ruled out when you label a patient as HFpEF, like the cardiac causes of dyspnea that may mimic HFpEF. These are, I'll just enumerate them. There's a cardiac amyloidosis, HOCM, cardiac sarcoidosis, constrictive pericarditis, valvular heart disease, CAD, high output heart failures like liver disease, AV shunts, and thyrotoxicosis, myocarditis, toxins. So these disorders should be ruled out before you label a patient as HFpEF. Also ruled out ISD, lung diseases, masquerading as heart failure, anemia, hypertensive crisis, and pheochromocytoma. So how do you diagnose a patient of HFpEF? So initially the pre-test probability, that is clinical characteristics, should be there. And the diagnosis starts with symptoms and signs of heart failure with an EF of more than 50%. And there should be objective evidence of diastolic dysfunction, which I will tell you later. Please remember that you do not need elevated BNP in all patients of HFpEF. Almost 30% patients of HFpEF have a BNP of less than 100. So these are those patients of HFpEF with less intrinsic myocardial involvement. So all patients of HFpEF should have these two scores. The first score is H2FPF score, in which 2 points are given for BMI more than 30, 1 point for hypertension, 3 points for AF, 1 point for pulmonary hypertension, 1 point for age more than 60, and 1 point for LV filling pressure as measured on echo. And the score of 6 or more has a high probability of HFpEF. The another thing is the HFA-PEF algorithm should be followed in all patients of HFpEF, in which the first step pre-assessment is signs and symptoms of heart failure, comorbidities, ECG, echo, natriuretic peptide should be measured. The second step is diagnostic workup, in which echo and natriuretic peptide, if not measured, have to be measured. The third step is functional testing in case of uncertainty, in which diastolic stress test and invasive hemodynamic measurements can be done in patients, in selected patients in whom you have doubt. And the final step is etiological workup, like CT, MRI, PET. So any breathless patient, the clinical assessment has to be done like with Stagner diagnostic test, natriuretic peptides, ECG, X-ray, echo, and then the HFA-PEFF score has to be calculated. I'll tell you how this score is calculated. And please remember, normal NT-proBNP does not rule out HFpEF. So this is how the HFA-PEFF score is calculated. Depending on the major and minor criteria, it is given the functional, morphological, and biomarkers. The NT-proBNP is different for patient of sinus rhythm and AF. So functional is calculated on echo by tissue Dopplers, morphological on echo by LA volume index, LV mass index. And the major criteria given 2 points, and minor criteria is given 1 point. And if the patient has more than 5 points, then it is diagnostic of HFpEF. So this is how, if it is calculated, if it is low, this score is low, then you have to search for other causes. If it is high, then you have made a diagnosis of HFpEF. If you are intermediate, then you have to do a diastolic stress test, either invasive or non-invasive, which we'll discuss later. And if it is abnormal, then HFpEF is confirmed, and the final step is etiological diagnosis. Some patients, will require advanced HFpEF workup, that is stress echo. On stress echo, you have to measure advanced tissue Doppler parameters. And some patients may need invasive hemodynamic measurements like calculation of PCP-WP, which on rest, if it is more than 15, it is diagnosis of HFpEF. And on exercise, if your PCP-WP is more than 25, it is diagnosis of HFpEF. So final etiological workup is done in patients by a CT, MRI, PET scan in very selected patients to differentiate the initial causes which I told, just to differentiate that there are no other causes which are mixing up with patients of HFpEF. So this is how the integrated diagnostic workup should be done for all patients. Patients with unexplained dyspnea, you should calculate these two scores, H2FPF score and the HFA-PEFF score, which I discussed. And if your patient has an intermediate probability, then only you have to move further to a hemodynamics exercise test, which I will tell you how. If you're high probability, then you have diagnosed the patient as HFpEF. If you're low probability, then probably you're dealing with something else. Now coming to an intermediate probability hemodynamic exercise test. So how is it done? This is a CPEX, that is cardiopulmonary exercise test, in which VO2 is measured, so that we can come to know about other conditions like impaired exercise capacity, or is it obesity induced limitation, or it is intrinsic pulmonary disease, or it is low stroke volume, or it is medication induced beta blocker versus chronotropic incompetence, or you can even prognosticate your patient of HFpEF on the basis of this VO2. So this is how PCPW is measured in cath lab. Invasive hemodynamic testing is done for patients with HFpEF, as patients with HFpEF often have large swings in intrathoracic pressure due to concomitant lung disease or morbid obesity, and therefore the end expiratory PCP-WP should be measured. Some patients will also need dynamic measurement of PCPWP, like on feet up and on exercise. And in whom you cannot do this dynamic exercise, you can just give them saline bolus, 1 liter saline bolus, and measure their PCPWP. These patients are very sensitive to saline boluses, and therefore they go early into failure. And you can also think in clinical practice, whenever any patient is HFpEF is given a saline bolus, they go into failure. So phenotype guided approach to HFpEF, any patient or suspected HFpEF on invasive exercise hemodynamic, if your resting PCPWP is less than 15, and on peak exercise, if it is not increasing to more than 25, then HFpEF is ruled out. If it is increasing to more than 24 on exercise, then this is type 1 HFpEF, which is exercise induced LA pressure increase. And on resting, if your PCPWP is more than 15, and if any of these criteria are there, then this is type 3 HFpEF, which is pulmonary vascular disease or right heart failure. If it is not there, then this is type 2 HFpEF, which is volume overloaded. So what should be measured on echo in all patients of HFpEF? Your LV wall thickness, LV mass, LA volume, your LVEF by global longitudinal strain and not by your M mode. Your tissue Dopplers, your E prime, your TR jet, your PAS should be measured. Also IVRT and tau should be measured. So IVRT is the time interval between aortic valve closure and mitral valve opening. It tells us about the early diastolic LV relaxation. It is affected by heart rate and arterial pressure. Whenever relaxation is prolonged, mitral valve opening is delayed, and hence IVRT is increased, and it is less than 70 normal subjects. So this is how it is measured. A cursor has to be kept between your mitral valve and your aortic valve annulus, and this is how we measure the IVRT. So what we measured, this is how it is translated invasively into the cath lab. This is what early diastolic relaxation we are measuring. So this is what we were discussing, that preserved EF does not mean preserved systolic function because of the arrangement of the myocardial fibers, the circular, longitudinal, the different way crisscross arrangement. Every patient of HFpEF should have their global longitudinal strain measured, because there have been numerous papers which have been published that strain imaging can detect impaired systolic function despite normal global EF in HFpEF patient, which contributes to pathophysiology of the HFpEF. So how are the outcome of HFpEF different from HFrEF? In HFrEF patient, actually, the 75% of the cardiovascular causes, the death is because of 75% of the cardiovascular causes, most of which is sudden cardiac death and pump failure. Whereas in HFpEF patient, 50% of the deaths are because of non-cardiovascular causes. So that is why now you can imagine why drugs are having a very hard time in HFpEF to have mortality benefits. So the problem of heart failure in 2022 is not HFrEF but HFpEF, because these are the 50% patients of heart failure in which 5 big trials have reported in last 15 years as negative. So where are we now in 2022? So we know till now that these 5 big trials have shown no benefit. So all over these were negative trials. And after the recent trials also, like your RAM-PEF, RELAX, NEAT, HFpEF, EDIFY, Socrates, PRISM, all these were nitric oxide trials which are also negative. And out of these 7 trials, these 3 trials which we'll be discussing today is TOPCAT, Paragon, Emperor, Preserve, and the DELIVER trial. So these 4 had some beneficial effects in HFpEF patients. So first is the TOPCAT, in which spironolactone was given to patients with HFpEF. The primary endpoint was also not achieved in the HFpEF patient, but the spironolactone had beneficial effects on heart failure hospitalization. But the benefit of spironolactone diminished with increasing EF. So this was something which was not good. And diuretic use in HFpEF, it is said it is empirical use as in other patients also. If there is no need of diuretic, it is said that there is probably not heart failure. So another trial is Paragon HF. Just like the brother Paradigm HF in reduced, this is the Paragon is done in patient with preserved ejection fraction. 5,000 patient with EF more than 45% was given this ARNI. So in this also the primary endpoint was not achieved, but there was improvement in the NYHA functional class. And if you see the subgroup analysis of Paragon, the female patient achieved their primary endpoint and the patient with EF of 57%. So this magical number of 57% was achieved in this trial. That is means your patient of EF 57% or lower will achieve the primary endpoint, whereas more did not have a beneficial effect. So benefits were according to gender and EF marginally significant, if you can say. So depending on this, FDA expanded the ARNI indication to HFpEF, but this has not yet translated into the guidelines. So what do the guidelines at present tell us? So basically and practically nothing. The guideline is just telling us you treat your comorbidities, you treat your systolic diastolic blood pressure, use diuretics, treat your CAD according to GDMT, you manage your AF, you give beta blockers, AS, ARBs as a class 2A indication and ARB as a class 2B indication. So practically nothing much in the guidelines. So if you have understood the pathophysiology of HFpEF, which I told earlier, now you will understand that why SGLT2 inhibitor having beneficial effect in the recent trial because it is causing decreasing cardiac preload, ventricular remodeling, atrial remodeling, systolic dysfunction, diastolic abnormality, fibrosis, and increasing endothelial function, decreasing the vascular stiffness, decreasing systemic blood pressure, fluid overloads. So where are we going now? So these are the trials of SGLT2 which have been lined up to 2023, and out of which the Emperor Preserved trial results are out, and the Deliver trials results are going to be out next month. So coming to the Emperor Preserved trial, so the Emperor Reduced was in EF less than 40, and this is Emperor Preserved, which was done in EF more than 40%. So these patients were given empagliflozin 10 milligrams. So it achieved it. This was the first trial in HFpEF which achieved its primary endpoint. So 21% relative risk reduction was seen in the NNT 31 and statistically significant from day 18. So this was very exciting because the first trial in HFpEF which achieved its primary endpoint. And if you go to a subgroup analysis, there was no difference between diabetes, non-diabetes, no gender difference. But what was seen that if you go on increasing your EF from 50 to 60% in 3 groups, there was decremental benefit which was seen. So this is slightly disheartening, but this is what we have now. And if you consider subgroup analysis of patients with EF more than 50%, that is your predominant HFpEF patient in all of these trials, then this is where Emperor Preserve stand out. That is 70% reductive risk reduction as compared to the other trials of HFpEF. So this is what was seen. There was a discordance seen in the estimated eGFR and the renal outcomes in the patients which was seen in Emperor Preserve. That is, the initial notch was seen in the patients of this trial when the empagliflozin. This notch is seen in the ACE and ARB also in all the patients. And after this, there is an improvement in the eGFR at the rate of 1.36 ml per year. But this improvement was not translating into the renal outcome. That is, the patient was not having benefit in dialysis, renal transplantation. So this is just like atenolol in heart failure, that your pressure is getting decreased, but you are not having mortality benefit. Now why is there this discordance? This will be answered by the other trial, like the Deliver trial and the other trials which are ongoing. But there was also seen positive improvement in NYHA class in the trial, and also first secondary endpoint, that is total heart failure hospitalization, were also decreased by empagliflozin in HFpEF. And not only patient who required ICU admission, who required IV vasopressors and IV inotropic agent had decreased hospitalization, but also patient who had come in OPD. The OPD visits also decreased in patients with HFpEF. And the beneficial effect was seen right from day 80. So you can see how beneficial was this drug in patients of HFpEF. And what were the adverse events? This was a pretty stable drug. There was not much of difference between the empagliflozin and the placebo. So it was a safe drug for HFpEF. So all the 3 endpoints were achieved in patients of HFpEF. That is primary endpoint, secondary endpoint, and secondary endpoint of eGFR were achieved. And if you consider the subgroup analysis of patients of more than 50% only, then also the primary endpoint, your recurrent heart failure hospitalization, your quality of life, your kidney function, all of these were achieved. So this is where we stand right now, the only trial with positive effects in the background of all these other negative trials. So the one drug, 2 trial for less than 40% and more than 40%, both of them positive. And this is the Deliver trial, which is ongoing, which has been just completed, but the results are going to come next month. So 6,000 patients of HFpEF were given dapagliflozin, and we'll see what the result comes next month. So one more trial which was Preserved HF trial done in HFpEF patient, dapagliflozin improved the 6-minute walk test. And these are the pillars of HFpEF in 2022 patient. So the patients of HFpEF, when discharged from the ICU, should be on a SGLT2 inhibitor, on an ARNI, and on an aldosterone antagonist and diuretic for symptomatic use. So any patient who is of HFpEF should have been these drugs, should be given these drugs to reduce the mortality benefit. So what are the future treatment in obese patient? Maybe GLP-1 receptor agonist, ketogenic diet, bariatric surgery. The future which is in pipeline is greater sampling for sphenic nerve ablation, camerin antisense, oligonucleotide, some neprilysin inhibition, PDE9 inhibition, and many interatrial shunt devices are in pipeline, but all are in developmental stage because of the increased LA pressures. What is the surgical management of HFpEF? So we know there is increased LV filling pressure, but what to do about it? So you can slice up the pericardium. So you can allow the heart to fill more easily, just like we do in constrictive pericarditis. And it can be done percutaneously for a very elderly patient, frail patient who are not suitable for any other surgeries. So you can a single slit in pericardium. It has been studied preclinically that there has been higher LV compliances by saline load. So all this is in pipeline, and we'll see. So HFpEF is a common underdiagnosed heterogenic systemic multi-organ reserved dysfunction syndrome. Diagnosis is challenging, but high degree of suspicion and following guideline-directed algorithm, diagnosis can be made certainly. So the gold standard is the invasive diastolic stress testing, which I told you how to do the invasive testing. And the H2F PF score is useful in patients with unexplained dyspnea. Always exclude the mimickers. The treatment is currently directed to symptomatic and congestion and comorbidity treatment. ARNI is approved to reduce the cardiovascular risk and heart failure hospitalization. However, the benefits are most clearly evidenced in patients with EF below normal. Guidelines are presently being revised, and ARNI and SGLT2 will be the promising new additions. Thank you. Hello, everyone. So now we are discussing acute massive pulmonary embolism. So it is the third most common cause of cardiovascular illness, but still it is one of the most underdiagnosed conditions. Consider DVT and pulmonary embolism as one disease, and if pulmonary embolism is suspected, look for signs and symptoms of DVT. Absence of DVT does not rule out pulmonary embolism. According to Indian statistics, it is responsible for up to 15% of all the in-hospital deaths. So if a patient of massive pulmonary embolism is going to come to you, he is mostly going to come to you with hemodynamic collapse, cardiogenic shock, or an arrest, or extreme unexplained dyspnea or chest pain, and uncommonly with cough, hemoptysis, and syncope. The other signs which may be seen is tachypnea, tachycardia, signs of DVT, fever, and cyanosis. So this is the three ways by which patients of pulmonary embolism presents. Usually 5 to 10% are massive, which is presenting as hypotension, cardiogenic shock, or arrest, and in which the systolic blood pressures are less than 90 or more than 40 millimeters of drop in pressures over 15 minutes, or any patient who is maintaining pressures with high dose inotropes or vasopressors. The second most common is 20 to 25% intermediate presentation, in which the patients are normotensive with signs of RV compromise, also called submassive. And the third common presentation is more than 70% patients are stable, in which they are normal blood pressure, normotensive with no or mild risk, which is also known as low risk patients. So everybody knows this Wells clinical prediction rule. I'm not going to go through, but only the simplified version which is available, in which the score is more than 2, which is out of these 7 scores. If score is more than 2, then pulmonary embolism is likely. Also, the common Geneva clinical prediction rule, if the score is more than 3 now in the simplified version, then pulmonary embolism is likely. What more commonly I would like to discuss is the new PESI score, which is pulmonary embolism severity index, which should be measured in all pulmonary embolism patients, in which you get 1 point if the age is more than 80, a 1 point for cancer, 1 point for either CHF or pulmonary disease, 1 point for tachycardia, 1 point for hypertension, and 1 point for saturation is less than 90. If you have any 1 point, then your 30-day mortality is going to be 11%. So initial risk stratification for acute pulmonary embolism, if any patient has shock or hypertension, then he is classified as high risk, like our patient of massive pulmonary embolism, as we initially defined, pressure is less than 90 or a more than 40 millimeter drop over 15 minutes, which is not caused by any new arrhythmia, hypovolemia, or sepsis. So any patient of pulmonary embolism, if he is not hemodynamically stable, he is high risk pulmonary embolism or a massive PE. If he is stable, then you have to do 3 things. One, you have to calculate his PESI score. You have to check his RV function either by a echo or by the CT, and you have to calculate his troponin levels. If all 3 are abnormal, he is intermediate high risk. If 2 are abnormal, he is intermediate low risk, and if all 3 are normal, he is low risk PE. So this is how we do the early mortality risk stratification, in which it is a high risk if he has hemodynamic instability, his PESI score is high, he has RV dysfunction, and troponin levels are high. So all the 4 ticks out, then he has high mortality risk. If he does not have hemodynamic instability, but the other 3 are positive, then he is intermediate high risk. If he does not have hemodynamic instability, and if he has either RV dysfunction or troponin positive with a high PESI score, then he is intermediate low risk. And if everything is negative, then he is a low risk. So pathophysiological pulmonary embolism is that there is an anatomical obstruction because of the clot. There is hypoxemic vasoconstriction and neurohormonal effects, leading to increased PA pressure, RV afterload, and increase in the PVR, leading to RV dilatation, dysfunction, decrease in RV output, interventricular septal shift of the LV, leading to decrease in LV preload, decrease in LV output, causing decrease in systemic perfusion, hypotension, also decrease in coronary perfusion, causing decrease in RV oxygen supply, causing decrease in RV ischemia, and so on. And all these things can be studied just by a bedside echo. Also, do not forget the 60-60 rule on echo, which is disturbed RV ejection pattern, which is RV acceleration time of less than 60 milliseconds in presence of TR gradient less than 60. So all these pathophysiologies can be studied on echo, which is increased PVR and RV pressure overload by our TR gradients, your RV dilatation, hypokinesis, and interventricular septal deviation, which is D-shaped LV, abnormal LV filling by the E and E prime and A, your decreased LV cardiac output and systemic arterial hypotension by your compressed LV, and your RV ischemia, infarction, and failure, which can also be seen by the McConnell sign, which is apical sparing. So any high risk or massive pulmonary embolism patient, bedside TE should be done, transthoracic echo, to check for RV dysfunction. If it is not there, you should then look for some other causes of the shock or instability. If it is there, then you should, if your CTPA is immediately available, then you can go ahead with the CTPA. But if it is not there, you should not waste time, and you should directly begin a treatment for high risk PE, which is usually lysis or anticoagulation. But if you have a CTPA and if it is positive, then you treat your patient with the lysis or anticoagulation. And if it is negative, then you search for other causes. So acute PE, patient with shock, hypotension, PE, arrest, it is high risk PE, and if there are no contraindication, please lyse your patient. If there are contraindication, then you have to consider surgical embolectomy or catheter-directed thrombolysis. If it is low or intermediate risk PE, as I mentioned, you have to check these three things, and if all the three things are present, it is intermediate high risk PE, then you should consider lysis or CDT is a low bleeding, if the patient is a low bleeding risk. And if that either 2 or 1 are positive, then it is a low risk or intermediate low risk, and patient is a candidate for anticoagulation. So how you do diagnose pulmonary embolism? By these tests. First is D-dimer. It has a good negative predictive value. It is less specific, but it is used to ruling out pulmonary embolism in low clinical probability patient. So ECG, what an ECG will show in massive pulmonary embolism: sinus tachycardia, right axis deviation, right bundle, a new RBBB, RV overload in V1 to V4, like ST depression, T inversion, V1 to V4, atrial fibrillation, your S1 Q333, right? You can also if you do a duplex ultrasonography, you may find evidence of DVT in the proximal veins. What will an X-ray show? So a normal X-ray in presence of severe breathlessness is diagnostic of massive pulmonary embolism. You can also have your Westermarck sign, which is focal oligemia in massive pulmonary embolism. But the other sign, which is Hampton's hump, is seen in peripheral pulmonary embolism, like because of pulmonary infarction. And your Pallas sign, which is enlarged right descending pulmonary artery, is also seen in submassive to peripheral pulmonary embolism. So echo and TROP and BNP we already discussed. Your CTPA will show you direct visualization of the filling defects. So what to expect in the ABG? The two most common gas exchange abnormalities are hypoxemia and increased alveolar arterial oxygen gradient. Some patient may hyperventilate, leading to hypocapnia and respiratory alkalosis. Hypercapnia, if it is present in a patient of high risk of massive pulmonary embolism, it is very bad, because it is showing impaired minute ventilation and increased anatomical and physiological dead space. And hypercapnia is usually a poor prognostic indicator. So non-imaging diagnostic tests for pulmonary embolism are D-dimer, cardiac markers, and ECG, which we discussed. So what is the treatment? It is, your goals are to prevent death, to reduce the chances of recurrent embolism, and to minimize the long-term morbidity due to the event. So hemodynamic support, although the initial strategy to manage hemodynamic instability is often to augment the RV preload by bolus IV, but excessive volume resuscitation may exacerbate RV failure by over-distending the RV, increasing the wall stress and worsening RV ischemia, decreasing contractility and causing further ventricular shifts towards the LV, and causing decreased LV filling and decreasing cardiac output. And therefore, initial trial of IV volume is most likely to be successful in patients without signs of increased right-sided preload, such as those with CVP less than 15. While in patients of more than CVP more than 15, volume overloading should be avoided, and administration of vasopressors and inotropes should be the initial steps in hemodynamic support. And vasopressors such as norepinephrine, epinephrine, dopamine have dual mechanisms of action as both inotropes and vasodepressors, and therefore may be preferred in initial support. While in patients with tachycardia, primary vasopressors such as vasopressin or phenylephrine may be most appropriate to avoid accelerating the heart rate further. So what is the treatment? Is heparin at unfractionated low molecular weight, lysis, either systemic or catheter-directed surgical embolectomy, and IVC filter. So mainly anticoagulation and thrombolytics are the mainstay of treatment in massive pulmonary embolism. And when should you begin your anticoagulation? As soon as possible. So you all know 80 and 18, which we follow, 80 bolus and 18 units per infusion of the unfractionated heparin, and it should be continuous for at least 5 days before. If you are going to use a vitamin K antagonist, then your target INR should be more than 2, or NOAC, then as soon as possible you can just start your NOAC after your infusion. And or thrombolysis. So why thrombolysis is beneficial? Because it causes faster clot lysis, dissolves obstruction, may reverse the RV failure, dissolves much of the source of your pulmonary embolism, decreases the risk of recurrence. It is usually well tolerated, has excellent prognosis, but has some risk of hemorrhage, like up to 1.2% risk of intracoronary hemorrhage, mainly more in patients of non-massive pulmonary embolism. So if you see the trials which was done, the efficacy of systemic thrombolysis was very excellent in massive pulmonary embolism. So all the patients of massive pulmonary embolism who don't have any contraindications for lysis should be given this lysis. But whereas patients with intermediate risk and low intermediate risk patient should be evaluated further, their bleeding scores and should be calculated, and if low bleeding they should also be lysed. But other trials such as the PETHO trial had shown high intracranial bleeding risk in patients of intermediate risk with tenecteplase. You should keep that in mind. Whereas safety, when it is concerned, the alteplase was found to be more safer than tenecteplase in terms of major bleeding and fatal intracranial hemorrhages. So these are the agents which are approved. Streptokinase, usually we follow 2.5 interlactional units as a loading dose over half an hour, followed by 1 lakh international units per hour for 12 to 24 hours. There is an accelerated regimen as 1.5 million units over 2 hours, but it causes hypertension. Urokinase, we give 4,400 as loading over 10 minutes, followed by 4,400 per kg per hour for 24 hours. There is also accelerated regimen, but is not commonly used. Most commonly used is the alteplase. 100 milligrams has to be given over 2 hours, or maximum dose of 50 milligrams has to be given over 15 minutes, which is accelerated regimen. Apart from this, there are two other agents like tenecteplase, which is weight adjusted as we all use, and also reteplase, which is 10 and 10, which can also be used. So alteplase is the one which is more commonly being advocated, and total of 100 milligrams has to be given in 2 hours, and 10 milligrams is usually given as an intravenous bolus over 1 to 2 minutes, followed by 90 milligrams as an IV infusion over 2 hours. Or in patients with a body weight less than 65 kgs, 10 milligrams can be given as an IV bolus over 1 to 2 minutes, followed by an IV infusion to a maximum dose of 1.5 milligrams per kg. So what is the evidence of alteplase in acute pulmonary embolism? This was a trial PAIMS-2 plasminogen activator Italian multi-center study in which the alteplase was studied, and after this approval was given. If you consider alteplase versus urokinase in a study, then the pulmonary vascular resistance was decreased faster in patients who were given alteplase rather than those who gave urokinase. So you can prefer alteplase rather than other agents. So what do the guidelines say? There is class 1 indication for anticoagulation in all patients with high risk PE. There is class 1 indication for systemic thrombolysis. There is class 1 indication for surgical embolectomy in patients with high risk PE in whom thrombolysis is contraindicated or failed. And there is class 2A indication for percutaneous catheter directed treatment in whom thrombolysis is contraindicated or failed, and use of inotropes and norepinephrine and dobutamine. And there is class 2 indication for ECMO in combination for surgical embolectomy or catheter directed treatments for refractory patients with cardiac arrests. So any patients with pulmonary embolism, you should anticoagulate them, and if there is any hemodynamic instability, you treat them as high risk. You should reperfuse them as we discussed. And if they are not hemodynamically unstable, then as we know, you should calculate these three things: the PESI score, RV dysfunction, and your troponin levels. And if all three are positive, then you should consider them for reperfusion or at least anticoagulate them. And if not, then you should at least hospitalize them and anticoagulate them for 5 days. So catheter-directed thrombolysis involves removal or disruption of obstructive thrombi from the main pulmonary artery and or local administration of small dose of thrombolytics directly into the pulmonary artery. The various interventional options include thrombus fragmentation with pigtail or balloon catheter, rheolytic thrombectomy, suction thrombectomy, aspiration catheters, and rotational thrombectomy. Concurrent administration of local thrombolytics can be performed via multiple side-hole catheters in the pulmonary artery with or without the application of ultrasound energy. And actually CDT is now only effective for MPA or its major branches and with less organized thrombus. The efficacy is limited by the relatively small size of the aspiration catheters compared with the size of the main pulmonary artery. It has the advantage of being better tolerated in patients with tenuous hemodynamics compared with surgical embolectomy and requires lower dose of thrombolytics compared to the systemic one. It has the advantage of increased efficacy of thrombus resolution due to synergistic effects of higher local thrombolytic drug concentration as mechanical disruption with greater exposed thrombus surface area. Because higher local drug concentration is achieved with overall lower dose of fibrinolytic agent, it may offer the advantage of decreased hemorrhagic complication. But there is limited good quality data on hard outcomes on using CDT in pulmonary embolism. So it should be considered in high-risk patient as an alternative to surgical embolectomy when systemic lysis is contraindicated or has failed, or in intermediate high-risk patient if the anticipated risk for bleeding with systemic lysis is high. Surgical embolectomy is open surgical procedure in which the clots are to be removed from the right atrium ventricle or the main pulmonary arteries. It is indicated in patients with massive PE and possibly submassive PE who have contraindication to lysis, or when lysis or catheter-directed treatments have failed. So these are the treatment options which we discussed: in systemic lysis, catheter-directed lysis with mechanical disruption, surgical embolectomy, and ECMO. All have their pros and cons. Each has their advantages and disadvantages, and it has each case, depending upon the bleeding risk, depending upon their pressure, depending upon their presentation, has to be individualized, and it cannot be just generalized that this every patient should be like. It has to be individualized case to case. So what is the optimal duration for anticoagulation? If it is a first provoked proximal leg DVT, usually up to 6 months. If it is first provoked calf DVT or upper extremity DVT, then it is 3 months. Second provoked DVT, then a VTE, then it is uncertain. Third embolism is indefinite always. If it is cancer, then usually it is indefinite or until the cancer is treated. Unprovoked proximal leg DVT is usually indefinite. First unprovoked calf DVT is usually 3 months, while second unprovoked calf DVT, the duration is uncertain. Thank you.
Myself, Dr. Chirayu Vyas, and cardiac electrophysiologist and interventional cardiologist, just going to present a topic which is related to the use of 3D ablation mapping for ablation of cardiac arrhythmias. Especially the tachyarrhythmias. The commonest form of fast heartbeats, which with the patient usually arrives in the emergency room or maybe on an OPD visit occasionally, that is what is usually called as a supraventricular tachycardia. It would be like ventricular tachycardia, and the other tachyarrhythmias are also there, but most often they are the ones which present with this supraventricular tachycardia, which actually present as narrow QRS complex tachycardias with short or maybe intermediate RP intervals. That is what is a technologically correct term for a description of a supraventricular tachycardia. And the usual ECGs which appear in front of us are usually in the form of this, which is where the heartbeats range more than usually 150 beats per minute, maybe may go up to as high as 200 or maybe up to even more than that, 200 beats per minute. So for that, looking at the hemodynamic stability, usually they are treated with certain forms of intravenous medication boluses, and very rarely with maybe DC cardioversion shocks. But actually the medicines are only a form of temporary cure for this kind of arrhythmias, because these are the arrhythmias which are usually caused by a re-entry of the electric current in an extra pathway which is located actually inside the patient's heart at certain locations. So a permanent cure of this form of abnormality is what is called as electrophysiology study and ablation, which is where looking at the electrical signals by introducing catheters, which are actually long tubes, which is what they're usually introduced from the groin area, the femoral artery and the femoral vein, and very rarely from the subclavian or the internal jugular vein. This is how they enter the heart's chambers and the different great vasculatures, including the vena cava and the other aorta and the other arteries. This is how actually these catheters enter these places, and these catheters are then connected to an electrophysiological system outside, which is where the signals which are appearing on that system, this is what would locate the extra pathway, which is what is causing the re-entry of the electric current inside the heart, which is the main mechanism by which this heartbeats go very, very fast. So that is what I showed on the ECG. in terms of that supraventricular arrhythmia, which is the commonest form of supraventricular tachycardia, which is a AV nodal re-entrant tachycardia. That is what the ECG was, the prior ECG. So here is the cath lab demonstration of how we usually enter the groin area by just giving a local anesthesia, anesthetizing the skin, and usually entering through a needle by Seldinger technique and introducing the long tubes, the catheters, which are they called as, which is what ultimately arrive the heart and the great vasculature, gradually guided by the fluoroscopy screen, which is where this is basically the documentation of the intracardiac electrogram. We usually see the ECGs, which are usually placed, the electrodes are usually placed outside the body. So this is what is demonstration of the electrical conduction system of the heart from outside. So if at all you want to have a detailed look at the electrical conduction system in a way, then that is the only way which is achieved by intracardiac evaluation of these electrograms, which is called as this electrophysiology study. Here is what in the picture you can see the ECG demonstrating the P and the QRS complexes, but actually the catheters which are placed through the femoral artery and vein into the heart chamber. This is where they're going into the high right atrium, the His bundle electrogram, and the right ventricle, which is where they're demonstrating the atrial electrogram A, the His bundle electrogram, the H, and V being the ventricular electrogram. So in detail, they're showing the electrical conduction system of the heart in terms of the parameters as to how they are measured, the baseline parameters, and as also those which would be revealed on stimulation protocols. So ultimately, these are the ways by which the heart is entered by these catheters, and the arrhythmia source of origin is localized as to what area of the heart, any focus or an extra pathway is causing these heartbeats to get going so fast. So this is what is the localization of the cause of arrhythmia, which is helped by this electrophysiology study. So actually, if at all we are going through the commonest arrhythmia as the first ECG showing the supraventricular tachycardia, the commonest one, the AV nodal re-entrant tachycardia. But actually, what's the fact in today's cardiac electrophysiological world? That most of the electrophysiologists would use the even higher version of mapping system, which is called as a 3D mapping system for very complex ablations, especially in tachyarrhythmias, which would be like atrial fibrillation, atypical right atrial flutter, a left atrial origin tachycardia, and especially the ventricular origin arrhythmias, the ventricular tachycardias. So especially these are the ones which would be done by most of these ablations would be performed correctly even without these 3D systems by experienced operators, but usually they would be preferred in 3D mapping systems. So these are the arrhythmias especially likely to be dealt with in a much better way by the 3D systems. So currently only 3 major systems are there in the market and widely used by the medical community. These are the ones in terms of their names. They would be a CARTO system as manufactured by the Cordis Webster, as it was known as earlier, and now it is called as the Johnson & Johnson system. The Ensight Navix system, especially by St. Jude Medical, and the third one, the Rhythmia system by Boston Scientific. These are the systems which usually give us the 3D mapping technology for electrophysiology. So what are the advantages of a 3-dimensional electrophysiology mapping system? The 3-dimensional cardiac chamber anatomy, which is rendered by point-to-point acquisition of the spatial coordinates by moving the mapping catheter. The electrophysiology information would be acquired by fluoroscopy free catheter navigation. So without pressing on the pedal to ensure fluoroscopic evaluation of the movements of catheter, you can just move the catheter in a way to just outline the anatomy of the cardiac chambers. An activation map, which is where how the arrhythmia progresses, would be built with 3D mapping system. It could display local activation time for a cardiac chamber in relation to a reference electrogram, either early or being late. It is helpful to determine the tachycardia mechanism as either being a focal or a macro re-entrant one. And this is how it identifies the ablation target size as to where to treat them correctly to give that a permanent cure. And thirdly, being a location tagging function, especially of 3D mapping. This is what could mark the catheter in virtual space. It could designate the locations of critical structures, which is what would avoid the collateral damage, and catalog the ablation sites as to where you have already performed the ablation and allow return to these sites of interest if at all you want to return that again. The next would be a voltage mapping system, especially through the 3D mapping. It can display electrogram amplitudes throughout the cardiac chambers and guide the substrate ablation, especially in the absence of an arrhythmia, especially if the patient is in sinus rhythm, then just by a substrate based ablation based on this voltage mapping can just localize the source of origin of the arrhythmia, even if the patient is not in tachyarrhythmia. An isochronal color-based 3D system map would depict all the points with an activation time within a certain range with the same color, which can assist in visualizing the direction of wavefront propagation, as I told earlier, and indicates the local conduction velocities. And lastly, being the image merge function of a 3D mapping system, this is what would provide a detailed anatomical information, especially like a pouch in left atria, and facilitate the extensive ablation about these anatomical structures, including pulmonary veins, the left atria, and even a ventricular scar if at all we have entered the ventricles. But as these advantages of the 3D system, the commonly used and the frequently used the two-dimensional electrophysiology mapping system, what are the disadvantages? Which is what causes us to move towards the three-dimensional mapping system, especially in such kind of complex arrhythmias. An extensive fluoroscopic exposure to the patient as well as to the operator is the main reason of a 2D electrophysiologic mapping system, which is the main disadvantage. It has got a significant likelihood of collateral damage because there is lack of orientation of an anatomical plane where the arrhythmogenic substrate is, and also where the working electrophysiology catheter is doing its own work. There is all usually a presumption of points related to prior ablation work, which is already done. So the ablation work desired, if at all, which needs to be done again, it also is only based on presumption of the fluoroscopic landmarks. An exhaustive list of ECG algorithms would be there in trying to localize a source of origin for the arrhythmogenic substrate, be it either a simple accessory pathway or maybe even a complex focal atrial tachycardia or maybe even a scar-related ventricular tachycardia. The ECG algorithms are absolutely exhaustive. So these are what the usual pictorial depictions of the 3D mapping systems. The commonest one being the CARTO, which is what is showing these color maps in a three-dimensional mapping system, as also in a EnSight Navix, which is what is showing the same, the 3D mapping system, and the Rhythmia, the 3D mapping system. These are the pictures which are again localizing the arrhythmogenic substrate in a much better way. But as compared to these advantages which I've already described, we should always keep what are the disadvantages of utilizing a three-dimensional mapping system for a basic electrophysiology study and ablation. The first one being the cost of installing the system, especially in a working cardiology cath lab, is pretty much high as to that cannot be used usually by all routine cath labs. The cost of the patient that he needs to pay the cost for needing to undergo a three-dimensional mapping EP study and ablation, it is not getting done through maybe especially government beneficiary schemes as of now, especially like Ayushman Bharat Yojana or all, because of the cost of the mapping catheter itself, which is what is usually only a single time use. Very rarely would be used for 2 times in a 2 different patients just to reduce the cost factor. But that is the usual burden which the operator as well as the patient would be constantly facing, especially to keep the cost under control. There's a steep learning curve for the operator as well as for the cardiac electrophysiology technicians also in terms of the 3D assessment of the mapping technology. Only few available technicians would overcome this steep learning curve for the 3D mapping in electrophysiology, and especially those who would be available on time to contribute during the working hours. That's very difficult in routine world today, day-to-day practice. Occupying the cath lab for a significant duration to set up the 3D EP system is one more disadvantage, especially because it takes a long time in getting it prepared, making other cardiology colleagues waiting for other procedures for a pretty long time, which is what is a practically pretty much a big disadvantage which everybody would be facing. Then a tachycardia should be sustained or especially most importantly tolerated enough to allow an activation mapping if at all we want to do that. The next disadvantage of a 3D system would be in case of a diseased atrium or a ventricle with extended scarring, either because of prior cardiac surgery or maybe because of any other reasons, comprehension of the activation mapping may be sometimes difficult. To date, cryoablation for atrial fibrillation does not combine with a 3D mapping system, which may render the cost of procedure excessively, and it is performed with fluoroscopy only. symptomatic, most importantly, symptomatic recurrences of tachyarrhythmia are documented even after 3D EP study ablation, especially in atrial fibrillation or especially post-congenital heart disease surgery, left atrial tachycardias. Implantable cardioverter defibrillator device, ICD device implantation is often required even after a ventricular tachyarrhythmia getting ablated by a 3D mapping system for secondary prophylaxis of VT, which has got to have been installed, especially the ones which are associated with sudden cardiac death prophylaxis. So 80% of the commonly encountered supraventricular tachycardia mechanism being atrioventricular nodal tachycardia, the first ECG that I showed, which is what in 99.99% of the cases could be safely and easily dealt with by ablation in conventional two-dimensional electrophysiology mapping systems. This is what we need to understand. So these are the basic pictures showing the two-dimensional EP study mapping systems ablating the AV nodal re-entrant tachycardia, the commonest SVT, as well as maybe even a left atrial accessory pathway, which is what would be transeptally or maybe encountered and then ablated accordingly. This is what was demonstrated in the third picture, especially in the presence of even a prior atrial septal defect occluded device, an ASD device in place, despite the AV nodal re-entrant tachycardia was ablated under 2D mapping system. The same thing maybe for the second picture, which is what are showing the surgical clips. That was a patient who had undergone a surgical open heart surgery, and despite that fact, was pretty much easily dealt with in a 2D electrophysiology system mapping. This is what would be a pretty much dangerous looking tachyarrhythmia, which is what most often people would recognize that as a ventricular tachycardia, and especially a polymorphic ventricular tachycardia. But actually, it is a pre-excited atrial fibrillation, which is what would be pretty fast, would be pretty broad in terms of the QRS width and irregularity. This is what would usually identify this pre-excited atrial fibrillation. And once with a DC cardioversion, getting this rhythm to return to sinus rhythm would easily reveal a manifest accessory pathway, which is what would localize the site of the accessory pathway, which is what would be dealt with usually in a two-dimensional EP study system, very straightforward. So at the end of this discussion, which is what would be the real indications of three-dimensional EP study mapping system for ablation of tachyarrhythmia, it all depends on the benefit that is what would be achieved as to the cost which would be paid by the operator as well as the patient per se in terms of these complex tachyarrhythmias, which would be usually dealt by these 3D systems in a much better way. Thank you so much.
Hi, everyone. We're going to take a look today on some tips and tricks in CTO PCI, and the primary goal is avoiding complications. As we know, the thing that always fears us when we take on complex PCI and CTOs are the risk of complications. So this talk is really not about a case complication, but it's about what are some things that you can do to avoid complications. Perforations is probably the biggest challenge, and we are always worried, and this is a real risk when we are talking about CTOs. This can happen in the main body, the distal vessel, or in a collateral. So how do you avoid perforations? So here is a case that I did a few years ago in Hyderabad with a fatal lima. There's ischemia in the LAD territory. There's a patent graft to the CERT. The first way you avoid a complication is by trying and not taking that epicardial collateral that goes through the graft to the OM. That would be really high end. So the plan, given that it's a long lesion and the distal vessel is okay, collateral is really iffy, proximal cap is discrete. Primary strategy is to do ADR. So this, what all goes into avoiding complications? Number one, go into the plan, understand the anatomy, go with the safest approach first. If that doesn't work, if you're really comfortable, then and only then should you consider retrograde. So here is knuckle with the intent of doing ADR, microcatheter, Miracle 12. We are in the architecture of the vessel. In this particular case, it so happened that Stingray wasn't available, so parallel wiring was done, alongside the knuckle, and that kind of pretty much finished the case. As you can see, that's a concrete spur 12 entering the true lumen. Then this is exchanged for a workhorse wire, and that's the final result of the LAD. Here's another case from a couple of years ago. So this is a CERT CTO. Once again, this actually was a live case, long 20 millimeter plus lesion. Distal vessels possibly okay, near a bifurcation, collaterals are iffy again, and the proximal cap was ambiguous, so really not a great case. But the plan was to try and do antegrade wire escalation after IVUS entry. If this didn't work, to switch to retrograde. If that didn't work, to go ADR. So IVUS guided puncture of the proximal cap. As you can see at 11:12, you've identified the proximal cap and punctured. So that's another pearl. Don't stick in blind, use IVUS, use imaging judiciously to identify anytime you have anatomic ambiguity. And then penetrative wire dual lumen catheter. However, wiring was unsuccessful. As you can see, the wire is nowhere close to the vessel. Multiple wires were tried, no retrograde option. Convince the primary operator to knuckle. Here's the knuckle going in along with the caravel. Knuckle is in the architecture of the vessel. Miracle, that's a stingray balloon that's going to come down here. That's here and here. Once that's in position, you see that it's in the architecture of the vessel. Stick and drive. Just going to let this video play. Okay, there, that's in. Once again, exchange for a work microcatheter goes in. Exchange for a workhorse wire. Secure the other branch with the dual lumen catheter. At this point, confirm that you are in the true lumen in both the branches. At 12:1, you see true lumen. Then you will see subintimal space, and more proximally true lumen. So use imaging here, for example, in this case, is used to both identify the proximal cap and to also confirm that we secured both the branches. That's the final result. Okay. Here's another case that we did in Delhi, father of a cardiac surgeon. And lo and behold, already had bypass surgery, RCA CTO, appropriate indication, refractory angina, good medical therapy. And of course, it's a double CTO with the PDA occluded as well as the RCA occluded. Cross without much effort. Initial wiring was unsuccessful. I really did want to try and go true to true here into the RCA, but unsuccessful. That didn't work. That's a tenting. That's probably where the graft is anastomosed. Knuckle, advanced, all the way back, and then it ended up being a reverse card. The plan was to just bail out and get the PL as a separate stick or as a separate retrograde option. So once this was done, thankfully, miraculously, it stayed open. So it's kind of a, sometimes, God is kind and you just take what you get, run with it. Timmy 3 flow, great answer. You got both branches. So the key, really, one of the key tips that I want to emphasize on, especially in India, is knuckles tend to stay in the architecture of the vessel, whether it's antegrade or retrograde, as you saw in the last couple of cases. Do not advance gear without knowing the wire position. That's a very important thing. So this was, again, maybe 2 or 3 years ago in Chennai. This is a Circ CTO. There's a dual lumen catheter to even enter into the epicardial collateral, SU03 to cross the collateral, unfavorable angle of exit. There's a safety wire placed, and then there's a retrograde Carlino. Using the dissections, was able to puncture antegrade, and here's the final result. And the whole point of doing this case was not about the epicardial collateral, but what I want to emphasize is that crossing the CTO can mean using a lot of strategies and using them judiciously. These include knuckling, Carlino, and other strategies. Here's another, this is a case from actually in China. Anatomic ambiguity, retrograde knuckle. It's going in some weird area. Just not sure. Retrograde Carlino showed the course of the vessel. So once this was done, used an antegrade knuckle, got in, and then there was a guide extension reverse card. So not a big deal. This was done. And here's the final result. So really what I want to emphasize on is, have a low threshold for using imaging, IVUS especially, to identify cap, branches, etc. Before you advance gear, make sure you know where you are so that you don't create a huge perf. Understand what it means, when we talk about dance, etc. And most importantly, use the knuckle. It can save you many, many times. Thank you very much for your attention.
Hello, I'm Dr. Prakash Sansgiri. I would like to thank the organizers for inviting me to speak on this new exciting topic, the use of SGLT2 inhibitors in patients hospitalized for acute decompensated heart failure. Before we proceed further, I think it's better to define what is acute heart failure. We basically divide it into de novo heart failure, where this is the first episode of heart failure, and it is usually related to sudden increase in intracardiac filling pressures or myocardial dysfunction. Commonly seen in acute coronary syndromes, accelerated hypertension, viral myocarditis, toxic cardiomyopathy, pericardium cardiomyopathy, Takashubo or thyroid storm or arrhythmogenic cardiomyopathy. And that presents as pulmonary edema or cardiogenic shock. Now, this is the first episode of heart failure, but after some time, it can lead to what is known as acute decompensated heart failure, where the primary problem is a dysregulated neurohormonal compensatory mechanism. And this results in congestion and fluid retention with weight gain, exertional dyspnea, orthopnea, and dependent edema. It's important to know that the treatment of these two is variable, because the treatment of the de novo heart failure primarily at the initial stages is treatment of the primary pathology. Going further, it is important for us to realize that heart failure carries a very high risk. On the left-hand side, you can see the risk related to atherosclerotic cardiovascular disease. And we can see that the maximum risk, even in the very high risk group, is about 7% per year. That's for myocardial infarction and stroke. However, if you see the risk of heart failure related to hospitalization or worsening of heart failure, what we call as acute decompensated heart failure, the risk for death as well as rehospitalization is up to 40%. Even in the so-called stable heart failures, the risk is 10, which is much more than that what you get for cardiovascular disease. So it is important that this aspect of heart failure is not neglected. There is no such entity as a stable heart failure. I think it's better to call it heart failure in remission, because once there is an acute event, what happens is the patient deteriorates, treatment improves, but never comes back to normal. So what it means that very often, with every event, you get a deterioration in the condition, a deterioration in the myocardial function, which eventually leads to death. So the best way to prevent this downfall is to see that these episodes of acute decompensated heart failure are appropriately treated and do not recur again. That means there are no further episodes of decompensation. That's the best way to manage these patients. And that is what we're going to talk about today. This is from the Indian study, the Trivandrum Heart Failure Registry. And it shows that if these people are readmitted again and again, then mortality is much more than if there's no readmission. Similarly, what it has also shown is that if you give suboptimal treatment, the mortality is much higher as compared to guideline-based medical therapy. So even in our country where the treatment does not reach everyone, basically if you give proper therapy, we reduce the mortality rate in these patients. As you see here, 4 to 6% in hospital mortality when there's acute heart failure. Post-discharge, 10 to 30% in the first 3 months, and thereafter, up to 5 years, up to 40 to 50% mortality. We need to stop it at this level of acute heart failure by giving the best possible therapy. A case history. 59-year-old male patient, hypertension, past myocardial infarction, complaints of orthopnea, fatigue, dyspnea, and exertion over 1 year. He presents to the ER with a blood pressure of 120/80, ECG acute old enterocephalomai, no acute coronary syndrome, no arrhythmias. 2D echo done in the ER shows ejection fraction of 35% with a lowered GLS and normal E/E' ratio. Patient is hospitalized in the intensive care unit. and stabilized over 4 days. After medication, the NT-proBNP falls, urine output increases, and patient is eventually stabilized with a stable eGFR and normal sodium and potassium levels. He is then transferred from intravenous loop diuretic therapy to oral diuretic therapy. So is that the patient is now getting ready to be discharged, very stable, receiving torsemide 20 milligram orally, metoprolol 25 milligram orally. Now, is this therapy which has been given to the patient adequate? That's the topic of discussion today. And this is a patient with acute decompensated heart failure. We know from the ESC HFA guidelines that these 4 drugs, the 4 foundation therapies of heart failure, beta blockers, SGLT2 inhibitors, ACE/ARBs or ARNI, and MRAs should be given to all patients. And this is on the basis of multiple randomized trial where they have shown that all these drugs are beneficial and together give the maximum benefit in reducing mortality, reducing morbidity, improving the quality of life, as well as reducing heart failure hospitalizations. SGLT2 inhibitors are the new people in the field, and they are beneficial in acute decompensated heart failure because they help in preload reduction, they increase the free water clearance, reduce the pulmonary vascular pressures, and reduce the intragranular pressure. Their benefit in the myocardium is related to the metabolic efficiency, better diastolic relaxation, and improving the oxygen uptake and utilization. In the long run, they also benefit LV remodeling and fibrosis. As far as afterload reduction, they improve the endothelial function and decrease vascular stiffness and decrease neurohormonal stimulation. So all in all, SGLT2 inhibitors have been shown to benefit preload, afterload, and help the myocardium, therefore improving the cardiac structure and function in these patients. Emperor Reduced trial was a landmark trial. And the most important thing which I want to stress is that the benefit of giving empagliflozin in these people with heart failure, with reduced ejection fraction, but relatively stable patient was that the benefit came as early as 12 days. Similarly, at 34 days, statistically significant benefit vis-a-vis placebo. This is to say that we know that the greatest mortality for heart failure patients is in the early phase. And giving this drug to these patients in the early phase at the time of hospitalization will be much more beneficial in reducing the mortality and reducing heart failure hospitalizations. A trial was conducted. I should call this more like a pilot study. It was called the EMPA Response HF study. In this study, 80 patients with acute decompensated heart failure with or without diabetes were studied. They were giving empagliflozin versus placebo. And randomization was done within 24 hours of presentation. That is, some of them had not even stabilized. The primary endpoints were not significantly benefited. But the secondary endpoints of risk reduction was definitely benefited. That would mean that as compared to placebo, worsening of heart failure in hospital, death or heart failure at 30 days, death of heart failure at 60 days, and worsening of heart failure at 60 days, or all the composite secondary endpoints were much better in the empagliflozin group as compared to the placebo. So, though the primary endpoints, that is improvement of dyspnea, diuretic response, change in NT-proBNP was not significantly benefit, this gave us an idea that empagliflozin benefits acute heart failure. So as a consequence of that, now this was in 2020, okay, published in 2020. Another trial was, it is not published, but it was presented at AHA. This was, and later on published in 2021 in the European Journal of Heart Failure. This was an EMPULSE trial. In EMPULSE trial, 530 patients with acute heart failure randomized between day 1 to day 5 to empagliflozin and placebo and followed up to 90 days. The endpoints which were just was death, number of heart failure events, time to first heart failure event, and the quality of life. And all these were assessed over a period of 90 days in these patients. It was important that these people were definitely heart failure, and they should have had dyspnea at rest or on minimum exertion, signs of decompensation, at least 2 of them, seen in the patient at the time of enrollment. Inclusion criteria were those people with heart failure, acute decompensated heart failure or de novo heart failure. And this was regardless of whether the person had heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, or heart failure with preserved ejection fraction. Patients were first stabilized, and the stabilization criteria mentioned that first and foremost, the systolic BP was over 100, no symptoms hypotension, no increase in IV dose of diuretic for 6 hours, no IV vasodilators for last 6 hours, and no inotropes for 24 hours prior to randomization. And after randomization, between 1 to 5 days, the patients were assessed. It was found whether there was an abnormal NT-proBNP, and the minimum dose of diuretics required was 40 milligrams of furosemide. Patients in cardiogenic shock, those people with acute MI, pulmonary embolism, acute coronary syndrome, previous stroke, TIA within 90 days, or a eGFR of less than 20, and type 1 diabetes, they were not included in the study. Interestingly, it was found that the all-cause mortality was significantly less in the empagliflozin group as compared to the placebo group. Heart failure events were much less in the EMPA group as compared to the placebo group. The quality of life at 90 days was better. Unplanned visits or heart failure visits to the hospital were much less. Now, this was a good indication that empagliflozin is a treatment option in acute heart failure soon after stabilization, and it reduces all the causes of mortality, repeated heart failure events, improves quality of life, few adverse events, and benefits all the 3 types of heart failure which we know about. So this is the takeaway from this EMPULSE trial, which was there in heart failure patients, acute heart failure patients. It is also interesting to note that adding empagliflozin to AC inhibitors is definitely better, whether even with the full higher dose or the lower dose. To beta blocker, it is beneficial. To MR, it is beneficial. And as well as you can see, to various combinations, empagliflozin added is definitely beneficial as compared to placebo. So it's a great drug to be treat patients with heart failure. Coming back to how we should be starting the drugs. The old conventional sequencing was start AC inhibitor ARB, add a beta blocker, MRA, and later on, if the benefit of AC ARB is not there, then you can add ARNI. You're losing a lot of time. It takes up to 6 months to titrate in these people if you go by conventional sequencing. But we know the maximum benefits are there when the patients are treated early. So what we have is a new sequencing event, the rapid sequencing. Start with the beta blocker SGLT2 inhibitor. Now, this is as per the European Society of Cardiology Heart Failure Association guidelines. So initially start with beta blocker SGLT2 inhibitor. After that, you can add ARNI and thereafter MRA. Regularly monitor 2D echo, eGFR, creatinine, and electrolytes in all patients. As I mentioned, it's a 3-step approach. Why beta blockers? Most effective and rapidly acting option to prevent sudden cardiac death and arrhythmias, and definitely help particularly remodeling in the long run. SGLT2 inhibitors, early osmotic diuretics, nephroprotection, ensure to it that the eGFR is more than 30 when you're starting DAPA, and the eGFR is more than 20 when you're starting EMPA. Eventually, at the moment of, we don't require some specialized monitoring when we start SGLT2 inhibitors. It's a single dose which has to be started and continued thereafter. Step 3 is introduction of Step 2 rather is an introduction of ANI. ANI is a great drug and should be given to all the patients who have got a heart failure with reduced ejection fraction. It has been shown to be beneficial when started, eventually when the patient is in hospital. And the third step is adding MRAs. MRAs, you have to be very careful because it can worsen kidney function, it can cause hyperkalemia. You need to closely monitor. There is no significant reduction of blood pressure, but you have to monitor when you introduce MRAs. So we have 4 drugs in 4 weeks. ARNI, 3 stages we have to do. Beta blockers 4, MRAs 2, SGLT inhibitors like empagliflozin, only 1 single dose to be continued. If you want to do it all these 4 days, you can understand that you get the benefit rapidly, you get the benefit for the patient in every way possible. Why start in hospital? In hospital, more likely to be treated, more likely to be tolerated, more likely to be getting the prescription right, more likely subsequently to adhere to treatment, more likely to persist, more likely to feel better, and more likely to be at home and likely to survive after giving all these 4 drugs in the first 4 weeks. The maintenance of this quadruple therapy is important. One may add or subtract depending upon the need, depending upon the EGFR, depending upon the blood pressure. A question which is commonly asked, can we start SGLT2 inhibitors in acute MI? The answer to this will come out in the next few trials with empagliflozin, which is there. Then you have got with dapagliflozin, which is coming up soon. You have got multiple trials coming. And these trials like DAPA-EMA, EMPACT-EMA, all these trials will eventually, in the next few years, give us an idea whether SGLT2 inhibitors can be used in acute myocardial infarction. So, this is a very beautiful slide which shows that when the blood pressure is more than 85 or equal to 85, you cannot start most of these drugs. Carvedilol can be given if the BP is more than 90 as per the IMPACT-HF trial. If the BP is more than 100, yes, you can start ARNI, empagliflozin, sotagliflozin. Now, this is before discharge. After discharge, yes, you can start ARNI, Vesiguard, and you can start Omnicart. Keeping all this in mind, what it means is starting these drugs early can be possible when the person is hospitalized, even if the blood pressure is low. You do it, you monitor it, and accordingly titrate the doses as per the patient's needs. The story is not over yet in the war against heart failure. It can only be won with pragmatic, deliberate, and scientific implementation of data, overcoming the inertia of prescription. Yes, we have some misgivings about starting all the 4 drugs. Please understand, giving all the 4 drugs together is the best option, and it is a new standard of care for patients with heart failure with reduced ejection fraction. Thank you very much for your attention.
Show Ahmedabad. My name is Dr. Rajiv Sankanarayanan. I'm a heart failure cardiologist from Liverpool, United Kingdom. Thank you to Dr. Kamal Sharma for inviting me to talk to you all about a newer device therapy for heart failure. I shall be talking to you about cardiac contractility modulation and baroreceptor activation therapy. These are my disclosure slides. So I shall be telling you why we need alternative or novel device therapy in heart failure. I shall start off with the role of cardiac contractility modulation, baroreceptor activation therapy or BAT. I'm sorry, I did not want to mention coronavirus, but I will be talking about BAT today. And also go through the current evidence and future directions. So if you look at the background, heart failure has a significant morbidity and mortality. There are around 26 million people with heart failure worldwide, we think. And of these, the vast majority, 80 to 85% of patients with heart failure are not suitable for device therapy such as CRT. And of those who receive CRT, up to a third are non-responders. So they don't feel any better even after CRT. There is therefore a need for novel device therapies, particularly for the above cohort. And of these, CCM, which is cardiac contractility modulation, and baroreceptor activation therapy, are two such new therapies. So we'll start with CCM first. So what is cardiac contractility modulation? So this involves delivery of precisely timed energy pulses to the heart. And this is through application of relatively high voltage, so 7.5 volt, and this is around 10 to 15 times or more than the traditional pacemaker impulses. Long duration, about 20 milliseconds, of biphasic electrical signals, which are applied to the right ventricular septal wall during the absolute myocardial refractory period. This device actually received FDA approval in 2019. And this schema represents the signals. So we can see that the signals are biphasic. They are relatively high voltage, like I mentioned. I mentioned the duration of 20 milliseconds and the fact that the signals are non-excitatory because they're applied during the absolute refractory period, as we can see. So the schema also shows us the artifact on the ECG trace through application of the CCM signal. And this schema also shows us what the device involves. So it is a rechargeable implanted pulse generator, and this can be rechargeable, and that extends the battery life to well more than 5 years. So the need for device changes is minimized. And like I said, the CCM signal is applied during the absolute refractory period. And this is standard pacing leads. Now, the first version of this, the first prototype of this, used the atrial lead for sensing. But the newer versions, as I'll come to, have actually removed the need for atrial sensing leads. So it is mainly the two ventricular leads, one of which is for sensing, the other is to deliver the impulse. Now, the biological effect of these stimuli is seen very rapidly in the region of signal applications. And these translate ultimately to improved peak VO2, improved symptomatic status, and reduced heart failure hospitalizations. The other biological effects are also seen remotely over time. As I mentioned, the two right ventricular septal leads, one for sensing and the other for CCM delivery. And how do the signals produce their beneficial effects? They affect the biology of failing myocardial genes. The heart failure the heart failure genetic phenotype starts to appear like the fetal heart genes. And what CCM does, it restore it to the adult functioning heart genotype. And so this is in terms of the genes, but also it affects proteins and phosphorylation, and this translates to improved function, ultimately to increased contractility, and all these are achieved without an increase in myocardial oxygen consumption. This slide shows us some of the effects of CCM seen in terms of LV reverse remodeling, and this has been demonstrated by 3D echo studies both in animals but also in humans, seeing that the beneficial effects on reverse remodeling are seen within 3 months of initiating the CCM therapy. I mentioned a bit about the timing of effects. So the rapid effects are seen within minutes or hours, and this involves local electrotonic spread of the signal, rapid phosphorylation of the key proteins, the contractile proteins involved in calcium signaling. So this leads to improved calcium cycling and contractile force, and all this without increased myocardial oxygen demand. Some of the intermediate effects, these take hours to weeks, and this, like I said, there's a shift of the gene program from the heart failure or the fetal type to normal, and these local effects improve contraction at a global level. And there are longer term effects taking weeks to months, and these translate to beneficial effect on global ventricular properties as well as reverse remodeling. What is the impact of CCM and how is this achieved? And this is through multivarious effects. So like I said, it improves intracellular calcium metabolism, improves diastolic calcium levels, and this ultimately leads to phosphorylation of myofilaments, increased small heat shock protein, tighten phosphorylation and distensibility is increased. So these improve the contractile properties of the heart. These also CCM also leads to reduced oxidative stress, reduce cardiac fibrosis, and reduce sympathetic nerve activity. And these ultimately lead to improved systolic reserve and diastolic filling and improved quality of life and symptoms. And these are some of the clinical trials. Quite a few of these were done many years back. This goes back to more than 5 years back. But if what we'll do is we'll focus on the phase 3 trials, and that is looking at the FIX-HF trials in the fixed HF5C, which are more recent. But in total, over or nearly 1,600 patients with heart failure have been studied as of date, and there are currently several other trials as well, looking at the role of CCM in patients with HFpEF and in combination with ICD therapy as well. So as I said, we'll look at the landmark fixed HF randomized control trial, which studied CCM. So this compares the control and the active arms, and we're looking more at the fixed HF confirmatory trial, which followed the fixed HF trial itself. So this included adult patients, and because the fixed HF trial showed that the benefit was largely seen in patients with an ejection fraction of 25 to 45%. This was estimated by echocardiography. So this trial looked predominantly at this cohort of patients. These were well treated and on optimal medical therapy. It is important to also look at some of the exclusion criteria. And this includes if their baseline peak VO2 is less than 9 or more than 20, if there is a correctable cause of heart failure. This could be valvular, this could be congenital, this could be if the patient is awaiting a bypass or PCI, or also if they already have CRT in situ. Patients on inotropic support were excluded. Those with a large ventricular ectopic burden or who might have a pacing requirement, that is, if they have a PR interval which is quite prolonged, were excluded. Also important to remember that this trial excluded patients with persistent or permanent atrial fibrillation. Obviously, patients whose exercise tolerance is limited by condition other than heart failure were also excluded, because exercise tolerance is one of the outcome measures for this trial. Those with an MI within 90 days of enrollment, those with the previous heart transplant, ongoing dialysis, or mechanical tricuspid valve, because these leads are put in across the tricuspid valve, like a traditional RV lead for a pacemaker, a Brady pacing. So the primary outcome measure was very impressive. CCM, or cardiac contractility modulation, significantly improves the peak VO2. And these are some of the secondary outcome measures, but not less in importance. So we want our patients to feel better, live longer, and stay out of hospital. And these outcome measures looked at the quality of life, so significant benefits seen in the CCM group, and also looked at improving NYHA class. So we can see that the CCM group had a 60%, close to 60% improvement in the NYHA class. And this is another secondary outcome measure, and this looked at the composite of cardiovascular death and heart failure hospitalizations. And we can see that in the CCM arm, the Kaplan-Meier curve shows that the CCM arm diverges from the control arm close to about 2 months. So around that time, we can start to see a significant benefit in terms of reduced cardiovascular death and heart failure hospitalizations. So what is the current evidence for cardiac contractility modulation? So the patients who have ongoing NYHA class 3 and some studies have also included ambulatory class 4, and this is despite optimal medical therapy. Those with narrow QRS, so those who don't have left bundle branch block would traditionally benefit from CRT. Ejection fraction between 25 to 45%. So this includes HFrEF, but also some patients with heart failure with mildly reduced ejection fraction. And like I said, there are ongoing studies looking at benefits in heart failure with preserved ejection fraction. We await those in the next year or two. And it's important that at the moment the evidence is restricted to those with sinus rhythm, but we don't know if the effects translate to those with AF at the moment. So that needs further evidence to be generated. So this is a flow chart which shows this. So essentially, we have a large cohort of patients who don't have left bundle branch block morphology, and even in those with left bundle branch block, the evidence is restricted to benefit seen in those with a QRS duration of more than 120 milliseconds. 130 milliseconds. So there is a large cohort of patients who, if they have ongoing symptoms despite guideline-directed medical therapy, who could be suitable for CCM, and this could be with ICD therapy as well. But we also have a cohort of patients who have had cardiac resynchronization therapy, but have to have ongoing continued symptoms of NYHA class 3 or ambulatory class 4, who can be considered for CCM as well. And what does the future hold for CCM? Like I said, combining CCM with ICD therapy is something that we could see a lot more in the future. And we await evidence for the benefit in heart failure with preserved ejection fraction. There are ongoing trials, like I mentioned. So now let's move to the other novel device therapy, which is baroreceptor activation therapy, or PAT. And this works on the premise of carotid baroreceptor stimulation. And what does that lead to? That leads to inhibition of sympathetic activity, and we see a sympathetic overdrive in heart failure, which is seen as a compensatory mechanism. So this methodology basically leads to enhanced parasympathetic activity and reduction in sympathetic activity. And what are the physiological effects that we see on the heart and elsewhere? We see a reduction in heart rate. So these effects are comparable to that seen due to beta blockers, for example, but also other heart failure prognostic therapies. So improved effects on remodeling, increased vasodilatation, effect on lowering blood pressure, improved diuresis, reduced renal secretion. And this is the actual device itself. So this is the carotid sinus lead, which is a 2mm electrode, 7mm silicon backer with a unipolar design. So this is the device. Again, it's an implantable generator, which has a 4 to 5 year longevity. So in terms of the lead itself, it is the function of the device is the location is around the carotid sinus, basically, and that is to achieve carotid baroreceptor stimulation. And like I said, these are some of the effects, and that those effects are achieved through a reduction in sympathetic activity, but also due to an increase in parasympathetic activity. And this is the programmer we can see for our programming, but also telemetry signals. So I'll focus in the next few slides looking at the BEAT-HF, which is a phase 3 multi-center randomized control trial, which demonstrated both safety and efficacy of this device therapy. So what were the key eligibility criteria for patients included in this RCT? Patients with predominantly NYHA class 3, smaller proportion of patients had class 2 and also recently class 3. This included patients with severely impaired LV systolic function, left ventricular ejection fraction of less than 35%, who've had a 6-minute hall walk distance of 150 to 400 meters, elevated NT-proBNP or previous heart failure hospitalizations. Looking at those, these are on stable optimal medical therapy, those traditionally who would not have been suited for CRT. And important distinction between this trial and those where we studied CCM was that this trial included patients with atrial fibrillation and also those who had implanted ICDs. So this is looking at the baseline demographics between the baroreceptor autonomic therapy versus control group, and we can see that they're largely representative of the heart failure population that we see. Slightly younger population, perhaps. Patients with a mean age of around early 60s in both arms. Definitely significant underrepresentation of women, and again Caucasian predominance. Majority, like I said, NYHA class 3. Some of the other physiological parameters are were definitely comparable. Heart rate perhaps could have been better controlled in both arms. LVEF comparable, 27 and 28%, so significantly impaired left ventricular systolic function. Elevated NT-proBNP, preserved renal function in both arms. About 30 to 43% of patients had atrial fibrillation in this study, and a significant proportion, close to 50% in both arms, had previous heart failure hospitalization. Now this slide is quite remarkable. It compares the use of baseline therapies. So this was a very, very well treated population, a large proportion of patients who were on ACE or ARNI, so 90% or above on beta blockers, 50% on MRA in both arms, well treated diuretic with diuretics. And again, this is quite important to note, close to 80% of patients in both arms had implanted ICDs. So if we look at the symptomatic improvement, so these were the different outcome measures. So if we start from the left side of the screen. So we're looking at improvement in quality of life. There was significant improvement in quality of life through use of baroreceptor autonomic therapy. This led to improvement in exercise capacity as well, and this translated through improvement in NYHA class. And we can also see that this trial, and this is comparable to Paradigm HF, which showed that even a 10% reduction in NT-proBNP leads to significant reduction of cardiovascular death and heart failure hospitalizations. This trial actually showed that there was a 25% reduction through use of BAT. Safety, the device was well tolerated with no significant events, and received FDA approval also in 2019. So if we look at the composite evidence for both device therapies, the current evidence is largely for HFrEF, particularly in patients who are not suitable for CRT, or this could be for CRT non-responders. CCM, there was some benefit seen in patients with heart failure with mildly reduced ejection fraction as well. And like I said, there are ongoing trials for CCM looking at the role in heart failure with preserved ejection fraction. There is not yet evidence for CCM in patients with AF. However, the trials for BAT, or baroreceptor activation therapy, have shown that the evidence extends to those with atrial fibrillation as well. So it's important we keep trying novel solutions for heart failure. I'd like to end sharing something that we'd like to learn from one of my favorite recent series, which is Patal Lok. And this is not just so some of these things that we see, the novel therapies, are not something that's just WhatsApp video pada tha. It's important that we keep trying some of these novel solutions. Like I said, a large proportion of heart failure patients are not suitable for conventional device therapy like CRT. So CCM and BAT could be the jugaad for this proportion of patients. Thank you very much.
Thank you, Dr. Kamal Sharma and team, for having me here to speak on the topic of localization of pathways. I would stick to the basics of narrow complex tachycardia and localization of the tachycardia based on tachycardia ECG. The first step is to differentiate between AVNRT and AVRT based on the P-wave morphology, QRS alternance, STT changes. Then you can localize the pathway site based on the P-wave morphology and the STT changes. And based on sinus rhythm ECG, the pre-excitation, when you can localize the pathway. So step one would be first to differentiate in a AVNRT and AVRT in a narrow complex tachycardia. Step two would be locate P waves and localize based on it. Step three would be location based on STT changes. And once the sinus rhythm is achieved and there is pre-excitation, step four would be localization based on pre-excitation. So how to differentiate between AVNRT and AVRT? AVNRT, the ECG shows R prime in V1 and pseudo SN inferior leads. That is because of the retrograde P waves in the terminal part of the QRS. The rate is generally of 150 to 200. The P waves, if seen, are negative in inferior leads, and 1-to-1 AV relationship is not mandatory. While in AVRT, STT changes are present because possibly of P waves falling on the T waves. QRS alternance may be seen, the rate is faster. And if seen separately, P-wave morphology can help in localization. 1:1 relationship is mandatory. AVNRT is basically from the AV junctional area where there is a slow pathway and a fast pathway, and a typical AVNRT is a slow fast AVNRT. Here the P-wave overlaps with the QRS complex and as activated at the same time. So therefore you may not see P-waves at all the time, or if it is present, it is in the just at the terminal portion of the QRS as R prime and V1 and pseudo SN inferior leads. So seeing this tachycardia ECG, you see this R prime and you see the S waves in 2,3 AVF. When the tachycardia terminates after carotid sinus massage, you don't see this R prime and the pseudo S waves. So therefore, this becomes a typical AVNRT. So comparison between the two same, R prime which is present and the pseudo S which is present in this patient is not there. This is typical of a typical AVNRT. What about AVRTs or related to WPW? They are generally short RP tachycardia most of the times. P waves are separate from the QRS on either the ST segment, which causes the STT changes, or they can be on the T waves causing a T wave notch, or a separate P wave may be seen differently. So there is a pathway separately other than the AV node. It's an orthodromic AVRT resulting in a narrow QRS. So antegrade goes via the AV node, retrograde goes via the pathway, and this completes the circuit. So let us see this tachycardia ECG here. Narrow complex fast tachycardia. You can see QRS alternance, there's no R prime, but there is a notch on the T wave if you can see, but the P wave is not very well appreciated. QRS alternance is here also, and therefore likely to be AVRT. The tachycardia when terminates shows a baseline short PR interval with pre-excitation, R wave being positive in V1, therefore suggests WPW. So what about the tachycardias with accessory pathways? It can be orthodromic tachycardia, which we commonly see, or it can be antidromic or a bystander. So we'll discuss more about orthodromic tachycardia. It is generally re-entry associated with WPW. There are other forms with their antidromic tachycardia like MAHEM and a PJRT, which is a slow kind of retrograde conducting pathway. So important is the ventricle forms a part of the circuit. The ventricle is a part of a circuit. So the step 2 is when you can see the P wave morphology. Now here in this tachycardia, it's a narrow complex tachycardia, and you can see that this P wave is inverted into 3 AVF, which is causing the ST segment to be there, and there is a bump in the T wave, which is possibly positive. So if you have this kind, it is suggesting that the P wave is retrograde, coming from the inferior area, and therefore is likely to be an inferior pathway. Based on the STT changes, if you have significant STT changes in the inferolateral leads, that means the P wave is somewhere there, and therefore the pathway is likely to be in the infralateral area, maybe the left lateral or left posterolateral. In a long RP tachycardia where the P wave is separately seen, here you can see a slow tachycardia ongoing, but the P wave morphology is 2,3 AVF is negative and V1 is actually positive, suggesting that it is arising from near the AV nodal region and likely to be a PJRT, a long AV tachycardia. To confirm this, a carotid sinus massage terminating the tachycardia suggests that it's a AV nodal dependent tachycardia. Now coming to the last step, that is localization based on the sinus rhythm, pre-excitation as a must. Either it's a left-sided or a right-sided arrhythmia, and the differentiation between the areas is as mentioned in this figure, but we'll go with the localization. Most commonly is in the left lateral region and then goes to the posterior, then right side and the anterior region. So the WPW ECG characteristics as shown in the ECG are short PR interval in sinus rhythm, QRS being wide, more than 120 milliseconds, a delta wave which is a slur in the start of the QRS, and STT changes are present because of secondary QRS widening. The localization based on ECG, the presence of pre-excitation is a must. Algorithms from 1945 by Rosenbaum et al. To right now, there are many algorithms. The limitations are inter-observer variation and non-producible results by independent different studies. You need to have a good amount of pre-excitation, and the QRS should be more than 120 milliseconds. Initial delta wave of 20 to 40 milliseconds is a must. There may be difficulty if there is an isoelectric start, or defining the morphology is difficult. If there are multiple pathways in structural heart disease, it becomes difficult to localize. So let us see the basic types of localization. So Rosenbaum in 1945 had the seminal paper showing the types of pre-excitation. So in short, if you have a positive R wave in V1, that is RBBB, it's a left-sided pre-excitation. And if you have a LBBB in V1, then it is a right-sided pre-excitation. Inferior leads negative, that means it's a posterior pathway, and inferior leads positive means it is an anterior pathway. Then came the Milstein algorithm, then is the Aruda algorithm, and many other algorithms being there. But I would like to discuss this algorithm for localization, which was given by Pamberg and Hassegray et al. And the step 1 remains the same. If V1 is positive, it's mitral annulus, V1 negative, tricuspid annulus. If you have V1 which is positive and you think it's a left-sided, then step 2 would be how many inferior leads are positive. More number positive, that is all three positive, 2-3 AVF, then it becomes a superior placed or left lateral pathway. If there are one or two which are negative, then it becomes a posterolateral area, and if all are negative, it becomes a posteroseptal or a posterior pathway. To differentiate between posterior, lateral and a posteroseptal pathway, the ratio of V1 to 1 is important. If V1 is taller than lead 1, that is the ratio is more than 1, it is a posterolateral pathway. If the V1 by lead 1 R wave ratio is less than 1, it becomes a posteroseptal pathway. And if there is a notch in the descending limb of lead 2, then it may be a deep cardiac pathway. So carotid coronary sinus pathway. Going to the right side, the tricuspid annulus, if V1 is negative, then you go to this again the inferior leads, 3 positive showing that it's a right anterior or a right anteroseptal, 1 or 2 positive right lateral or right septal, and all 3 negative means right posterior or posteroseptal. How do you differentiate between these? Septal versus the lateral is where the transition is. If the transition is in V2, then it is likely to be septal. If the transition is V3 and more, then it is likely to be a lateral pathway. So this helps us localize the pathway when there is pre-excitation. So let us share some examples. Step 1, V1 positive, left side, then step 2, 2-3 AVF positive. That means it's a left lateral pathway. If 1 in AVL is negative, that means it's a left high lateral pathway. Again, pre-excitation, V1 positive, V2, so all 3 are positive here, again left lateral, but here 1 and AVL are towards more positive, and therefore it becomes a total left lateral rather than a high lateral pathway. Again V1 positive, and here you can see that 2-3 AVF are equiphasic, they're not totally positive, while 1 is positive. You can see that this is a left posterolateral pathway. Here the lead V1 is more positive as compared to lead 1, and therefore a left posterolateral pathway. Again V1 positive, but 2-3 AVF being negative, so it becomes the posterior region, and here the ratio of lead 1, so 1 is more positive as compared to V1, and therefore becomes a left posteroseptal pathway. The next is a V1 positive, and what you see again is 2-3 AVF negative, so left posterior. 1 is taller than lead V1, and therefore it is a left posteroseptal, but there is a notch in the descending limb of lead 2, suggesting that this is a left-sided pathway. However, it can be in the deep coronary sinus. When V1 is negative, then you see for 2-3 AVF, and all 3 are negative here, suggests that this is a left posterior pathway. The transition being in lead V2, therefore it becomes a left posteroseptal pathway. Again here the pre-excitation, V1 is negative, the step 2 would be 2-3 AVF, so here only 2 is positive, but 3 and AVF is negative, therefore it's likely to be left posterior, and the transition is basically in more than V3, V4, so left postero or left lateral pathway. Here the step 1, V1 is negative, then we go to 2-3 AVF, which is positive, and once you see that this is positive, it becomes a right anterior pathway, and the transition is in V3, so it becomes a right anterolateral anteroseptal pathway. So based on these, tachycardia ECG helps to differentiate AVNRT from AVRT. P waves and STT changes, if seen, can localize the pathway. Pre-excitation on sinus rhythm localizes the pathway, and localization of pathway helps while doing an EP study and RF ablation. Thank you for your patient listening.
Thank you, Kamal sir, for giving me an opportunity to present on this platform. My talk would be a quick 5-minute run through the topic of localization of ventricular tachycardia, or PVCs, premature ventricular complexes. Ventricular tachycardia is characterized as a wide, complex tachyarrhythmia at a rate greater than 100 beats per minute. It is classified as by duration as non-sustained or sustained. Individually, each of these QRS complexes of a ventricular tachycardia are known as a PVC or a premature ventricular complex. In the successive slides, PVC will be used instead of VT. There are a lot of algorithms out there to help us predict the origin of PVCs, but male instincts took over and few guys completed the mammoth task of super simplifying the pathway for localization of PVCs. What they did is that they described a posterior view of the heart. In this description, the atria are cut out and the intercavitary structures of the ventricles are seen. They have divided the heart into 4 quadrants and broadly divided the PVCs into those with superior axis and those with an inferior axis. Inferiorly directed PVCs have positive reflections in leads 2, 3 AVF, while superiorly directed PVCs have negative reflections in the same leads. Few PVCs show inferior lead discordance, which have also been discussed. The PVCs originating in the upper quadrants record a positive reflection in the inferior leads. AVR and AVL, which are superior leads, also show a negative reflection because of the vectors directed away from them. The PVCs originating from the upper quadrant were further divided into a left-sided or right-sided originating PVCs. The right-sided PVCs have a positive reflection in lead 1, while the left-sided PVCs have a negative reflection. This gaudy picture best demonstrates the overlapping anatomy of the outflow tract. It's important to remember that all RV structures are not right-sided and all LV structures are not left-sided. As depicted by the mummy, the left arm represents the old LVOT, which starts on the left and is directed towards the right. The right arm represents the RVOT, which starts on the right, is anterior and directed to the left. This arrangement makes the pulmonary valve the most anterior and superior structure. The non-coronary cusp is the most inferior structure, while the right coronary cusp is the posterior most structure. Excuse me. In the left upper quadrant, picture the outflow tract and mitral valve in an anterior-posterior fashion and correlate the arrhythmia origin with the characteristic ECG morphology in lead V1. Since lead V1 is an anterior lead, the anterior-most structure like the anterior RVOT results in a typical left bundle branch block morphology. More posteriorly, like the region of left coronary cusp or iotomitral continuity origin is characterized on the ECG with a distinct R wave in lead V1. Finally, even more posterior and leftward, like the posterior mitral annulus, will have a clear right bundle branch block morphology. The PVCs from LV summit are a topic on their own. They have a broader QRS morphology suggesting an epicardial origin, a V2 break, a V2 pattern break, and they can also manifest as LBB or RBB morphology. In the right upper quadrant, these 4 structures show an inferior axis and a positive lead 1. Another lead, the AVL, which is a superior and a leftward lead, will show a QS pattern for PVCs from the outflow tract, while the PVCs from the paraaxial and tricuspid valve annulus will show an isoelectric or positive reflection in lead AVL. This is because of the more inferior location of the paraaxial and the tricuspid valve annulus compared to the outflow tract. Also, the forces from the superior tricuspid valve and the paraaxial area are less pronounced than the more superior structures. Differentiation of PVCs originating from posterior RVOT and RCC is challenging. Transition at V2 or earlier suggests an RCC origin. Transition after V3 suggests an RVOT origin. If the transition occurs at V3, then the PVCs and the sinus rhythm transition is compared. If the transition of the PVC occurs later than the sinus rhythm, then the origin of that PVC is from RVOT. If the PVC transition occurs at or earlier than the sinus rhythm transition, then the so-called V2 transition is measured. The ratio of more than 0.6 predicts an LVOT origin. PVCs originating from the inferior aspect of the heart have a negative reflections in the inferior leads, and the bundle branch pattern helps us to tell whether its origin is from RV structure or an LV structure. PVCs with LBB morphology and superior axis may arise from RV structures like the inferior tricuspid valve annulus, a moderator band, or the cardiac crux. Left bundle branch block morphology PVCs may also be seen arising from the interventricular septum. PVCs with RVB morphology and a superior axis arise from LV structures, while the inferior mitral valve annulus, the left anterior fascicle, or the posterior papillary muscle. Once the quadrants are localized, the precordial transition of these PVCs suggests the likely origin. In case of PVCs with RBB morphology, the transition from positive to negative occurs early as we move from apex towards the base. In PVCs with LBB morphology, the transition from negative to a positive occurs early as we move away from the free wall towards the septum. The left quadrant structures are the inferior mitral valve annulus, the posterior papillary muscle, and the left posterior fascicle. Idiopathic PVCs can be differentiated arising from these structures on the basis of precordial lead transitions, QRS morphology, and lead V1. An RS ratio greater than 1 in V6 suggests a more basal location, which is seen in PVCs arising from the mitral valve annulus. An RS ratio less than 1 by V5 usually suggests a posterior papillary muscle or a left anterior fascicle origin of PVCs. RSR pattern and a QRS duration of less than 130 milliseconds suggests early recruitment of the His-Purkinje system seen in PVCs from LPF. Cardiac crux is an epicardial space where all 4 chambers of the heart are in closest proximity. It's also the junction of the MCV and the CS. PVCs from this area have a left superior axis and early V2 transition and features suggesting of its epicardial origin, pseudo delta or the maximal deflection index of more than 0.55. The moderator band is a free-running muscular structure extending from the anterior septum to the anterior papillary muscle of the right ventricle free wall. PVCs originating here have a left superior axis and a later than V4 transition. Tricuspid valve PVCs have variable precordial transition from V2 to V4 anywhere between these leads depending on their septal or lateral aspect of origin. The inferior lead discordants are seen in mid-cavitary structures. Two kinds of inferior lead discordance are noted. Positive negative discordance, which is a positive deflection in lead 2 and negative in lead 3. Negative positive discordance is negative in lead 2 and positive in lead 3. The positive negative discordance are seen in RV structures and interventricular septum, while negative positive discordance are seen in LV structures. The maximal deflection index is interval between the earliest ventricular activation and the maximum deflection in each precordial lead. Taking the shortest interval is divided by the QRS duration. An MDA of greater or equal to 55 milliseconds had a high sensitivity and specificity to identify an epicardial ventricular tachycardia origin in patients without structural heart disease. In summary, with the diagram kept in mind in the background, this paper easily helps to approximate a localization of a PVC origin in a structurally normal heart. The same idea can be applied to a diseased heart, but it will be approximating the exit site of the PVC. All RV structures are not right-sided and all LV structures are not left-sided. Broadly, PVCs can be divided into those with superior and those with inferior axis. Lead 1 further divides the inferiorly directed PVCs into right or left-sided origin. The bundle branch morphology and the precordial transition is useful for the superiorly directed PVCs. Inferior lead discordance and epicardial origin are additional things to remember. Thank you.
Hi, good evening, everyone. So today's talk is the Vignet on vagal nerve stimulation therapy, and this is a new emerging therapy that we are looking at. This is how the X-rays you may actually end up encountering. A patient may have an ICD, and there is another lead which you can see on the opposite side, and the lead is actually tunneled through into the neck on the vagus nerve, and this is what is a vagal nerve stimulation therapy or baroreceptor autoregulation therapy as it is known, and it is one of the recently approved therapy by US FDA in refractory heart failure. So this all started with the multiple trials. We now have a lot of data emerging for it, but the first in our part of the world was part of the Anthem study, and this is the publication that happened, and I was author and lead investigator from my center, and this was published in JACC. I was fortunate enough to do the world's first vagal nerve stimulation device implant in a refractory heart failure, and now we have recently published even 7 years follow-up and the long-term follow-up from the Anthem and CORE study. Basically, this study was to look at the improvement of LV function and heart failure symptoms, and the objective was to evaluate whether autonomic regulation therapy, also previously called as ART, with the left or the right side for the treatment of chronic symptomatic heart failure with reduced ejection fraction. Firstly, it was looking at its feasibility and tolerability. Secondly, at the primary endpoint, which was the incidence of procedure device related AEs at 9 months initially, and then it was followed up into ENCORE extension and ENCORE studies, which also looked at into the long-term follow-up up to even now 7 years follow-up. And they also assessed the efficacy outcomes in terms of LV ventricular ejection fraction and systolic volumes at 6 months. They also looked at the overall in the study into the LV and diastolic diameters, quality life as assessed by 6-minute walk distance, quality life by Minnesota Living with Heart Failure Questionnaire, functional NYHA class, heart rate variability, and biomarkers like hsCRP and NT-proBNP. These were the various sites, and I was principal investigator from the clinical site of Sanjeevani. There was Medanta, KIMS, and multiple other hospitals that were part of the study. So the trial actually, the study actually looked at the beyond consenting, the left versus right side randomization, and then there was a titration. So every follow-up, the output and the cycles were modulated and regulated for 10 weeks, and this cyclic venous therapy was then followed up for 6 months, looking at the outcomes every 3 months. So what it is, basically it is the device which has got already multiple implants, more than 1 million implants now worldwide, in epilepsy and refractory depression, where it is implanted on the left or right vagus nerve by a carotid dissection by neurosurgeons. And of course, the lead doesn't go to the RV lead. So the only thing that goes is a pectoral generator, and then it's implanted through the tunnel into the carotid artery, carotid sheath into over the carotid nerve, through that into the carotid sheath to the vagus nerve, and that's how the polarity is towards the brain in patients with refractory epilepsy. All that has been now done is the polarity is reversed, and now the current goes from the vagus nerve towards heart rather than going towards the brain. So chronic intermittent stimulation was devised with 10 hertz of 250 microsecond pulse width, with VNS intensity was titrated over weeks to maximum tolerable current below the threshold of side effects, that is alteration of voice or hiccups, which was the only side effect noted. And ECG was monitored to confirm no acute changes in the heart rate. Over time, the side effects they went off as the with the time went by. An average stimulation current was 2 to plus minus 0.6 milliampere. These are the baseline characteristics, left versus right. You can see not pretty much any major difference. Most of the patients were male. You can see that class 2 patients and class 3 patients, there were some more, almost equal amount, though slightly more in class 2. Baseline EF was around 32%. LV end systolic dimension of 51 and LV diastolic dimension of 62. So these were pretty much enlarged heart with a baseline heart rate of 78. These patients were already on beta blocker, and none of these patients previously had an ICD. The one that you saw was the later images that may be emerging. You can see that almost 100% were on beta blockers, 83% to 87% on AS or ARB. Remember, this is a pre-ARNI study. Aldosterone antagonists, digoxin, and loop diuretics were also there for the symptoms. And you can see that commonest side effect that was found was the cough or oropharyngeal pain. Otherwise, there was no local implant related infection, and unrelated events or pooled were more, but related events were not many. So primary FAC outcome, you can see that the left ventricular ejection fraction, though, did not change much in this, improved drastically by 5 to 10%. But what was most significant was the LV end systolic volume, which reduced. You can see these all values: LV end systolic volume, NYHA class, 6-minute walk test, Minnesota left heart failure questionnaire, heart rate variability, heart rate drop by 3 to 4 beats, and NT-proBNP was not significant, but CRP values were significantly reduced. So to conclude, Anthem HF approach to ART on either side, left or right, was feasible, well tolerated, not any safety concern, with improvement in the cardiac function and heart failure symptoms, and further investigation in a controlled study was recommended. And then it came, Anthem HF was followed up with Anthem, followed by Anthem long-term follow-up, and then came ENCORE, and then ENCORE extension, and we all have published these multiple papers. But what has happened is now this is another device, not the same device, which has got FDA approval for its trial that has been done in the US and the other part of the world. So this is Barostim device, which is actually approved for the same therapy in patients who have refractory heart failure, who have narrow complex, who are not eligible, or CRT, or who are symptomatic despite ICD or CRT. Those patients were only eligible. And narrow complex patients, this is the proposed new algorithm. Of course, it's not something that's been implemented yet, but you can see that anybody who's got narrow QRS and ICD is already done, and patients still remain symptomatic in class 3, these are the patients you can consider for BAT, that is autoregulation, baroreceptor autoregulation treatment. So it can be with or without ICDs if the patient is not eligible for CRTs, that is. And of course, in class 4 patients, you would still stick to the CRT and ICDs, but class 3 patient is placed where this therapy can still find a role, and with waiting for the new outcomes, maybe we'll have it for class 2 as well later on. Thank you. Good evening. Today, I'm talking about winking coronary sign, which was published by us in a PubMed Index journal, and I'm going to try to explain what is a winking coronary sign. So winking coronary sign basically is a sign of angiography of ventricular septal rupture. Ventricular septal rupture is an uncommon but lethal complication of acute MI, and its prompt recognition is important to permit timely institution of corrective measures. Basically, it's a novel, unique angiographic sign, and it's an angiographically diagnosing a post-MI ventricular septal rupture, and also called as Kamal-Sharma sign. It's defined as a partial transient occlusion of infarct-related culprit artery over the site of ventricular septal rupture during ventricular systole with near normal filling in the diastole. So basically, this is how it looks like. You can see the LED, this patient, and you can see the mid LED actually winking, actually closing down transiently, and the dye flow is stopping in between. So this is a patient whose angiogram was done post stenting. Actually, you can see somebody has already put a stent, and then this patient underwent an angiogram, which goes on to show the winking of the mid LED. So this was first reported by us in Journal of Cardiovascular Medicine and Surgery, where we presented analysis of 15 patients, and we found out that the 15 patients who had this sign, almost all, 13% of them had anterior wall, and 2 patients had inferior wall MI. The circumflex as a culprit was never found because probably of the annular fibrous tissue that the circumflex runs over the AV groove. Only 1 patient had completely occluded infarct-related artery, and then it became apparent once the artery was opened up, and this was the first publication of the same. Then we, of course, went ahead and did a retrospective observer-blinded case-controlled study of 129 patients. Of it, 56 were consecutive VSR secondary to acute MI, who had undergone cardiac cath between August 2008 to 2017, over a decade. And these cases were compared with 73 age and sex matched controls with STMI without a VSR. So all the angiograms were reviewed, analyzed by 3 different interventional cardiologists who were trained to recognize VCS, but were not aware whether the ventricular septal rupture was present or not. So winking coronary sign was considered to be present if it was confirmed independently by all the 3 of them. And these were the results. You can see that it was, of course, more common in patients who were diabetic and hypertensive, and patients had good TB grade flow. Unless the artery is not flowing, then we will not be able to see. But as you can see, in the VSR group, almost 57% of the patient were having TB grade 3 flow. Thrombolysis was performed in almost 1/3 of the patient, and the winking coronary was present in the VSR group in 38 patients, which is around 67 or 2/3. 67% or 2/3 of the patients. So this is basically systolic compression or of the culprit vessel. Here you can see the LAD and near normal flow endoscopy in the patient with anterior wall VSR. This is our data. You can see its sensitivity is almost 67.9%, but it was 100% specific with 100% positive predictive value. It was observed, whereas none of the patients without VSR actually showed the winking coronary sign. So the absence of winking coronary sign among patients without VSR resulted in a good positive predictive value, though negative predictive value could not be calculated because of very low prevalence of the sign in patients who did not have a VSR. So there are various postulated mechanisms that we have proposed. One is the Venturi or the mechanical theory, 3 theories: the Venturi effect, the mechanical theory, and the hemodynamic theory. The Venturi effect basically is that when the shunt across the VSR leads to a rapid drop in the pressure across the defect, causing overlying artery to collapse, and hence there is a systolic wink of the artery overlying the rupture. Second theory is the mechanical theory. It's the anatomical disruption of the septum because of the mechanical movement per se, that the artery itself can get compressed, and hence the rupture site causes transient loss of flow in the coronary artery. Mechanical instability of the disrupted septum may also be responsible, not the movement, but the hemodynamic impairments can actually be responsible for it. So we all know this is the blood supply of interventricular septum, and that's why it runs just on the anterior part of the groove, while the PD runs on the posterior part of the groove. And you can see this is a patient with the right coronary artery. It's a post-10. You can see that this patient has got a wink in the PD. And this is again corroborated with a device actually that was implanted in this patient who had a winking of the posterior descending artery or the right coronary infarction. So again, this goes on to show the wink. You can see here the mid part of the PD, which is winking with an acute infarct-related ventricular septal rupture. And this was corroborated on a surgical device. You can see correlation as well. The device was implanted and it corroborated with the site of the wink. This is the VSR device, which was put along with an intra-aortic balloon pump. And this is how the VSR can often correlate. And this is, of course, the other one. So this is the second publication in series, as I mentioned, in the Indian Heart Journal about the accuracy of the winking coronary angiographic sign. So one can learn a lot just by good observation. Thank you. Thank you very much.
So a very warm good evening to all of you. First of all, I would thank you, the organizing committee of this CardioCon conference, for inviting me, and allowing me to discuss an important topic, which is about the recent updates in high bleeding risk patient who are undergoing percutaneous coronary intervention. So we know that with the evolution of percutaneous coronary intervention, now we are able to treat more and more complex cases. And what we are doing day in and day out, that these days more and more patients with high bleeding risk, old age, having malignancy, taking oral anticoagulations, they are undergoing percutaneous coronary intervention. So there is always a risk of bleeding in these cases. And the bad part is that we have to give, as per the previous guidelines, the DAPT for at least 12 months. So if you have a high bleeding risk patient, the most of the time what we used to do, we used to implant a bare metal stent, because it was assumed that we have to give DAPT for only 1 month, then we can start on a single antiplatelet therapy. Why the evidence was like this? Because in most of the trials with the drug-eluting stent, these patients who were having high bleeding risk, they were not presented or given due presentation, and they were usually in the exclusion factor. So the population which was there in those trials, now we are treating this population, means the population having bleeding risk. So what we have evidence, and what and how we can treat these kind of patients. So first of all, how will you define that these are the patient subgroup which will have a high bleeding risk? So a good thing was that in 2019, due to various definition in defining the population in high bleeding risk, academic research consortium, they published a definite points, major points, minor points, and they defined that what kind of patients they should be kept under HBR risk. So there are few major criteria, the few minor criteria, and if the patient is having one major criteria or at least two minor criteria, then the patient was assumed to be having high bleeding risk. And what exactly is high bleeding risk? That if the patient in future will have more than 4% of major bleed, means bark class 3 to 5, or more than 1% of intracranial bleeding. So if the patient is having this much of risk or more than this, the patient will be defined under HBR. And what are the criteria? The major criteria are like, if the patient is taking oral anticoagulant, if the platelet count is less than 1 lakh, if the patient is having bleeding diathesis, liver disorder, having active cancer, or is planned for any surgery. Even if the patient is having past history of stroke or any AV malformation, previous aneurysm, previous bleeding, or if the blood hemoglobin level is less than 11, or if the eGFR is less than 30, then these kind of patients have, these are the factors which are major, and if the patient is having any one of them, he will be defined as having HPR. Similarly, there are some minor criteria like age more than 75, chronic use this chronic use of NSAIDs, steroids, or if eGFR is more than 30 but less than 60, or hemoglobin is more than 11 but less than 12 in females or less than 13 in male, or if the patient is having remote CVA, not less than 6 months. So if these are the minor criteria, and if any two of them are present, then the patient will be defined as having high bleeding risk. So by this, you are going to define, these are again the same criteria, that yes, these patients are having a high bleeding risk. So until 2015, with the publication of three major landmark trials, means leaders, free, Zeus, and senior trial. Until this thing was there, we used to give these patient BMS with 1 month of DAPT followed by single antiplatelet therapy. But after publication of these trials, all the intervention cardiologists, they got confidence that yes, you can implant a drug-eluting stent and you can easily stop antiplatelet therapy after 1 or 3 or 6 months of DAPT. So these are the major trials, and they were published in 2015-16. So now, after the publication of these trial, and that which showed that yes, high bleeding risk patient can have DAS and can have a DAPT, short course of DAPT. So more and more cardiologists, they started treating these kind of lesions. And what is peculiar about these HVR patients, because in our routine practice, up to 30% of patients who are undergoing PCI in our day-to-day practice, they will have the 1/3 of patient will have high bleeding risk. Any one major criteria, they will have this. And these kind of patients, they usually have complex lesions as compared to those in which the HBR risk are not there, because the patient is having either renal disease or he is having history of CVA, ICH. So most of the time, these factors are also in favor of complex coronary artery anatomy. Also, the chances of stent thrombosis and recurrent MI are more in these kind of patients. Mortality is high, and the bad part was that we have got very less evidence, because these kind of patients, they were historically they were excluded from all the trials, so the data was very limited. But after the publication of these 3 trials, many trials are planned. Recently 2 or 3 major trials after the this definition of ACR, they were published using these same criteria. So now we can have more and more evidence, and we have more confidence in treating these kind of patients. So this is the art of balancing ischemic and bleeding risk in these kind of patients, because we know that if the patient is having more thrombotic or more ischemic burden, then if we are going to use short course of DAPT, the patient will have recurrent ischemia. And yes, on the other hand, if the patient is having more risk of bleeding, patient will have bleed. So this is, each and every patient is different. So every physician have to evaluate these kind of patients separately, and they have to make a balance between these kind of therapies. So as already mentioned, the leaders free, Zeus and senior, these were somewhere published around in 2015. We can see that senior trial was a trial in which only the age more than 75 was taken. So only one minor criteria was there. The stent used was Synergy from the Boston, and in Zeus the stent used was Rotarlimus, and in leaders free the stent used was polymer free from the biosensor. So this leaders free trial was a major landmark trial which has got all types of patients having ICH, thrombocytopenia, all types of patients, they were represented appropriately in this trial. And the drug was, the patient with HBR was given the short course of DAPT in these kind of patients. So we will have some points, some slides discussing these major trials. So the first was, as I mentioned, the landmark trial, leaders free trial, in which a biofreedom stent polymer free was compared with the BMS Gazella in those patients in which the HBR the patient was having high bleeding risk. And we know that before the publication of this trial, we used to implant BMS. So as per the previous guidelines, BMS was implanted, and in the other arm, since it was a randomized double-blind trial, in the other arm, DES was implanted, and DAPT was given for only 1 month, and it was stopped in both the arm. So then primary safety and efficacy endpoints were checked. So what was found, that primary safety endpoint and primary efficacy endpoint, they were significantly better with this biofreedom stent, and also the bleeding was almost similar. And when secondary endpoints they were tested, it was found that almost these were equal. Only the thing was that the myocardial infarction was less in biofreedom. So with less bleeding, similar incidence of safety and efficacy endpoint, this was a superior trial, and it established that even in patient with high bleeding risk, we need not to go for BMS. We can easily implant drug-eluting stent. So the 2-year data was also published in 2017 after the initial publication in 2015. It was also on the same line, that yes, the benefit was still present in the follow-up also. Then the next trial, this was the Evolve Short DAPT trial. It was also recently published, and in this also the Synergy stent was used, and it was also found that all types of patient having thrombocytopenia, major bleeding, renal insufficiency, history of stroke, or patient having chronic anticoagulants or age more than 75, they were taken. And it also showed that it was a non-inferior trial, and showed that Synergy can also be implanted. Synergy is also polymer-free drug eluting stent. So in this kind of stent also, the drugs can be stopped after 3 months. We need not to give drug for at least 12 months. Then another landmark trial, the Onyx trial. In this, this was also a randomized control trial, and it was single blind. And the patient was either give. The best part was that it was 1:1 randomization, but the polymer-free stent was compared with a stable polymer resolute onyx stent. And we know that biofreedom, it proved its efficacy as compared to BMS in the leaders free. So the onyx was compared to this one, and it also showed the non-inferiority. It was significant and it reached the parameters of non-inferiority. So onyx was also deemed to be favor. It can also be the drugs can also be stopped after 1 or 3 months in HBR patients. As we can see, all types of patient, elderly, oral anticoagulants, patient having anemia, renal failure, active cancer, they all were present in these kind of patients. So this was also a non-inferiority trial. Then we come to another landmark trial, the master DPT trial. Again, a polymer-free Ultimaster stent was compared, and it was that in one arm the stent was same, in one arm the DPT was on the longer duration, and the other arm the DPT was of the shorter duration. And it was found that the standard DPT with the long duration and abbreviated DPT, it was all the net adverse clinical events were almost same. So it was achieving the non-inferiority margin. And so what they concluded recently in 2021, that in patients with HBR who had undergone implantation of a biodegradable polymer Ultimaster sirolimus eluting stent, the discontinuation of DPT at the median of 34 means 1 month compared with the discontinuation of treatment for median approximately 1 year. It was non-inferior for the incidence of net adverse clinical events. It was non-inferior for the incidence of major MACE. Also, it was associated with lower incidence of major or clinically relevant non-major bleeding. So the Ultimaster is biodegradable polymer free. The biofreedom was polymer free, and again, this also this stent also established that with these kind of stents we can have shorter duration of DPT. Only stable polymer stent which was evaluated in this kind of patient is this onyx. Now recently also this Zines 28 and Zines 90 trial were also published, but the thing is that in this the cohort it was not randomized. We can see that leaders free was a randomized trial, then onyx was a randomized trial, and master DAPT was randomized trial. So the evidence is always better for a randomized control trial. Zines was also tested in these kind of patients, the HBR patients, Zines 28 and Zines 90 trial, in which the incidence of stent thrombosis, major bleed, MACE, and all these primary efficacy and secondary points, they were compared with the historical data in the same kind of patients when they were given the long duration of DAPT. So it was not a randomized trial. But yes, in these kind of population also, Zine established the non-inferiority of its shorter course of DAPT. So this table shows that leaders, onyx, and this DAPT, these three randomized trials, they included most of the patients in which the criteria, major or minor criteria for HBR, they were equally represented apart from this age. So this established the confidence of treating physician that yes, we can stop the DAPT after 1 or 3 months if in those kind of patients in which the bleeding risk is high, and each patient should be evaluated separately. So just to summarize what we have got the latest evidence and what we have in our hands. First we come to the all the trials in which the DAPT was short, means short DAPT duration, the stents are different. So first in 2015, the leaders free trial, biofreedom stent compared with BMS. In both of them, abbreviated DAPT was given, and it achieved the superiority in terms of primary efficacy and safety endpoints. So shorter duration of DAPT in both the arms, BMS versus DAS. That's a senior trial. The synergy was compared to the BMS. In both of them, the shorter duration of DAPT, and it was superior to the BMS, the DAS. Then we have onyx trial. the Resolute Onyx was compared with the Biofreedom, and it was a non-inferior trial. So the Resolute was as good as Biofreedom and better than DICE. So these are all randomized control trial. Then few trials of Orsiro and Supraflex, they are recruiting patient, and the results are being evaluated, and the results are pending. So the major trials in which different stent platforms were compared were Leaders Free, Senior, and Onyx. In first two, the stent was compared, but DICE was compared with the BMS, and in the Onyx, the DICE was compared with another DICE, which has established itself. But in all these trials, the DPT was abbreviated. Now we come to those trials in which a short duration of DAPT was compared to the long duration of DAPT, and stent was same. So we have Zines 28 and Zines 90. 28 means 1 month DAPT, and Zines 90 means 3 months of DAPT. Both of these trials, they established the non-inferiority of abbreviated DAPT. The platform was same, but it was found that abbreviated DAPT in these kind of patients, it has got the same effect. Then we have master DAPT. It was a randomized trial. The stent was same in all these trials. The stent is same, only the course is shorter versus this 12 month of DAPT, they was compared. Then we have a pending result of Firehawk stent, the target safe trial. Now the third summary will be that those in which the DAPT duration was also different and stents were also different. The evolved short DAPT, it was just published, in which the synergy was compared with the historical cohort, and it established its non-inferiority. Then we had a failure trial, the Cobra reduced trial, in which the polymer free stent was compared with the drug, and it failed to establish its superiority. So what are the recent guidelines? If the patient is having acute coronary syndrome, both European and US or AHA guideline, they say that at least, even if the patient is having high bleeding risk, you have to give at least 6 months of DAPT. But if the patient is having stable coronary angina and the patient is having high bleeding risk, it is reasonable to at least give DAPT for 3 months, but yes, you can stop, or it may be considered to stop after 1 month. But then you have to select only those kind of platforms which have established their efficacy and safety endpoints in published trials in peer-reviewed journals. So this is the recent European guidelines, the summary from this one. Again, if the patient is having acute coronary syndrome, we know that in acute coronary syndrome, we have the P2Y12, we can use clopidogrel, prasugrel, or ticagrelor. So either patient may be DIAS, BMS, or drug-coated balloon. He may be treated with any one of them. And now if the patient is having high bleeding risk, then you cannot use prasugrel. Only we can use is aspirin with clopidogrel or aspirin with ticagrelor. And at least, since the patient is having acute coronary syndrome, at least we want to give DAPT for 6 months. But if the patient is having acute coronary syndrome and there is no high bleeding risk, then we can use prasugrel, tica, or clopidogrel in combination with aspirin, and at least we have to give for 12 months. On the other hand, if the patient is having stable coronary angina and he has got either BMS, DAS, or drug-coated balloon, and then if the patient is having high bleeding risk, then we are going to use aspirin with clopidogrel for 1 month to 3 months. We reasonable to give for at least 3 months, but can be considered to stop after 1 month only. But if the patient is having stable coronary angina and there is no high bleeding risk, we have to give for at least DPT for at least 6 months. But only thing is, in patient of stable coronary artery disease, we have to combine aspirin with clopidogrel, and in those cases in which the patient is in ACS, we have to use these tica or prasugrel. So this is all about the recent in high bleeding risk patient, recent trials and recent guidelines. Thank you.
Welcome to CardioCon 2022. Myself, Dr. Mukesh Latta, DM cardiologist from Sal Hospital, Ahmedabad. Friends, we all know that the intervention cardiology has evolved from time to time, and now we are in such era where the imaging has a great role. The IVAS, we all know that the basic tool now in almost all complex angioplasty, including the left main disease. But the understanding and the knowledge in overall the IVAS is the crucial, because this is the newer advancement in the intervention, but easy to learn as well. Now, friends, yeah. So as I told that the IVAS is now the main tool to improve overall the precision in terms of the angioplasty, and this is the era of imaging where the IVAS has the great role to give the maximum best result in the angioplasty. Now, what IVAS says, and what normal routine angiography or angioplasty. In routine angioplasty, the vision is our only two-dimensional. Even though we have to work in the whole 3D structure, but we can see only in the 2-dimension. Here you can see that this picture, you can think about one object, but as you see the 3D image, your whole perception will change, because you are totally, change your thought, your mind after seeing this image. So same way, what we see in the angioplasty or angiography, after IVAS, the whole image, the whole perception about the lesion, identification of the overall criticalness of the disease, and later on these background, we decide the treatment, and which is really great helpful to overall prognosis of the patient. Now, coming to the main objective of this talk, as I told you that IVAS, we have a great tool in terms of imaging and identifying the IVAS catheter indicated for the coronary imaging, that we have to understand what kind of IVAS catheter we have, and different types of catheter which are available in the market, and these are according to the frequency, and according to that frequency the imaging quality improves. And the next is the recognize how IVAS complement the diagnosis and the treatment. As I told, IVAS is the great tool. It make your decision and make your result very precise and critical, and in terms of IVAS has great role. Now, once you are using the IVAS, what can we think about in lesion terms of that IVAS gives you exact lesion identification, how critical, what kind of lesion it is, and how is the morphology of that lesion. That lesion is having more of fibrous tissue or more of calcium, and according to that, the physiology and according to the morphology of that lesion, we decide the treatment. What are the added modality we have to use when we are using, we are tackling a calcified lesion, that is also can be judged according to the IVAS finding. So in terms of lesion categorizations, in terms of lesion preparation, IVAS is a wonderful tool to start with. Now, the limitation of angiography. Since decades, we are using angiography, and with experience, we know that most of people are very well trained cardiologists, and they do a really wonderful job with naked eye angiography and angioplasty. But once you are added your IVAS, the whole perception will change, as we know that most of the lesions we see in a 2-dimension. One dimension can say it is a 30-40, and another dimension it may be 70 or 80%. So these are the view side, drawback of the normal angiography, which can be countered by the IVAS. And IVAS gives you a 360-degree rotational image, which is a total real-time image. Now, so friends, what is the basic IVAS? IVAS is nothing a ultrasound which we used to take inside our coronary vessels with the help of catheter which is available, and these are the just add-on technique in terms of, we can say, a normal angioplasty. There is no added skill required to learn to incorporate this device in your technique. And IVAS provide detailed and accurate measurement of lumen and vessel size, which is the crucial in selecting the proper size of the stent, and the plaque area and volume. most of the time we just think about the plaque and the volume according to our experience, but this is the IVUS which give you exact objective volume and data about the plaque. And the last thing is the location, the key locations where to start and where to end. That can be clearly demarcated with the help of IVUS. So these are the main purpose of using IVUS in the coronary angioplasty. Now, how does it work? As I told, this is just a normal ultrasound, and as we use in the echocardiography, the same principle is applied here also. The ultrasound wave which is emitted by the transducer, and ultimately this is reflected in terms of the images, and that images by that software has converted that real world images for our interpretation. So these are the just normal ultrasound mechanics, and that is totally incorporated in this wonderful technique. Now coming to the normal anatomy, when you are tackling with the IVUS catheter and we are going inside, what you found? We know that in our MBBS days that the adventitia is the outermost layer. You see, this is the number one, which is the most outer layer of the vessel wall, and that is the adventitia. And after that, you see the media. This is our target area where we have to deploy our stent and where we have to exactly measure the overall lumen area. And last is the intima. In between intima and the media, the exact is the plaque burden. So friends, as we know the total plaque burden, what is the lumen area, and exact the total length of the lumen diameter. All these three are really helpful to deploy and to select the size of the stent, and that gives you in a long-term better result. Now this is the IVUS catheter. It is a 64 Hertz transducer with digital technology, and which we use in a railroad technique to pass in the normal guide catheter, and that goes into the coronary as in our routine balloon or our any deployable material. Now this is the platinum catheter, because we have different kind of catheter to tackle different morphology and different places to handle. This is mainly used in the peripheral intervention, where we need a bigger lumen diameter, and that can be maximum up to 20 mm. We can see the structure clearly. So these are the main, for just audience purpose, these are the different type of catheter which is used at the different place and the purpose. But they have the cardiologists are very well aware of these things, and that can be utilized as and when time required. This is again a different type of platinum short tip catheter. That is again, this catheter is a beauty is that beautifully demarcate the bifurcation lesions, where short tip helps in the proper demarcation of the ostial or the bifurcation lesions. So these are the different catheters which are used at the different purpose and different level. Coming to the how IVUS work. With rotational IVUS, we know that the premise of the ultrasound as emitted, and the transducer in a sheathed housing is rotated by a drive cable at almost 1800 RPM. And this RPM is handled by the rotation, which is the governed by the driving cable inside the catheter itself. So these are the normal mechanics which is applicable in our technique. Now this is the motor, basically a motor unit. Through this motor unit, our IVUS catheter is attached, and that motor unit goes in and out. We have to handle by manually that device. And it is an easy to use and easy to handle device, and even a single operator can use whole IVUS thing. And this is the beautiful structure of this beautiful Philips IVUS catheter device and the whole system in toto. And that doesn't require too much big space. You can place in your cath lab anywhere, wherever you want, and it is a mobile also. So this is a good things to do. Now friends, why we need IVUS? Because we want to know the exact lumen diameter. Yeah, we want to know the exact length of the lesions and the plaque composition. As we are handling more and more complex intervention, we want to know the exact plaque composition, how plaque morphology wise, like having more of fibrofatty tissue or more of calcium. And according to that, we have to decide add-on technique or plaque modification technique. And finally, once you are deploy the stent, how good you have deployed, what is the total optimization of stent is the critical thing for final result. And that you can easily detect, or that you can easily visualize with your IVUS catheter or IVUS device. And finally, as we know that whatever you do best, even though even a small mistakes can, totally jeopardize your whole thing. But IVUS, with the IVUS help of the IVUS, you can detect your small tiny dissections also, and that can prevent your major catastrophe or immediate stent thrombosis. These are things really helpful in terms of when you do a more complex or calcified intervention. And this is the normal, A is the normal anatomy of the coronary vessels, and the B is the where lesion is there. And according to that, you have to judge the total luminal area and the maximum luminal area. And this is the normal math which is used to identify the exact lesion, the size of lesion, the plaque burden, and on that basis we have to judge the stent size. And this is the really a wonderful thing, so that you can minimize your geographical mismatch, even though with the axial geographical mismatch as well as longitudinal geographical mismatch. Most of time we have, when you do naked eye or two-dimensional angiography or angioplasty, that time most of time this may happen because you just sometimes you undersize the stent mostly, and that prevent your delay your overall problem. Now coming to the different kind of plaque morphology, where what kind of morphology you see in a IVUS. The fibrous plaque, first slide, the left side, that fibrous plaque that is more homogeneous, that you can see easily hold the structure homogeneously placed. The second is the calcific plaque. You see that more brighter structure almost at 12 to 2 o'clock, that is having more calcific plaque. So these are the basic things to understand while you do IVUS. The soft plaque rupture. You see that there is a plaque rupture that most of time when patients, even the young population, when the plaque burden is not more, main pathology is the plaque rupture or plaque erosion, that can easily be detected with this IVUS. And the last is the dissections. Most of time when you do intervention, you don't know which is the true lumen or which is the false lumen if you created true, false, true. But in that case, you, with the help of IVUS, you can easily recognize which is the true lumen and which is the false lumen, and you can detect your dissection at timely. Now, this is the last slide. As I told that IVUS is having a wonderful role in the coronary as well as in the peripheral intervention. People who are doing complex peripheral intervention, that time also the same indications can be applied for the peripheral intervention, selecting the proper armamentarium, proper stent size. All these things can be managed with the IVUS catheter. We have integrated Philips overall IVUS, where you can place your whole things on your table, and you can place your screen alongside your 2D angiography image. And this is the seamless integration. You need not to carry your whole console or whole things in toto, because and this is the main beauty right now, because it is easy to handle, easy to see, and these are all things are in side by side. So this is the great advantage when you are using this seamless integrations. And this is only platform with the supporting Windows 10 and the most secured platform, and 24/7 online support. Whenever you require support, they have persons who can immediately help you solve your all problems. And this is the system capable of all peripheral as well as coronary applications. So this is the real tool when you are doing all kind of intervention, and a wonderful thing. this is the just prima facie of the seamless integrations, where you can see the whole screen which is attached to the cath lab itself, and this is the cath lab all normal functioning buttons, and this is the attachment of the system to the IVAS screen itself. And now same thing, this is the inside cath lab, where the whole monitor is attached to whole screen, where you can see your coronary angiogram as well as IVAS images both same time in real world. And this is the again outside the console, where you can see images, you can do your patient also, as well as you can also interpret it after doing your angioplasty. So this is the overall good integrated system, where you can place your working screen alongside your angiography screen, as well as you can do study later on when you require outside the cath lab inside your console. So wonderful things, and is the new intervention, a new invention in terms of IVAS. When we used to in the initial era, when we used to see whole system in a one tool, but now it is totally integrated with our cath lab. So it's a great thing. Now different kind of IVAS modality is available to analyze proper physiology and the vascular structure of the coronary and other peripheral structure. This is the digital IVAS, where we used to do normal coronary intervention, and this is the chromoflow IVAS, where we can easily identify the maloppositions or how good is the stent opposed to the vessel wall, because once it can detect the blood flow which is going only through the lumen. If it is going between the lumen and the stent, then we can see that stent opposition is not proper. So it's the again a great advancement in this Philips IVAS. And this is the peripheral IVAS, where the same thing which we do in the coronary, and this is the high resolution, because the 45 megahertz catheter, which gives really equivalent image to any other or advanced IVAS catheter, IVAS device. And the last, which is again important thing, is that this IVAS catheter comes with IFR, and this is the really boon when you are doing or judging the vessel where borderline lesion is there, when your decision making doesn't fulfill with only IVAS, and that time IFR play a great role, because the physiology is the main thing when you are taking any decision, which sometimes in the situations like IVAS may be plus minus, but with the help of IFR you are 100% sure that you go for the plasty or not. So these are the integrated things which gives you a lot of comfort in terms of making a decision. Now friends, this is the digital IVAS catheter. As I told, that this short tip catheter, these are the different type of catheter, and among them this is the short tip catheter, which gives you a good result in terms of side branch ostia and the total assessment of the bifurcation lesion, mainly in the coronary left main system, left main bifurcation. So this is the new thing. And now the chromoflow. The chromoflow is the such thing, it's kind of an invention in terms of the physiology of the overall the coronary, where we can see the incomplete appositions with the help of this chromoflow, where if suppose the blood go in between the whole lumen, that means your stent is totally purely apposed properly and there is no malapposition. So another way of looking your vessels from the inside with the help of colors, which gives you another way of thinking about your vessels and the stent. This is the lumen, where you can see incomplete appositions. You see the stents are not apposed properly to the media. And after that, you can see the tear also. Here you can see that there is tear in the vessel wall, where the blood is again leaking from that part. So these are the benefit of the chromoflow, where you can see sometime a hidden dissections which you can't see with your naked eye, but that the technique and that image that can show you. Now this is the whole thing can be done through the radial access, That also gives great comfort to the patient, and as well it is the highly resolution, the frequency which now we are getting, the 45 megahertz, which gives you a comparable image quality to any any imaging other tool. And the next thing that this Philips device doesn't require a disposable sled as and when you go for a next case, and this is the mostly controlled with automatic pullback device. It doesn't require like in the you have to change that thing again and again when you are going for a next case, but this is the thing which you can use as many time as you want. Coming to the peripheral intervention, here we can see the role of IVUS in the peripheral intervention. The same way as you do coronary intervention, the similar way you can use IVUS catheter, because this IVUS catheter can see up to 20 mm diameter of the vessels. So you can do your plasty in the leg vessels or in the calf vessels, where they give you better understanding about the lesions and the proper positions of the stent. So not only in the coronary, these IVUS device can use in the peripheral system also. Now coming to the IFR. We know that IFR is having a great role in terms of decision making when physiology has a game changing, basically the deciding factor when you want to do stent or not. And this device, when integrated with the IFR, and gives you an extra added comfort when you want to take a decision. Now IFR co-registration. This is again a new thing, and I'm really glad to share with you guys, because this is just a virtual stenting. Before doing angioplasty, you can identify that these are the area where you are going to get that much of IFR before deploying the stent, and this is the real thing where you can judge, or where you change or you can manage your plan according to that IFR readings. So it's a great thing. An integrated approach, decision making makes your decision making very easy and clear cut, and it's really mesmerizing things to do when you do angioplasty with such system and such kind of technique. Really help your patient to do better in future. Thank you so much, dear.
Good evening, ladies and gentlemen. At the outset, I would like to thank Dr. Kamal Sharma sir, Chairman Scientific Committee, and all the other organizing committee members for giving me this opportunity to present a case of trick wall in this update, Cardiocon update, recent update session. So in our day-to-day practice, we tend to underestimate and undertreat tricuspid wall, tricuspid regurgitation, mainly because the limited therapeutic options on one hand, and it carries very high morbidity and mortality, and surgical mortality is very high on the other hand. So same thing happened to my case. So my case is a 53-year-old gentleman, LIC officer, who had a road traffic accident with head injury and polytrauma 20 years back. So he underwent neurosurgery and subsequent orthopedic surgeries in a peripheral center. So where he developed sepsis during the course of hospitalization, and it caused infective endocarditis of tricuspid wall. So then for the management of infective endocarditis, he was shifted to famous teaching institute in Hyderabad, Nizam's Institute of Medical Sciences, and where he was successfully treated for his infective endocarditis with long-term antibiotic therapy. But unfortunately, he developed mild tricuspid, he left with mild tricuspid regurgitation at that time. So then the doctors told him, reassured him that nothing going to happen with mild TR. So they reassured him and discharged him. So he also forgot about his condition, and he carried on later. But subsequently, for the last 5 years, again, he developed cardiac symptoms as well as pedal edema, gross abdominal distension. So he consulted local physicians and found to have a very severe tricuspid regurgitation with early stage of cardiac cirrhosis. So from then, his natural course was complicated by recurrent hospitalizations with congestive cardiac failure, abdominal distension with episodes of spontaneous bacterial peritonitis. So he visited many hospitals for the treatment of TR, but nobody offered him any therapy, mainly because of his comorbid conditions. And he is also a known case of hypothyroidism, rheumatoid arthritis, and cholelithiasis. He had left lower limb DVT in 2013, managed conservatively, and he underwent umbilical hernioplasty in 2017 at our center by a senior most surgical gastroenterologist. These are the MAS before and after the umbilical hernioplasty. In last year, during the COVID wave, he developed COVID pneumonia. Everybody in the family thought with so many comorbid conditions, he'll not do well. But luckily, he recovered with home isolation only. But in the month of July 2021, he admitted again in our center with severe pain abdomen under the same surgical gastroenterologist who treated him earlier. Again, he was diagnosed to have spontaneous bacterial peritonitis. And at that time, they did a paracentesis and they could aspirate a purulent aspirate. Cultures were sent and Pseudomonas was grown, and he was started on higher antibiotics. Just like a routine consultation, because he's having severe tricuspid valve regurgitation, they gave referral to cardiology, and nothing they expected much from us except managing the edema part. But on examination, he had functional class 3 symptoms: gross pedal edema, huge scrotal swelling with gross ascites. These are the MAs with gross ascites and pedal edema. On examination, JVP was elevated and bounding. ECG showed atrial fibrillation with controlled ventricular rate. Right bundle branch pattern was there. 2D echo, you can see here, grossly dilated RA-RV with severe low pressure TR with TAPSE of 20 millimeters. And you can see the myxomatous mitral valve with some mild eccentric TR with fair biventricular functions. Coming to the labs, LFTs were deranged. He had hypoalbuminemia. RFT was normal, and total leukocyte count was elevated. So, when I discussed with our heart team colleagues, so surgeons turned down this case for any sort of repair because of so many comorbids and the risk of high mortality. So we have very limited interventional options. So these are the options of transcatheter tricuspid valve landscape. So we have a direct suture annuloplasty, direct ring annuloplasty, coaptation enhancements, and valve replacements. These are all various devices under development at various stages of development. But definitely TrickWalve is available now for the therapy. So we narrowed down our possibilities to TrickWalve. This is the TrickWalve system. It comes as a bicaval valves, 2 valves. One we have to implant in SVC, this valve, and the other one is in IVC. So these are the nitinol frames with bovine valves attached to it. So to prevent the caval reflux. So for any structural intervention, CT angiogram is a must. So CT planning is necessary. It decreases the possibilities of paravalvular leak as well as migration of the walls. Proper sizing is very essential. So we have done the sizing, and so for us, it came like SVC 29 millimeters valve and IVC 41 millimeters valve. And this is the 3D imprinting of the CT. We can see grossly dilated RA and RV with rotation to the left. So when we were planning all these things, but his intra-abdominal sepsis worsened and he started having pus inside. So initially that was managed by an interventional radiology colleague with pigtail drainage conservatively, almost close to 15 to 20 times he drained pus, but still it was coming. So then they suspected bowel perforation. CT abdomen was done. They suspected appendicular perforation on CT abdomen. Then subsequently, surgical gastroenterologists went ahead and they did diagnostic laparoscopy, and peritoneal wash was given with adhesiolysis was done. And subsequently, he developed lower respiratory tract infections, recurrent pleural effusions, again drained by the interventional radiologist under ultrasound guidance. And one day he had one episode of code blue in the room, but that was successfully resuscitated by our critical care team. So once the drain stopped, cultures became negative. We thought that is the right time to implant the walls. And so at that time, walls were not available in India. So we ordered the walls and we were preparing for implantation. But unfortunately, he developed a septic shock. So he required multiple inotropes, and he was intubated and kept on ventilator. And subsequently, he developed AKI. He was on CRRT. So during that CRRT and ICU stays, he developed one more episode of cardiac arrest. So at that time, everybody in the team thought he will not make it. So everybody lost hope. But after 1 week of CRRT, slowly his urine output started coming, and his creatinine also started decreasing. So then at that time, our main dilemma was whether to go ahead and implant the walls or to wait till everything becomes normal. So then we counseled the family. In the family meeting, the family members told that anyway, we have paid for the wall and walls are available. Why don't you go ahead and put the walls? Let's see the effect of the walls. So with that encouragement, and we took a chance. And so on the day of implantation, he was on CRRT with multiple inotropes and on ventilator. So we took him for the procedure. Then this is the procedure. For right groin, mainly we use for the device delivery, and the left groin we use for the landmarks, like one catheter in the right pulmonary artery for the implantation of the SVC valve, and the other second valve is for the placing of the looped wire in the RA to identify the SVC RA junction as well as RA junctions. So these are the steps. So finally, after placing the landmarks, we have pushed the SVC transcatheter heart valves 29 mm into the SVC, and this has to be deployed above the RPA catheter. The belly part, which is a protruding belly part, we have to keep it above the RPA catheter. So we have deployed that, and this is the final full deployment of the SVC valve. Again, after doing the hepatic vein angiogram, so we have identified the hepatic vein origin, and then we have taken the IVC valve again, and we have deployed above the hepatic vein. And this is the final angiogram after the putting both the bicable valves. So we can see there was no reflux, valvular or paravalvular. So this is the final check angiogram, and this is the intraoperative PEA. So here you can see the IVC valve opening, closing nicely, and here the SVC valve again closing nicely. And the groin is pre-closed, so no necessary for surgical cut down or surgical closure. And this is the final result of after the putting both the valves in place. This is the SVC valve with the protruding belly between, and this is the IVC valve. And on third day, we extubated him and we mobilized him in ICU, and subsequent recovery was very amazing, and so he improved. He was extubated, and CRRT was stopped, and his abdomen girth was decreased so drastically. Overall weight decreased, and he was shifted to room, and he came for follow-ups, 3 follow-ups till now. So we have done 3 months follow-up. This is the follow-up echo of 3 months. So we can see the slightly reduction in size of RV, RA. PR is there still, but slowly, gradually, I hope it will come down. So take-home message here is TrickWalk is the latest in the horizons of tricuspid therapy. It helps in reducing symptoms and recurrent hospitalization in patients with severe tricuspid regurgitation with caval reflux. And the caval valve implantation is technically easy, simple. It's like putting the filters, IVC filters, similar to that. And the good part is now this therapy is available in India. So when I implanted, I imported it from Germany, but now it's available in India, so we can order. And these valves are pre-mounted valves. There is nothing like much preparation required during the procedure. You can straight away go ahead and after identifying the landmarks, you can deploy the valve. Thank you very much for your patient listening.
Yeah, so thank you very much. This is a privilege for me to be speaking in this forum, and I'm speaking upon some interesting TAVR case, which a few months back I have done, and I thought it is worthwhile sharing this because there is a lot of education in this case. And you know, our TAVR journey is becoming consolidated day by day, and our numbers are growing. So I think more the challenges which we confront during a TAVR case and we discuss amongst all of us in these forums, it's going to make us more wiser how to handle these situations for our future patients. So interesting TAVR case, and practically the interesting point in this was the coronary access and fear and scare of a coronary occlusion. So coronary artery disease and aortic stenosis, they are known to be coexisting with each other. And as per literature, the need of PCI post-TAVR, although is not very high, but it's not uncommon also. The future may look different as we now offer TAVR in low-risk cases. So what this slide means is that if we do a TAVR, and even at that point of time, patient doesn't have a coronary artery disease, we have to think that if the patient develops a future coronary artery disease, how to handle that. So this is my case. He was 56-year-old, not very old patient, but this is also one point which I like to enumerate. Normally, we consider TAVRs in above 65 years of age patients, but in some of the other patients where the morbidities are very high and surgical risk is very high, it can be thought of. This procedure can be thought in such patients also. So this was the same patient. He had many comorbidities. He had renal cell carcinoma. He had frequent urological infections. And given that, the family was very clear that they are not going for 2 surgeries because he was posted for renal cell carcinoma surgery also. And in the workup, he was found to be having a critical aortic stenosis. So we sat as a heart team, which we usually do in all cases of TAVR. So heart team decision was very clear to go ahead with TAVR. And given the age, we opted for a valve, which potentially gives the largest effective orifice area. So that was our selection. And in that, I would say without any inhibition, I think Medtronic Evolut valve is one valve which gives us a better orifice areas in terms, because it's a supraannular valve. So openings are much better as compared to all other valves available. In this patient, the critical points were a narrow sinus of Valsalva diameters, borderline left coronary artery ostia. So this is also a point which needs to be discussed in such patients. How do we plan? So this is the CT analysis. Now, if you see very clearly, so it was the sinus of Valsalva on the left side was hardly 25. So it was not a spacious anatomy. And the left coronary artery ostia, left main ostium from the annulus was 9.2. So less than 10 is a clear red flag and we need to be extra vigilant and extra cautious if we are planning a procedure with some red flags. So these are the two red flags, that sinus of Valsalva was narrow and the coronary ostial height. The left main coronary ostial height was less than 10, again a red flag. All other parameters were okay, but this is a big thing. So these are the femorals, common iliacs, very spacious, no problem here. And then we went in for the procedure. As a step number one, we do the coronary angio, obviously more than 50 years of age. The coronary anatomy, coronary arteries were fine. There were no critical blockages in the coronaries, but as I mentioned, the main point of interest and point of concern is the red flag sign of left main coronary ostial height is narrow. And then this is how the puncture is taken. I think not a great deal. We checked from the contralateral side, do a femoral angiogram, and based on that, we see the profunda rising, and then mark up our point on the femoral head, femur head, to make a mark where to puncture. And then we go with the micro puncture and then step up with the normal wire and a sheath. So after having done that, this is the aortogram with a pigtail catheter. Now this also defines, if you see it very carefully, see it's a constrained anatomy, and if you see there's a thick valve, and valve is moving towards the left main ostium and almost reaching the height of left main ostium, covering the left main ostium. So this was the point where we were absolutely concerned that we should not be putting, making the patient vulnerable or vulnerable for coronary occlusion once we do the procedure. So I was very clear from the word go that we need to protect these coronaries. Sinus of Valsalva constrained and a left main ostial less than 10. We need to protect. I think this is clearly written on the wall. And following that, side by side as we progressed, we crossed the aortic valve, and this is a rigid wire into the LV, confida wire. And then after this, I engaged the left main, and see a wire is into the left circumflex. And over that wire, I passed a guide liner. So once a guide liner is into the circumflex over the wire, I retracted the guiding into the ascending aorta. So this is one important thing. Few operators also do differently by placing a stent, by harboring a stent into the circumflex or into the LAD, and then do not take guide liner. But this is a better approach, since we are not opening any stent. We are just harboring the guide liner into the coronaries and then proceed on with our TAVR deployment. So after having done that, so this is a Medtronic valve, and see slowly and gradually we were opening this valve. We got a good height as regards the annulus. So we were 3 down the annulus, and we were almost 80-90% open the valve. We are still at a point of retrieval. We can retrieve the valve still, and at this point we waited quite patiently because there have been reports that coronary occlusions can happen even few hours after the valve deployment in TAVR. So it's not necessary that all the occlusions would happen on table. It can happen 1 hour or 2 hours after the valve deployment. So we have to be really vigilant and be safe totally, because once it happens, nobody will get a time to save a patient. So it means a life. We are practically dealing with a full life. So see, now we are constantly checking with the aortogram repeatedly whether coronaries are flowing. Our guide liner is still in position into the left main, into the circumflex, and almost waited there for 20 minutes and checked by both means, by a aortogram and by a selective injection through that guide liner into the coronaries. So we have deployed the valve here after having established that the flow was not impeding or not a slow flow into the coronaries by both injections, by aortogram and selective injections. But despite that, we kept our guide liner even after deployment of the valve. And again, we waited for 15 to 20 minutes. I think it's worthwhile making a sure assessment of the situation, whether nothing is happening or any vulnerability for coronary occlusion. We again waited for 15-20 minutes, kept on checking with this guide liner the coronary perfusion. See, it's quite narrow actually. The margin where occlusion can happen or patient is safe is very narrow in certain patients. And this was a similar patient like this. Now, if you can see, as far as height is concerned, the native valve, which gets twisted behind this metal rim, actually is almost reaching the left main ostium, but there is some extra space of that sinus valva which is continuing the perfusion. So, but we waited. So the reason why we waited, because even if a obstruction or a slow flow or a TB1 flow starts happening into the coronaries, we can still take a stent and make a chimney to save a patient. But if we take out this guide liner and then the obstruction starts, then the occlusion starts, then we are left with nothing. So we waited 20 minutes prior in that position where the valve was not fully deployed, and 20 minutes after, almost 40-45 minutes, even after the valve deployed, once the flow was absolutely fine, brisk, and we could actually see that that small extra space of sinus valva is leading to a good perfusion. Then we take out our guide liner back, and that was the end of the procedure. As far as valve was concerned, there were no gradients. The mean gradient was only 5 mm of mercury post valve deployment, and there was no AR. So we were pretty happy with the valve position, the outcome, and the red flag of low coronary ostial height. We took these steps to make sure that we are safe and patient is safe. So TAVR is a very powerful therapy, very patient-friendly therapy. Choosing the right candidate becomes very critical. We should clearly know the red flag signs, where to do TAVR and where not to do TAVR, or where to actually practice a special actions or special points to save and have the best outcomes with a patient who's undergoing TAVR. Keep all necessary hardware available. So this is again very important. The guide liners, the stents, the larger stent which could fit in from a left mid to chimney if required. You should have all those things in your hybrid lab. Choose a device based on a risk allowing maximum safety. In this case, a recapturable, repositionable, a biggest effective orifice area valve was chosen because patient was relatively younger and there was some risk of occlusion. So we could actually manage by keeping the valve, and once it is still not fully deployed, we can still do a lot of maneuvers to keep the patient safe. In case it is a single shot balloon mounted valve, it is done, and if occlusion happens, we can't do anything then. So this is my case. Hopefully it is going to be quite educative for the audience. Thank you very much for giving me, for inviting me here. I really enjoyed it. Thank you.
So today we will be talking about a new molecule or just simplifying or even with innovation or even bettering the management of diabetes and in the context of risk reduction in various ways. So we are always looking for an ideal anti-diabetic drug because we still have not achieved whatever we want. So now we will look at a new era of how we can give a peptide in a pill which was never possible in the past. So what's wrong in this picture? So you can see that our quest for treating diabetes started way back. It started with insulin, then in 60s with sulfonylureas, then we had metformin. But as of 2005, we have almost about 40 new treatment options for diabetes. And in spite of all these options, what we can see here is that people who have achieved HbA1c below 7% is only 23.4. So 3/4 of the people who, in spite of so many treatment options, have their HbA1c above 7%. So obviously, despite these available treatments, diabetes remains the 9th major cause of death globally. 50% of patients with diabetes present with microvascular complication, 27% with macrovascular complication, and 25% have diabetic kidney disease. When we say that we want an ideal anti-diabetic drug, we are trying to balance various things. On one side, we have a desire to control or lower the blood glucose, but at the same time, we don't want hypoglycemia episodes to happen. We want to control the weight gain, or if possible, want a weight loss, but at the same time, we don't want off-target effects, and we want obviously a better HbA1c. So our expectations from a new anti-diabetic drug is that it gives good glycemic control, smooth control with low risk of hypoglycemia. And it should cause weight loss or at least no weight gain. So it should be weight neutral if not losing weight. And there should be minimal off-target effects. And our HbA1c should be below 7. So these are the ideal features. Now, if you look at all the available options or classes of anti-diabetic drugs, we will not go into the details of all classes in terms of their every property, but let's look at important things. We just discussed about the hypoglycemia risk. So a lot of molecules, inclusive of GLP-1 have low risk of hypoglycemia. The efficacy for reduction of HbA1c is good in some molecules. It is very good. It is very high in GLP-1 the weight effect, you can see that the green arrows or the downward arrows are only in 2 options. That is the SGLT2 inhibitors and the GLP-1 More importantly, the cardiovascular benefits. So not only they are neutral, that means there is no increase in risk as in some of the other molecules, but there is actually cardiovascular risk reduction, which is one of the most important things. So if you look at this orange part of the diagram, you can see that GLP-1 provide kind of fulfill our every wish list that we have with an anti-diabetic drug. So there are various effects, and without going into these slides, that this addresses 6 out of the 8 octet mechanisms. So other perspective in taking an anti-diabetic medication is patient convenience. And what do patients prefer? Do they prefer to take a violent syringe, whether it is insulin, whether it is some of the other injectable things like liraglutide, even with, so violent syringe is probably modified by the pens, which is slightly better. But obviously, everyone would prefer a tablet form. So this question is purely rhetorical. There is no sort of great science behind this, that everybody would prefer a simpler method of administration. But if you want to administer a peptide orally, then the problem is that it undergoes degradation in the stomach due to the low pH and due to proteolytic enzymes. And this enzymatic degradation is also further increased or is further troubled by the limited permeability across the GI epithelium. So there is a very low oral bioavailability. So if you administer a GLP-1 RA alone orally, then its bioavailability would be less than 0.01%. So it is something like 1 in 10,000 part will actually be available inside the body. So this issue of limited absorption till now was one of the major concerns. Semaglutide is a molecule which has a 90% homology to human GLP-1. So it has certain these things like the spacer and C18 fatty acid chains to lysine, which causes strong binding to albumin. It has a very long half-life of about a week. And then you have these other substitutions of amino acid, which protect against DP4 degradation, and also the C18 fatty diacid binding at the wrong side. So these minor substitutions from the natural molecule kind of help in creating a drug option. So how do we overcome this issue that we have a very good peptide molecule in the form of semaglutide, but now how do we give it in a pill? So we have something called an absorption enhancer. It is called SNAC, or sodium N-aminocaprylate. It is also known as salcaprozate sodium. It's a small fatty acid derivative that promotes the absorption across the gastric epithelium, and by itself it is metabolized by beta oxidation and glucuronidation and eliminated through urine. This co-formulation does not change the chemical structure of any of the molecules. So there are two different entities just kind of bundled together. So it protects the SNAC protects the semaglutide molecule and helps in getting it absorbed. So it absorbs, get it absorbed from the stomach, and therefore better transportation through the gastric epithelium, and the degradation with gastric enzyme is prevented. So this is the GLP-1 analog semaglutide. It has a very long half-life. It's a very effective molecule. And then we combine it with this SNAC, which promotes the absorption through the gastric epithelium, enhances the availability. And therefore now, just by joining these two in a single tablet, it would be possible to have a better bioavailability. So it basically increases the absorption because of this co-formulation. It causes a local increase in pH, which leads to higher solubility and protection from proteolytic degradation. So basically, this is a strictly time and concentration dependent mechanism, and it is fully reversible. It doesn't mean that the pH in the stomach would remain changed. And it is also happening very locally, but it will not remain changed for a very long time or something. So it's not going to alter your normal GI mechanisms. And approximately 1% of semaglutide is absorbed. So even now it is 1%, but remember previously it was 0.01%. So the absorption is now significantly increased. So we know that we need an ideal anti-diabetic drug. Peptides are challenging compounds, and therefore they can't be easily given through oral route. Although semaglutide is a good GLP-1 RA molecule with a long half-life, but it needs a co-formulation with SNAC. So the mechanisms of absorption is compound specific, transcellular, and without any effect on tight junctions. So this concept of peptide in a pill, or oral peptide or oral semaglutide, is not only just an advance for diabetes or for semaglutide, but it will open an entirely new chapter in the administration of peptides given orally. Thank you. Thanks for this opportunity for talking to you about a new pioneering game changer, the oral semaglutide in the management of type 2 diabetes. I have no financial disclosures. The pioneer phase or pioneer programs about the semaglutide are divided into various types. So this is a pioneer family of trials, and we'll just briefly go through it so that in future slides, when we are talking about the outcomes, it would be better to comprehend them. Pioneer 1 was a comparison of with placebo. Those patients only had diet and exercise, and they were compared with placebo versus the semaglutide. In comparison to the other oral antidiabetic, the Pioneer 2 was with SGLT2 inhibitors, Pioneer 3 with DPP4 inhibitors, Pioneer 4 with placebo or other GLP-1 RAs, that is liraglutide, Pioneer 7 with the flexible dose adjustment versus DPP4 with extension, Pioneer 8 with insulin, which also included some Indian patients, the Pioneer 9 and 10 were against the other GLP-1 RAs, that is liraglutide and dulaglutide. Pioneer 5 was in patients with renal impairment, and Pioneer 6 was for cardiovascular outcomes, which included cardiovascular outcomes, which had 201 Indian subjects also. And there is an ongoing trial of sole superiority in cardiovascular outcomes, which is ongoing, which has 788 Indian patients. So the inclusion criteria in all these pioneer trials was subjects with more than 18 years of age, those who had type 2 diabetes for more than 90 days prior to screening. They had HbA1cs in the range of either 7 to 9.5 or 7 to 10.5. And they were on stable treatment with background medication, which was allowed. The exclusion criteria has included retinopathy, multiple endocrine neoplasia, history of pancreatitis, history of major surgical procedures involving stomach, and MI, stroke, or any kind of unstable syndrome like acute coronary syndrome or TIA within 6 months prior to screening, and history of or presence of malignant neoplasms in the last 5 years. So what were the endpoints? So we will be discussing about the outcomes with various trials. So let's look at the endpoints. So Pioneer 1 to 5 and 8, which was a 26-week trial, the primary endpoint was the reduction in HbA1c. And the secondary endpoint was the change in body weight. The Pioneer 6 was an event-driven trial. That means it was time to first event. So time to first 3-point MES, and the time of first expanded composite cardiovascular endpoint was the secondary endpoint. And then we have Pioneer 7, which was a 52-week trial for looking at the HbA1c reduction in slightly different way, and that is proportion of patients achieving HbA1c of less than 7, and secondary endpoint of change in the body weight. Now, if you look at the outcomes, so first let us look at the change in the HbA1c at the end of treatment. The dark blue bars are the semaglutide in a dose of 14 milligram. The lighter blue bars are semaglutide in 7 milligram, and some of them have this 3 milligram dose, which is this grayish blue color. So if you look at the blue bars, then across the board, what we will find is that there is a very robust reduction of HbA1c from 1.5, 1.3, 1.2, 1.4, etc. But you also look at the 7 milligram outcome. And even with 7 milligram, you have a reduction of 1.3, 0.7, 0.8, etc. So the message is that you have a robust risk reduction, a robust HbA1c reduction with 14 milligram, but you also have a significant HbA1c reduction even with a half dose, that is 7 milligram. Looking at it the other way as to how many achieve the HbA1c less than 7% at the end of treatment. So you will find that these dark blue bars at 80, 72, 69, 64, 64. And the light blue bars also in the range of 70 to 50, 47. So across all these trials, 70% of patients were able to achieve an HbA1c of less than 7%. And I will add to that, that even with 7 milligram dosage, about between 50 to 70, so maybe about 60% patients were able to achieve the HbA1c of less than 7%. How robust was the HbA1c reduction in those patients where baseline HbA1c was very high, that is above 9? This is with the use of 14 milligram. So if you look at this dividing line, which is of 2, then only other thing that comes close is another GLP-1 RA. So basically it means that GLP-1 RAs are one of the most robust reducers of HbA1c in patients who have a very high baseline HbA1c. So, but except this liraglutide, you will see that no other drug is able to cross this line of 2. So the reduction with semaglutide is far more robust, and it is up to the tune of 2.6%. So in patients who have a higher baseline HbA1c, you require a very robust reduction in the HbA1c because their starting HbA1c is so high, and probably the only molecule that can achieve it is the semaglutide. The other aspect that when we were talking about the quest for an ideal anti-diabetic drug was a change in body weight. And this is especially applicable to those patients who start with a higher body weight. We know that this loss of body weight then translates into a much better control and much better long-term control and outcomes. So if you look at the change in the body weight, again, look at these blue bars. Across all the pioneer trials, you will find a weight reduction 4.1, 4.7, 5, 3.5, 4.3. So at the dose of 14 milligram, a weight reduction of about 5 kilograms is achievable using semaglutide. Again, I will add to that message that even with the lower dose, that is 7 milligram, you still have a significant weight reduction of about 2.5 kilograms, 2.7 kilograms, 2.9 kilograms. So you have a very good weight reduction with the dose of 14 milligram. But in case you have to use a lower dose, then even that will give you a fairly good amount of weight reduction. But finally, we want better clinical outcomes or better cardiovascular outcomes because the macro and microvascular complications is the major concern. So this is the Pioneer 6 trial, which included patients who were more than 50 years with either an established cardiovascular disease or age more than 60 years with at least one cardiovascular risk factor. They had a very good retention in the trial of about 99.7%, which is phenomenal. And vital status were known for all the patients. The primary outcome consisted of cardiovascular death, non-fatal MI, or non-fatal stroke to establish the cardiovascular safety. So in terms of outcomes, obviously there was a HbA1c reduction and body weight reduction, which was significantly better than placebo. The adverse event profile was like any other GLP-1 RAs, major issues being with just nausea. But this resulted in a 21% reduction in the cardiovascular outcome. So if you look at the time to first occurrence of cardiovascular death, MI, or non-fatal stroke, then compared to placebo, oral semaglutide had a hazard ratio of 0.79, which means a 21% risk reduction. This was statistically very significant in terms of non-inferiority. That means there was no doubt that this does not add to the risk, but actually it was superior but it did not reach the statistical significance of superiority, probably because of certain limitations with the trial, and probably in future we may have more robust data which may show statistical superiority. So in summary, the oral semaglutide, which has undergone this pioneer family of trials, shows that it is superior to EMPA, SITA, and liraglutide in HbA1c reduction. In terms of weight reduction, it is superior to sitagliptin, liraglutide, and empagliflozin. The cardiovascular safety point of view, it confirmed in the Pioneer 6 at least that there is a 21%, not statistically significant, but a 21% reduction in the MACE in favor of oral semaglutide. The oral semaglutide demonstrated significant greater HbA1c and weight reduction versus sitagliptin, EMPA, and liraglutide, and it was well tolerated with a good safety profile, which is consistent with the previous GLP-1 RS. The most common adverse event was mild to moderate nausea. So the efficacy was established when given either early in therapy or late in therapy, and regardless of renal or hepatic impairment. And I think this is very important because many of the other molecules, especially the other risk-reducing molecules, like say DAPA or EMPA, when patients develop renal impairment, then we have limitations of administering them. So semaglutide can be given regardless of renal or hepatic impairment. So this was the sort of overview about the program. So which are the kind of patients which are ideal patients for initiation of oral semaglutide? So patients who are taking one or more oral anti-hyperglycemic agent, including metformin, with inadequate glycemic control. So this is appropriate agent. So it can, in patients with the high ASCVD risk, it can be given as a first line of drug, but otherwise as a good second line drug after failure of metformin. So in a previously metformin treated patients, it will give you a very good glycemic control, very good robust HbA1c reduction, as we have seen. There are patients who definitely have high BMI, the high weight, and they need a weight reduction. So there is, I think, there is absolutely no doubt that this is the best drug in terms of achieving the weight reduction and a very robust weight reduction. So it would be reasonable to consider in patients who would benefit from the weight loss. Patients in whom hypoglycemia is concerned, because there is a very low risk of hypoglycemia, which is similar to the other agents. Patients who are already receiving an injectable GLP-1 RA and are not reaching glycemic target, then probably there would be an issue with compliance. So some of them are not getting controlled because the patients sometimes may be avoiding injection. And therefore, in these patients, by switching to an oral or a tablet formulation, probably the compliance would be better, and that would result in a better achievement of glycemic targets. Patients who have either established cardiovascular disease or high cardiovascular risk, we know that these high-risk patients, you have a reduction in cardiovascular risk. Patients with renal or hepatic dysfunction, no dose adjustment is required, so it can be considered. There is no age effect, that is, patient's age does not appear to affect the efficacy and safety of oral semaglutide. So in older patients where we have many times some concerns, it can be given. So there are lots of subsets where this is an ideal drug to either start in high-risk patients as maybe as a first line, as it is already put in guidelines, but also as a second line after metformin. So we know that across the global pioneer trials, oral semaglutide has proven its efficacy with a good HbA1c reduction of 1.5%, across all the pioneer trials, the oral semaglutide has shown it can produce a good weight reduction going up to 5 kilograms in a dose of 14 milligram. Patients who have very high baseline HbA1c, more than 9%, you can achieve a reduction of about 2.6%. The oral semaglutide has been found to reduce HbA1c more than either SGLT2s, DPP4 inhibitors, or other GLP-1 RA like liraglutide. The oral semaglutide also has now proven to have a cardiovascular safety and possibly a reduction in cardiovascular death and all-cause mortality. The efficacy of oral semaglutide was established when given either early in the stage of disease, late in stage of disease, and irrespective of renal or hepatic impairment. Thank you.